All right. Neuro, embryo, neural development, neural plate, notochord, neural fold, and that turns into neural tube and neural crest. Okay. So you have notochord that induces overlying ectoderm to differentiate into neuroectoderm and form neural plate. Okay. Notochord becomes nucleus pulposus of intervertebral disc in adults. Neural plate gives rise to neural tube and neural crest cells. Lateral walls of neural tube are divided into LR and basal plate. Okay. So notochord, round thing, and that turns into ectoderm. Uh, wait, no, that makes the ectoderm on top to differentiate into neuroectoderm and neuroplate. Right. The notochord itself becomes nucleus pulposus, the jelly thing in between your intervertebral discs. The neural plate gives rise to neural tube and neural crest cells, right? So that's the neural tube and neural crest cells. Okay. So neural plate comes from ectoderm, okay, and the neural plate will give rise to neural tube and neural crest cells. So anything derived from neural tube and neural crest cells, they're coming from ectoderm. Okay. Lateral walls of neural tube are divided into alar and basal plate. So let's look at that. What that means. Okay, so the lateral walls of neural tube, right? So these are the lateral walls, okay, and they're making that stuff. So this is the alar plate and this is the basal plate right there. Okay, and this is the alar lamina and this is the basal lamina of the forebrain, midbrain, and hindbrain. Okay, so that stuff is made from neural tube. So alar plate, dorsal. It's so wait. Mm, cerebellum. Okay, we'll come back to that. So alar plate, dorsal. Dorsal part is gonna make the sensory part. It induces by bone morphogenetic proteins. Okay, and basal plate is the ventral part, motor. So basal is motor, and alar is sensory. So basal motor induced by sonic hedgehog gene. Um, that was anterior posterior one. Same orientation as spinal cord. Okay. So when you're looking at spinal cord, hold on. Where'd it go? Okay, I can't find it right. Okay, right there. So the dorsal part is known as the sensory part, and this is the part that's known as the motor part, the corticospinal tract, right? So that's what they mean when they say similar to that orientation. So alar plate, which is the dorsal part, is the sensory, and basal plate, it's the ventral part, that's the motor part. Okay. Regionalization of neural tube. Uh, Telencephalon is the first part. Diencephalon is the second part. It has di in it, right? And Telin, if you remember telephones, the old ones. Right, they didn't have that thing. That's why it's called telencephalon, because it has two things like that. Like that, right there. Right, so it looks like a telephone, so telencephalon. Okay, and then you have diencephalon over here. Then it just goes alphabetically: mesencephalon, metencephalon, and myelencephalon. Okay, meten and myen are part of hindbrain. Only mesencephalon is part of the midbrain, and then you have telin and di part of the forebrain. Okay, you need to know which one's derived from what. So, okay, let's start from the top. So, cerebral hemispheres from the telencephalon and basal ganglia. Okay, the cavities it involves are lateral cavities. Okay, so it has two lateral sides, so lateral cavities. Cerebral hemisphere, so right and left hemispheres over there, and basal ganglia. Then forebrain also makes diencephalon, which makes thalamus and hypothalamus and retina. So, and the cavity it involves is third ventricle. If you remember the cavities. Okay, so these are the cavities right here. Okay, and just to reference it. So the lateral ventricles are over there, and right in the middle you have a third ventricle, so it makes sense that you have two lateral ventricles here and a third ventricle right in the center, right? And this is the thalamus, and you have hypothalamus right down here anyways, right? So that is attached to, hypothalamus down there somewhere, to third ventricle. Okay, and retina, that's an odd one. Okay, midbrain and mesencephalon. So midbrain is gonna be made by mesencephalon, or it's part of the name. Okay, so that's easy. Midbrain makes midbrain uh, from mesencephalon. And you have cerebral aqueduct. So that's this thing attaching the third ventricle to the fourth ventricle. That's the cerebral aqueduct. Okay. Then you have hindbrain, metencephalon and myelencephalon. So metencephalon makes the pons and cerebellum, and myelencephalon makes medulla. Okay. The last one, medulla. So if you remember a brainstem, right? So you have a midbrain there, pons over there, and medulla over here. So this is the last part, right? That's made by myelencephalon, and then midbrain and pons are made from, or cerebellum and pons. So that's over here. That's the cerebellum, right? So that and pons, which is that's the midbrain. So pons and cerebellum from the upper part of so up here, right, of the fourth ventricle, and then the lower part of the fourth ventricle is made by the medulla. Okay. Moving on. Central and peripheral nervous system origins. Okay, so I do have a couple of mnemonics, but we did these in musculo, so I guess it works either ways. If you want to do this or that one, doesn't matter. Neuroepithelia and neural tube. Okay, so you have CNS neurons, CNS glial cells, astrocytes, oligodendrocytes, or ependymal cells. Okay, the way I remember it is tube, which is a neural tube. It goes to a central station. So tube, like in UK, they call tube subway or train station or something like that, right? So they call it the tube. So tube goes to central station or CNS when a guard, so that's for glial cells, has a pen for ependymal cells, and leaves on go, so oligodendrocyte like an asteroid, so astrocyte. Uh, Rather than remembering the whole story, you can just remember it however you want, or you can just use this if you don't have one. Okay. Neurocrest, PNS neurons, dorsal root ganglion, autonomic ganglion, sympathetic, parasympathetic, enteric, PNS glial cells, um, Schwann cells, satellite cells, and adrenal medulla. Okay, so Neurocrest is awesome or autonomic toothpaste, so paste for PNS with some salt. So some salt is Schwann cell, odontocyte, melanocyte, enterochromaffin cells, spinal membrane, arachnoid and pia, adrenal medulla, laryngeal cartilage, and tracheal cartilage. So these ones are the most important ones you have to remember. And then there were some other ones as well, and musculo, I think. So you gotta know these ones at least. Okay, so yeah. Schwann cell, odontocyte, melanocyte, enterochromaffin cells, spinal membrane, that's arachnoid and pia, uh, adrenal medulla, laryngeal cartilage, and tracheal cartilage. For neural tube, it's CNS neurons. Okay, glial cells, ependymal cells, oligodendrocyte, and astrocytes. Okay, and then you have mesoderm. Okay, mesoderm is it makes microglia. They're like macrophages. Also, this layer is the one that's responsible for dura matter, or dura membrane. Okay. Neurotube defects. Neuropores fail to fuse for the by the fourth week of development. Persistent connection between amniotic cavity and spinal canal. So these are the neuropores. This thing right here. Okay. So if they don't fuse together, you get a persistent connection, right? Communicating pore over there between the amniotic cavity, so outside of the cavity, uh, and spinal canal. Okay. Hmm. Okay. Associated with diabetes and folate deficiency during pregnancy. Okay. Um, so if this is inside the baby, how is that attached or going into the amniotic cavity? Because wouldn't amniotic cavity be out here? So there should be an opening here, right? Okay. Yeah, so there's an opening with this one, right? So that's an open defect. Okay. That looks like a hygroma. Okay. So again, neuropores fail to fuse by the fourth week of development. Persistent connections between amniotic cavity and spinal canal. It's associated with diabetes and folate deficiency during pregnancy. There's increase in alpha fetoprotein in amniotic fluid and serum. Okay, except for spina bifida occulta. Uh, in that you get a normal AFP level, alpha fetoprotein. Okay, so there's spina bifida. Here you don't get a opening of the skin, so that's why none of this fluid is gonna go outwards, and you won't find that. So it's normal in that. Okay, uh, increase in acetylcholinesterase. Uh, that that's an ACE, so that cleaves acetylcholine in amniotic fluid is a helpful confirmatory test. Okay, so that's how you confirm it. Spina bifida occulta, that's failure of caudal neuropore to close, but no herniation. Okay, so it doesn't close, but this thing is not herniating outwards. Okay, that's all. Before I do that, so that's the dura mater. This is the leptomeninges. This is the spinal cord. This is the transverse process, and this is the skin, and that's a normal presentation. So in spina bifida occulta, you don't have the fusion of these two processes. Okay, so failure of caudal neuropore to close, but no herniation, usually seen at lower vertebral levels. Okay, so your lumbar region, I guess. Dura is intact. That's important. It's associated with tuft of hair, or skin dimple at level of bony defect. Okay, so tuft of hair and skin dimple is a giveaway. That is spina bifida occulta. Okay. Meningoceles, that's meninges go through the seal. That's how I remember that. So meningocele is the meninges goes through the seal. Meninges but no neural tissue herniate through bony defect. Okay, so that's the dura going outwards and leptomeninges, right? But spinal cord is still inside. So spinal cord is the neural tissue, so that don't herniate through. Okay, then myelomeningocele, that's myelin, which is neural tissue, and meningo or meninges through the seal. Okay, so myelin and meninges go through the seal. So meninges and neural tissue, for example, quota equina, herniate through bony defect. Okay, so that's meningocele, that's myelo and meningocele. So myelin or spinal cord and meningo going through that. Then you have myeloschisis, also called rachiosis. It's exposed, unfused neural tissue without skin meningeal covering. So this might not work for you, but this thing, it reminds me of a character from Watchmen, the comic. Right, so that's him, Rorschach, and he has a face that keeps moving, kind of thing. So it's unfused, and it's on the skin, right? So that's how I remember that one. So also called rachiosis. It's exposed, unfused neural tissue without skin or meningeal covering. Okay. That's myeloschisis. And anencephaly, that's failure of rostral neuropores to close, so no forebrain, open calvarium. Okay, that's an easy one to remember. Clinical finding is polyhydramnios, no swallowing center in the brain. Okay, like that. Okay. Okay, and done with that. So skin is thin or absent over here, skin defect and thinning, and subarachnoid space over here. Moving on. Brain malformations, often incompatible with postnatal life. Survivors may be profoundly disabled. Okay. Holoprosencephaly. Remember, this was with SHH mutation. So sonic hedgehog mutation. So that would cause holoprosencephaly. Right. Yeah. Let me just do a recall to that. So yeah, over here. Not Musk. It was Repro. I was mistaken. So Sonic Hedgehog. It's anterior to posterior, and mutation causes holoprosencephaly. Okay. Um, so holoprosencephaly, it's a failure of forebrain prosencephalon to divide into two cerebral hemispheres. Development of field defect, usually occurring at week 3 to 4 of development. It's associated with SHH mutations, may be seen in Patau syndrome, that's trisomy 13. Uh, and that's the one where you have the scalp open scalp, known as cutis something, aplasia, I think. Yeah, cutis aplasia. So um, that happens in Patau. Okay. Uh, why are they showing? Oh, okay. So that's Edwards. They're showing Edwards over there. This is Patau. Okay. Uh, and fetal alcohol syndrome will do this as well. Okay. Holoprosencephaly. Uh, Presentation with midline defects, so monoventricle, fused basal ganglia. Okay, so there's a fusion of basal ganglia over there. Because if you remember a normal scan somewhere, um, you have a whole line coming through this, right? Separating the two hemispheres, and one basal ganglia will be in left, and the other one will be on the right, but it's fused together, just like these ventricles. Okay, so that's, you should be able to identify this from the scan itself. Okay, it presents with midline defects like monoventricle, fused basal ganglia, cleft lip palate, hypotelorism, so that is abnormally decreased distance between two body parts, as usually the eyes. Okay, cyclopia, that's single. So it's the most extreme form of holoprosencephaly and is congenital disorder characterized by failure of embryonic prosencephalon to properly divide the orbits of the eye into two cavities. So they're all fused together, so like a cyclope, right? So that's where it comes from. Mm-hmm. So, like that. Okay. And proboscis. This is the nose of a mammal, usually, especially when it is long and mobile, like the monkeys, right? Proboscis monkeys. Like that. Okay. Increased risk for pituitary dysfunction, for example, diabetes insipidus. Okay. Important thing to know about this, you gotta know about the gene and what it's associated with, or where you would see it, basically. Okay. Lysencephaly. This is failure of neuron migration. Okay. So you'll get a smooth brain surface that lacks sulci and gyri. Uh, okay, so you don't see any gyruses over here or sulcuses, right? Normally it's like a little noodle, but here it's all smooth, right? So smooth brain surface that lacks sulci and gyri. It's associated with microcephaly, uh, facial anomalies, and hydrocephalus. So less like a normal brain, less encephaly, or less sulci and gyri. So normally you would see something like that, but a lot more of it. Right? So this is like a normal. Wait, no, this is also smoothed out. Okay, so this is what it looks like, a normal one, right? You have a lot of little sulcuses over here and gyruses, but here you don't see any of that. Okay, and you should be able to identify it from the scan as well. Posterior fossa malformations, carry 1 malformation and carry 2 malformation. So carry malformation 1 is ectopia of cerebral tonsillar. Oh, sorry. So we're doing posterior fossa malformations. Okay. So posterior fossa, it's posterior part of the brain. So something wrong over there. So carry 1 malformation, ectopia of cerebellar tonsils, inferior to foramen magnum. So one structure for carry 1. So it's just cerebral tonsils. So these things. Okay. So those things right there, tonsils. Okay. This is the vermis. This is the tonsil. Okay. This is the horizontal fissure part and flocculus over here and cerebellar hemisphere. Okay. So these are part of the cerebellum. On the side is the vermis. Okay. Fourth ventricle over there. This is the medulla. So on top of it is that. Medulla goes through the foramen magnum. Okay. In this. Okay, so ectopia of cerebellar tonsil inferior to the foramen magnum. Okay, so it goes below the foramen magnum. Usually asymptomatic in childhood, manifests in adulthood with headaches and cerebellar symptoms. It's associated with spinal cavitations, for example, syringomyelia. Okay, so if they're going to question you about this, and they're going to give you symptoms for this, and they'll ask you what's wrong, and then you explain this to them in the answers, right? So syringomyelia, we'll read it over here, but overall, it's just loss of sensation in this area, and it's called a cape-like formation. In the cape-like area of the body, there's loss of sensation. So it could be symmetrical loss of pain or temperature sensations. Okay, so if you find that in the question stem, they tell you something about that, they're hinting towards this. Syringomyelia, and it happens because of carry 1 malformation. So what happens there is this syringe-like thing, a cyst is formed. Okay, over here, in the middle area, right, and it pushes downwards. So when it does that, it pushes in this area where there's connection between the two tracks going through it. So it basically compresses it. So when you compress that area, the central canal, it does that. So because of this cyst, it's pulling everything outwards. So when it does that, it pulls this stuff above downwards as well, right? And that is going to create carry 1 malformation. We'll look at it again. Carry 2 formation malformation is herniation of cerebellum, vermis and tonsils, and medulla. So 2 structures now through foramen magnum. This leads to non-communicating hydrocephalus. It's more severe than carry 1. Usually presents early in life with dysphagia, stridor, apnea, and limb weakness. Okay. Yeah, we'll do this in hydrocephalus, but basically non-communicating is when the ventricles are not communicating with each other. Okay, so the fourth one's not communicating with the third one, or third one's not communicating with the lateral one. Okay, so that would be a non-communicating hydrocephalus. More severe than carry 1, usually presents early in life with, gotta know these, so dysphagia, stridor, apnea, and limb weakness. Okay. Although this is very vague, so I don't think they'll expect you to carry two malformation just from these. It's associated with myelomeningocele. Okay, it's usually lumbosacral. Okay, myelo meaning the spinal cord, meningos with the leptomeninges going out of the seal, so going through the pores. Okay, Dandy Walker malformation. Okay, wait. So let's go look at these. Okay. So that's the medulla, that's the cerebellum. This is the foramen magnum. Okay. So medulla is going through it, foramen magnum right over there, and so is this. So that's basically what that is. Okay. Now Dandy Walker malformation. Walker, that tells you, uh, doesn't tell you anything, but just walking. Cerebellum is responsible for walking, right, or balance, coordination of the balance and all that stuff, right? So it tells you that it's something to do with cerebellum. Okay, so dandy is just walking weird. That's how I remember it. So he's a dandy walker. So agenesis of cerebellar vermis. Okay, that's the middle part that we looked at. It's there's a cystic enlargement of fourth ventricle, arrow in A. Okay, so this was the vermis, so cystic enlargement of that fills the enlarged posterior fossa associated with non-communicating hydrocephalus and spina bifida. Okay, so Dandy Walker is agenesis of cerebellar vermis. Okay, Syringomyelia. Okay, 525. Let me go look at that. Okay, this thing. Okay. I think I have a photo there anyway, so it's fine. So it's this thing. Okay. So normally what you have is a central canal here. Okay. This is the posterior horn, the anterior horn. Okay. This is the gray matter. This is the white matter. This is the spinothalamic, dorsal, lateral, anterior and lateral, and this is the corticospinal tract. Okay, so there's a connection between this side and this side, and that's how things get transferred. So from spinal it's going to go into the nuclei, and then from nucleus it's going to go to the corticospinal on this side, and similarly from here it's going to go to this side. Okay, so that happens through here. Okay, so if this central canal gets expanded because of some cyst or something, cystic fluid or space or tumor, whatever, it's gonna push down this way. Okay, why this way? Because this is much thicker over here, so there will be increased resistance on that side, so it's easier to push this way downwards. Okay, so it's gonna do that. So that's what's gonna happen here. So syringomyelia, it's a cystic cavity or syrinx, or syringe. You can think of it like a syringe. Within central canal of spinal cord. Okay, yellow arrows in A, so that. Fibers crossing an anterior white commissure, spinothalamic tract, are typically damaged first. Okay, so that's the sensory part, spinothalamic tract. Okay, so that's responsible for pain, temperature, crude touch, and pressure. Okay. Spinothalamic are typically damaged first. So results in cape-like bilateral symmetrical loss of pain and temperature sensation in the upper extremities. Okay, over there. Fine touch is preserved. Why? Because fine touch is part of the dorsal column. So fine touch is part of that. So it's going to be preserved. Okay. Uh, Associated with Chiari-1 malformation, red arrow in A, so you can see cerebellum coming down through the foramen magnum. Okay. It shows low-lying cerebellar tonsil, scoliosis, and other congenital malformations. Acquired causes include trauma and tumors. Most common location is cervical, then thoracic, and very rarely lumbar. Okay, so it happens usually on the top sides. So syrinx equals tube, as in syringe. Okay, your dorsal ganglia coming in from the nucleus or nuclei of the thing. Okay, this is expanding syrinx. It can affect multiple dermatomes. You have to be able to pick it up from a question stem that they're talking about this. So they're going to be like, okay, so um, this patient is not able to feel pain and temperature sensations, or you know, has a multiple burn marks on arm, and that still tells you that this person is not able to feel pain, so that's why they are burning their hands or something. So multiple burn marks on hands and on hands bilaterally, so that tells you it's something to do upper motor neuron, not the lower motor, right? And yeah, so like that. Gotta be able to figure it out. That's it. And once you figure it out, it's pretty easy. Once you know it's a cape-like bilateral symmetrical loss of pain and temperature for this. Okay. Tongue development. That's what this thing is for. So we'll do that when we get there. Tongue development. First pharyngeal arch forms anterior 2/3 of the tongue. Sensation via cranial nerve 5. That's the trigeminal nerve. Third branch is the mandibular nerve. Mandibular branch of the trigeminal nerve. Right. There are 3 branches to trigeminal: ophthalmic, maxillary, and mandibular. Okay. So the mandibular branch is responsible for sensation over there. So these are the sensation sides. Okay. So anterior 2/3, that's mandibular branch of the trigeminal nerve, and the taste is via seventh nerve, the facial nerve. Okay, so taste via the seventh nerve for anterior 2/3 of the tongue. Third and fourth pharyngeal arches. Okay, so they make the posterior 1/3 of the tongue. Okay. Second arch doesn't make anything. Oh, it does actually. It makes the stapedius and stapes and all that stuff, right? Right. The smile muscles are from second, if I remember. Let me just do a quick recall to that, so we don't mess it up. Nope. Right here. Okay. So second pharyngeal, yeah, the smile muscles. So stapedius, stylohyoid, platysma. Okay, it's the fifth one that doesn't make anything, right? Okay, saves in this. Cool. Okay. Third and fourth pharyngeal arch form posterior 1/3 of the tongue. Sensation taste mainly via the glossopharyngeal or the ninth nerve. Extreme posterior via 10th nerve, the vagus nerve. Okay. So if this is the extreme posterior, sensation and taste are both by 10th nerve, but the posterior 1/3 is sensation is by the glossopharyngeal nerve, and the taste is by glossopharyngeal as well. Okay, I misread that. Sensation taste mainly via glossopharyngeal. Okay, so it's easier to remember it now, right? So sensation via mandibular branch of the trigeminal, Taste is through the facial nerve, and on the back it's both by glossopharyngeal and posterior, extreme posterior back, it's going to be vagus nerve. Okay, so motor intervention, okay, is via the 12th nerve, right? So that's hypoglossal nerve to hyoglossus, so it retracts. So here we should look at where that is. Okay, so that's hyoglossus. Okay, it's on below the tongue over there. It attaches to I guess whatever looks like the hyoid bone. Okay, so it's in the name, hyo, so that's hyoid bone, and glossus, that's the tongue. So connection between the hyoid and the glossus, so the tongue, right? So motor intervention is via hypoglossal, so that's below the tongue nerve, to hyoglossus, so it retracts and depresses the tongue, so it will bring it back and it will depress it. Genioglossus, so that protrudes the tongue. Okay, so genie comes out of the tongue, so genioglossus is over here. Okay, it's attached to the mandible, right? So it's gonna pull the tongue outwards, right? So it protrudes the tongue. And styloglossus, so it draws the sides of the tongue. So this is the styloglossus, so that's stylo to stylohyoid, and glossus the tongue, so it pulls the tongue to the styloid side, right? So side to side. Cytoglossus draws side of the tongue upwards to create a trough for swallowing. And then you have motor intervention, which is via 10th nerve, the cranial nerve, vagus nerve, to palatoglossus. So that's palate and the tongue. So it elevates. Okay, do we have palatoglossus here? No, we don't. Let's look at palatoglossus. Okay, so palatoglossus goes from the side, from under the tongue to the palate, like that. Okay. So motor intervention is through 10th nerve, the vagus nerve to palatoglossus, and that's the only different one, right? All the other ones are supplied by the 12th nerve. So palate is different. It elevates posterior tongue during swallowing. Okay, so 10th nerve intervenes palate tendinoglossus. Okay, and genie comes out of that. So taste is through the side, right? So 7th nerve, the 9th nerve, and the 10th nerve. Okay, and they go to solitary nucleus. You have the pain or the sensation nerve. That's the mandibular branch of the trigeminal nerve. The 9th and the 10th as well, right? And then the motor you have is 12 and 10 to palatoglossus, and 12 to hyoglossus, genioglossus, and styloglossus. Okay, on to physio. Let's take a break here. Neuro. And then physio, neurons. Single transmitting cells of the nervous system, permanent cells, they do not divide in adulthood. Signal relaying cells with dendrites receive input, cell bodies and axons send output. So dendrites, they receive the body, this input or the signal, and axons are the one that sends out the thing. So okay, so this is the axon, this is dendrites, that's the cell body. Cell bodies and dendrites can be seen on nasal staining because it stains the RER. Okay, and RER is not present in the axon. Okay, column. Okay. That's not gonna help. I guess they'll show us later. Astrocytes. Okay, so the types of neurons. Astrocytes, most common glial cell type in CNS. Um, Physical support, repair, removal of excess neurotransmitters, component of blood-brain barrier, glycogen fuel reserve buffer. Reactive gliosis is in response to neural injury. Is derived from neuroectoderm, and astrocyte marker is GFAP or glial fibrillary acidic protein. Okay, so if you have that, it tells you that it's from CNS or derived from neuroectoderm. Okay. Microglia. These are phagocytic scavenger cells of CNS like macrophages. Okay. Uh, Activation in response to tissue damage and release of inflammatory mediators, for example, nitric oxide and glutamate, not readily discernible by nasal stain. Derived from mesoderm, HIV-infected microglia fuse to form multinucleated giant cells in CNS and HIV-associated dementia. Ependymal cells, ciliated, simple columnar glial cells lining ventricles and central canal of spinal cord. Apical surfaces are covered with cilia, which circulate CSF and microvilli, which help with CSF absorption. Derived from neuroectoderm, specialized ependymal cells, choroid plexus, and produce CSF. Okay. This is important because uh, it could be responsible for, or you'll come across something about a question about this in hydrocephalus. Okay. So once more, ciliated simple columnar glial cells lining ventricles and central canal of spinal cord. Apical surfaces are covered with cilia, which circulate CSF, and microvilli, which help with CSF absorption. Okay, so microvilli is the one responsible for CSF absorption. It's derived from neuroectoderm, uh, specialized ependymal cells, choroid plexus, and produces CSF. Right, it goes with this thing. Tube goes to central station with guard, so glial has a pen, ependymal, and oligodendrocyte and astrocytes. Okay. So specialized ependymal cells, choroid plexus produces CSF. So CSF comes from specialized ependymal cells. Myelin, increase in conduction velocity of signals transmitted down axons. Okay. It's called saltatory conduction of action potential at the nodes of Renvier, where there are high concentrations of sodium channels. In CNS, including cranial nerve 2, myelin is synthesized by oligodendrocytes in PNS, including cranial nerve 3 and 12. Myelin is synthesized by Schwann cells. Okay, that's important. What else is important? It's synthesized by oligodendrocyte in CNS, and in PNS, it's synthesized by Schwann cells. This is important. What that's basically the function of it, right? So increase in conduction velocity of signals transmitted down axons. Saltatory conduction of action potential at the nodes of Renvier, where there are high concentration of sodium channels. So sodium, that's what it's called saltatory conduction. Okay, so myelin, that thing, it wraps and insulates axons, so it decreases membrane capacitance and increases membrane resistance. Okay, so ions can't leak out because of that. Increase in space length constant and decrease in time constant, right? So it decreases the amount of time it takes to travel through it, the myelin, as opposed to when you don't have myelin on it, and increase in space length constant, so it can cover more distance than it could without it. Right? So decreased membrane capacitance is decrease in the membrane thickness. This is to concentrate the ions on the node of Renvier. Myelin increases resistance and prevents movement ions across the insulated area, thus promoting the movement of ions across the exon. So lower the time constant, faster the response. Length constant is a graded action potential in absence of anything that helps to regenerate the potential. Okay, so once the action potential is being made, how far can it continue without, you know, getting help from some other source to add on to the action potential? So that's the length constant, a graded action potential in absence of anything that helps to regenerate the potential will decay as it moves further from its origin by losing ions across the membrane, which is why myelin also increases membrane resistance. The decay results in decrease in the amplitude of the action potential, and this is described as the length constant. So we can conclude that length constant will be higher, which means longer action potential, in large myelinated axons than it would be in thin or even unmyelinated axons. Okay. So you gotta understand what these terms mean. The space constant, time constant, membrane capacitance, and stuff like that. Okay. Schwann cell. So we just learned about Schwann cell being made in the being in the penis, right? And up there as well. Where was it? Okay, so penis glial cells were Schwann cells and satellite cells. Okay. Okay, Schwann cells. So nucleus and Schwann cell, myelin sheath, and node of Renvier. It promotes axonal regeneration. Okay, that's important, and it's derived from neurocrest. Okay, so for neurocrest, it was these. Neurocrest is an awesome autonomic toothpaste for penis and with some salt. So salt is Schwann cell, odontocyte, melanocyte, enterochromaffin cells, spinal membrane, adrenomedulla, laryngeal cartilage, and tracheal cartilage. Each Schwann cell myelinates only one penis axon. It's injured in Guillain-Barré syndrome, and Schwann cell marker is S100. Okay. So you'll see these markers in Guillain-Barré syndrome. Uh, oligodendrocytes. So again, nodes of Renvier over there, and oligodendrocytes. Okay. So myelinate axons of neurons in CNS. Each oligodendrocyte can myelinate many axons, approximately 30. Predominant type of glial cells in white matter. It's derived from neuroectoderm, a fried egg appearance histologically. It's injured in multiple sclerosis, progressive multifocal leukoencephalopathy, leukodystrophies. Let's check out a scan for these. It's caused by JC virus. We learned about that in micro. And it causes multiple lesions in the brain, right? Like that. Okay. There's no pattern to it. Like, it doesn't just stick to the border lining of the ventricles or anything. It can be anywhere. And there are multiple ones. Okay. Alright. Okay, so you should be able to identify this just from the scan itself, because you don't have to know a lot of scans for brain. You need to know it for neurocysticercosis, for toxoplasmosis, and for this, and maybe for EBV or CMV. Okay, so tube again, neurotube goes to central station where a guard has a pen and leaves on go like an asteroid. Okay. Neuron action potential. Okay. Okay. So first step, what happens is resting membrane potential. Membrane is more permeable to potassium than sodium at rest. Okay, so this is sodium, uh, can go through. Potassium can't go through the voltage gated channels. However, it is permeable for potassium, so it's gonna keep, passing through the membrane at rest. So voltage gated sodium and potassium channels are closed. Okay, so you have potassium going out, right? Because it goes outwards. Membrane depolarization. So sodium activation gates opens. Okay, so when that opens, sodium flows inwards. Okay, so this is inactivation gate. Cellular activation gate is this. So when this attaches to that, it gets activated. Okay. So now, oh, never mind. It just activates by itself. Okay. So sodium's coming in, and this one is still closed, so potassium can go out. It can go out by normal permeability, like passively, but not actively. Okay. Membrane repolarization. Uh, its sodium inactivation gate closes at peak potential. Okay, so here we had a rise of influx of sodium. So that tells you what? It tells you that the polarity of it is gonna go into positive, right? So first the membrane potential was at negative, and then when you add sodium positive to it, it's gonna go towards the positive side, right? So it goes positive, and right at the peak, it's gonna close. So sodium channels in activation gate closes at peak potential, thus stopping sodium inflow. The potassium activation gates open, so potassium then flows outwards. Okay, so after it peaks the potential, uh, the potassium channels open up, so now they're gonna go out. So more positive ions are gonna now leak out, so that's gonna make it more negative, right? That's what that is. Okay, and so potassium flows outwards, and then membrane hyperpolarization. So it takes time for potassium gates to close, right? And that leads to this. So potassium activation gates are closed, slow to close. So excess potassium efflux and brief period of hyperpolarization. Voltage gated sodium channels switch back to resting state. So sodium potassium pump restores ion concentration that way. Okay, so it gets back to this through sodium potassium ion pump. Okay, that was the action potential. Notice how there's no calcium anywhere, right? So this action potential does not require any calcium. There's no plateau or nothing. Okay. Sensory receptors. So receptor type, uh, sensory neuron fiber type, location and senses. Free nerve endings. You have A delta, so fast myelinated fibers, and C is slow. Okay, so unmyelinated. A delta plane is fast, and but text C is slow. Okay. Location. They're found in all tissues except for cartilage and islands. Numerous in skin though. The senses they carry are pain and temperature. Okay, so sensory receptors, that's what we're doing. So there are multiple types of sensory receptors. One type is free nerve endings, and there are two types of free nerve ending fibers, um, A delta and C, right? And they carry pain and temperature. Then you have Meissner corpuscle, right? So the way you remember that is Ms. Her vibe and her fine touch. So Mesner corpuscle. From that you should remember Ms. Her vibe and her fine touch, cause that's what it senses. It's known for dynamic fine light touch, uh, and vibrations, so low frequency vibrations and skin indentation. Okay, it's large myelinated fiber and it adapts quickly. Okay, so what does it mean by adapts quickly? So that's adaptation is the decline of electric response of a receptor neuron over time in spite of continued presence. uh, Again, adaptation is the decline of electric response of a receptor neuron over time in spite of the continued presence of an appropriated stimulus or constant uh, strength. Okay, so let's go look at this. Okay, so that's the clever skin, I guess. Okay, and if you constantly press on it, right, eventually you're gonna stop feeling the pressure, and that's what it means. Okay. Okay. The hairless skin. Uh, okay. So it's large myelinated fibers, and they adapt quickly. So soon enough, they will stop feeling the fine touch or the vibrations if you continue giving the stimuli. Okay, it's found in glabrous or hairless skin. The senses are dynamic, fine light touch, low frequency vibration, and skin indentation. So Misner corpuscle, you miss her vibe and her fine touch. Pecinian corpuscle or Pecinian, but I pronounce it Pecinian. Okay, so packet in deep pressure or Pacific Ocean has high tide. Okay, so it's a large myelinated fiber. It adapts quickly as well, similar to that one. But here, these ones are found in deep skin layer, hence the packet in deep pressure. Okay, so deep for deep pressure, deep, right? Ligaments and joints. Okay. High frequency vibrations. That's what the high tide is about. High tide for high frequency uh, vibrations. And then pressure. So deep pressure. Uh, that's how I remember that. Then you have Merkel, right? Like Merkel works under pressure and superficial people at her fingertips. So Merkel is a councilwoman in Germany, right? Former Chancellor of Germany, right? If you remember her from the news. So Merkel works under pressure, right? She has a lot of pressure, and she has a lot of superficial people at her fingertips. So large myelinated fibers adapt slowly as well. Uh, so it's located in the fingertips and superficial skin, and senses of pressure, deep static touch. For example, sharp edge, sharp, sorry, shapes and edges. So discs on fingertips, if that helps. Okay. And Ruffini corpuscle. So Ruffini guitar string stretches under fingertips at different joints. So Ruffini is a company that makes guitars. Okay. Uh, so I remember that way. Right, the strings, they help you remember this because they stretch and joint angle changes. You would change these angles right here, not there, like on the other side or over there. Right. So that helps with that. Sensory neuron fiber types, they're large myelinated fibers intertwined among collagen fiber bundles. These one adapt slowly as well, just like this one, Merkel discs. Okay. They're also found in fingertips and joints. So since at fingertips, you don't want to, lose the stimuli or sensation due to constant stimuli. So they adapt slowly. Okay. And senses a stretch and joint angle changes. So Ruffini guitar guitar string stretch under fingertips at different joint angles. Okay. So free nerve endings, you have A delta and C. Pain, temperature, it's on all cartilages and numerous in skin. Meissner corpuscle or Misner corpuscle, miss her vibe and her fine touch for the senses that are found in that and she likes your hairless skin, so glabrous skin. Okay, these adapt quickly and they're large myelinated. All of them are large myelinated anyways, except for the C one. Right? And since it's not myelinated, it's a slow one. Okay, then Pacinian or Pacinian corpuscle. So Pacinian deep pressure or Pacific Ocean has high tide for high frequency vibration and pressure. Large myelinated, adapts quickly, and it's found in deep skin layer, ligament, and joints. Merkel disc. Okay, Merkel works under pressure, has superficial uh, people at her fingertips, right? So fingertips and superficial skin, and works under pressure. And for discs, if you remember the disc, you would play it with by putting in a finger and then spinning the disc. So uh, sharp shapes and edges, all that stuff. Okay, discs on fingertips. Uh, Ruffini corpuscle, Ruffini guitar strings stretch under fingertips at different joint angles, or you can, you fix the joint to fix the strings. Uh, they're all large and myelinated, but right, so Merkel it adapts slowly as well, because government doesn't work that fast anywhere. So Ruffini corpuscle also adapts slowly. Okay, location fingertips, joint stretch, joint angle change. Okay. Let me fix that. Peripheral nerve. Okay, so you have a nerve trunk. Okay, you have epineurium, perineurium, endoneurium, and nerve fibers. So nerve fibers are surrounded by a sheath, and that's known as endoneurium. Around multiple endoneurium is also a sheath that's called perineurium. Okay, and around all the perineuriums, you have a sheath that's called epineurium, and then all of this together makes a nerve trunk. Okay, so endoneurium, they're thin, supportive connective tissues that ensheaths and supports individual myelinated nerve fibers, may be affected in Guillain-Barré syndrome. There's perineum, blood nerve permeability barrier. It surrounds a vesicle of nerve fibers. Okay. Uh, then you have epineurium, that's the outermost. Dense connective tissue that surrounds entire nerve, vesicles, and blood vessels. So you have endo, which is inner, peri around, and epi outer. Okay. So notice how you can see a cell body, but you don't see an axon. It's because the axons don't have RERs, right? Only the nasal body and the dendrites have RERs. So that will get stained, but it doesn't stain the axon, or you can't see the axon because there's no stain there. So it's reaction of chromatolysis. What is that? Body in the cell body, and okay. So it's a reaction of neural cell body to axonal injury. Changes reflect increased protein synthesis in an effort to repair the damaged axon. It's characterized by round cellular swelling, displacement of nucleus to the periphery, and dispersion of Nissl substance throughout the cytoplasm. Okay, so this is chromatolysis. You have round cellular swelling. Okay, and everything is coming in, and there's like a swelling is because of the fluid or whatever, and that's going to push the nucleus to the periphery, right? So this nucleus gets pushed out of from the center to the periphery, right? And there's dispersion of Nissl substance over here because that's where RER is, okay, throughout the cytoplasm. So if you see these three things, or they talk about these three things, they're talking about chromatolysis. Okay. So what happens? How does it fix that? It happens during a damaged axon, and then this is in an effort to, retain as much as it can or repair it. So there's, if it can repair, there's Wallerian degeneration. Okay, that's disintegration of the axon and myelin sheath distal to the site of axonal injury with macrophages removing debris. So that's axon retraction. So this is where the damage is. So all of this will get retracted into the cell body, and then it's going to make another connection somewhere else with this. Maybe this will project outwards and attach to a different axon. Or, yeah. Okay, so disintegration of the axon and myelin sheath distal to the site of the axon injury with macrophages removing the debris. So this is the distal site. Macrophages for CNS is called microglia, right? So that it's going to start eating it up. This is called Wallerian degeneration. Proximal to the injury, the axons retract and the cell body sprout new protrusions that grow towards other neurons for potential re-interventions. It serves as a preparation for axonal regeneration and functional recovery. Okay, so it's just a way to save whatever it can. Okay, neurotransmitters changes with disease. Okay, location of synthesis, anxiety, depression, schizophrenia, Alzheimer's disease, Huntington's disease, Parkinson's disease. Okay, acetylcholine. Okay, it's located in basal nuclei of Maynard or forebrain. Okay, it decreases in Alzheimer's disease. Okay, so A for Alzheimer's and acetylcholine. And it decreases in Huntington and increases in Parkinson's disease. This is just a mnemonic to remember location of this and this thing as well. So, oh my nerd. So you'll see this in the option, right? That's how I use these. If you see it in the option and they're asking which one makes acetylcholine, then remember minor as oh my nerd. I have a frontal headache, right? So ache is for ACH. Okay, frontal for forebrain, that's where it is. Okay, and connected to Alzheimer, Huntington, and Parkinson's disease somehow. Okay, uh, dopamine. It was dope when we pitched a tent at Niagara Falls. Okay, so that's ventral tegmentum. It's made in ventral tegmentum, and it's found in substantia nigra or subthalamic nucleus, I think, right? Where's that? Substantia nigra, right? Okay. Uh, so dopamine, that's the happy one. So in depression, you don't have that much dopamine. It also causes hallucinations, right? In schizophrenia, it increases. In Huntington, it's excitatory as well, right? And it's inhibitory as well. So when it's excitatory, you have increase in excitatory one in Huntington disease, and the inhibitory one in Parkinson's disease will decrease. Okay, so that's why you have all those, tremors and stuff. You have hemibolism in this one. GABA. So grab a cucumber in the background. Okay. So GABA is grab a cucumber in the background. So GABA. So why cucumber? Because it's made in nucleus accumbens, which is part of basal ganglia. So a cucumber, a cucumber, right? In the background, BG for basal ganglia. Or you can just remember grab a cucumber because GABA is made in accumbens. Okay. This is the inhibitory one, right? So what happens in anxiety? You don't have inhibitions. So you get, you get the panic attacks and all that stuff. So it's because you have decrease GABA. As also in Huntington, you have increase in excitatory ones, but you have decrease in the inhibitory ones. So that leads to the hemibolism as well. Okay, so yeah, GABA, it's decreased in Huntington and anxiety. Okay, norepinephrine or new look, NE for norepinephrine, and look for locus coeruleus. Okay, so new look or new blue uniform for pune, right? I don't like that one. Let's get rid of that one. You'll remember this one. New look. So locus coeruleus. Coeruleus just means blue, right? Let me make sure. Okay. It means blue in, like, I don't know, old language. Anxiety. It will increase, right? This increases everything, like your fight or flight response and all that stuff, I think. Or norepinephrine. It's EpiPen you give and all that stuff. So in anxiety, you have increase in norepinephrine. In depression, it's decreased. Okay. And then serotonin, or Sir raps about bullshit. Okay. So bullshit is BS, right? So BS is for brainstem, raps is for Raffi nuclei, and Sir raps, or Sir is like the rapper, or serotonin. Okay, so serotonin. That. That's the uh, hormone. Anyways, it decreases in anxiety, uh, in depression as well. It increases in schizophrenia, right? And that's what we give SSRIs, selective serotonin receptor inhibitors, in schizophrenia, and it's decreased in Parkinson's disease, okay, as well. Okay, so oh my nerd, I have a frontal ache for ACH. So that basal nucleus Maynard, it's AA, so acetylcholine decreases in Alzheimer's, and that's basically what Alzheimer's is about, right? Huntington decreases acetylcholine, and Parkinson's. So let's do it this way actually. So let's start from anxiety. So anxiety will have decrease in GABA, increase in norepinephrine, and decrease in serotonin, right? In depression, you have decrease in dopamine, decrease in NE, and decrease in serotonin. Okay, in schizophrenia, you have increase in dopamine and serotonin. I added that, by the way. Uh, Alzheimer's disease, you have decrease in acetylcholine. That's it. No other thing is involved in Alzheimer's. It's just the acetylcholine. Huntington's disease, you have decrease in acetylcholine and GABA, and increase in dopamine. That's a neurotransmitter, excitatory neurotransmitter as well. And in Parkinson's disease, you have increase in acetylcholine, but decrease in dopamine, the inhibitory one, and decrease in serotonin as well. Okay. Meninges. So you have three membranes that surround and protect the brain and spinal cord. Dura mater is a thick outer layer closest to the skull, derived from mesoderm. Arachnoid matter, that's middle layer, right? Arachnoid is from like spider-like, right? That's what it means, and it's called that because it has all these veins and all that stuff in it. Okay, the bridging veins, and that's why it's called arachnoid matter. So middle layer contains web-like connections derived from neural crest. Okay, so dura mater, we read about it. It's derived from mesoderm, and then neural crest is the one that makes arachnoid and the pia mater, right? Because of the neural crest has some salt, and some salt L was for leptomeninges that makes these. So pia mater is thin, fibrous inner layer that firmly adheres to brain and spinal cord, derived from neural crest. Okay, so CSF flows in the subarachnoid space. So subarachnoid, that's below the arachnoid and above the pia mater, located between arachnoid and pia mater. Okay. Epidural space, potential space between dura mater and skull vertebral column, containing fat and blood vessels. Okay, so that's above the dura and below the skull. So potential space between the dura mater and skull vertebral column, containing fat and blood vessels. Site of blood collection associated with middle meningeal artery injury. This is important. That comes in patho. So if you have blood collection between this layer, it's because of injury in the middle meningeal artery. Okay. Blood-brain barrier. So you have astrocyte foot processes over here. This is the capillary lumen. This is the basement membrane, and tight junction in between them. Okay. So blood-brain barrier, it prevents circulating blood substances, for example bacteria and drugs, from reaching the CSF and CNS. It's formed by four structures. These are your tight junctions between non-fenestrated capillary endothelial cells. Okay, that means no holes, right? Basement membrane, pericytes, and astrocyte foot processes. Okay. Glucose and amino acids cross slowly by carrier-mediated transport mechanism. Non-polar lipid-soluble substances cross rapidly via diffusion. Okay. So if it's lipid-soluble or non-polar, rapidly across through diffusion, whereas anything big like amino acids and glucose, it's gonna be needed to carried out or carried in with transporter. Circumventricular organs with fenestrated capillaries and no blood-brain barrier allow molecules in blood to affect brain function. Okay. Let me read that again. Circumventricular organs with fenestrated capillary with no blood-brain barrier allow molecules in blood to affect brain function. For example, area prostrema. So this is called the vomiting center, right? And vomiting occurs after chemotherapy. There's also OVLT or organum vasculosum lamina terminalis. These are your osmoreceptors over there. Or neuro secretory products to enter circulation. For example, neurohypophyses or ADH release. Okay, so all of these don't have the blood-brain barrier, so they're exposed to all this stuff. Blood-brain barrier disruption, for example, stroke. It leads to vasogenic edema. Hyperosmolar agents, for example, mannitol, can disrupt the blood-brain barrier, which leads to increase in permeability of medications. Okay. So hyperosmolar agents like mannitol, it can disrupt the blood-brain barrier, which increases the permeability of substances like medication. Okay. Disruption is vasogenic edema. Okay. Vomiting center. So, vomiting center coordinated by tractus nucleus, nucleus tractus solitarius. Let's look at where that is in medulla. Here. Okay, so it's up here. Okay. But let's see if there's a labeled one. Ventral tegmental area. That's where the dopamine is made, right? This is tractus solitarius over here, and lateral parabrachial nucleus over there. Okay, cool. So coordinated by nucleus tractus solitarius in the medulla, which receives information from the chemoreceptor trigger zone or CTZ located within the area postrema. Okay, pronounced puke strema. In fourth ventricle. GI tract via vagus nerve, vestibular system, and CNS. Chemoreceptor trigger zone and adjacent vomiting center nuclei receive input through 5 major receptors. These are histamine, muscarinic, neurokinin, dopamine, and serotonin. Okay, for histamine it's H1, muscarinic it's M1, neurokinin it's NK1, dopamine is N2, and serotonin is 5-HT3. So 5-HT3, D2, and NK1 are antagonists used to treat chemotherapy-induced vomiting. Okay, so those are the drugs you would give for this. And then H1 and M1 antagonists treat motion sickness. H1 antagonists treat hyperemesis gravidum. So these are your, we'll just look at the drugs. Ondansetron and all of these. The cetron ones are anti-emetic. Okay. Okay. So these are the chlorprotexin and this. Okay. For that, and NK1 antagonists are aprepitant, rolapitant, and cazapritant, and all of these. Okay, the important one is this aprepitant. Okay, I think we read about these in GIT. Okay, and then H1 and M1 antagonists treat motion sickness. So I guess that's like your scopolamine and hyoscine, that stuff. For this, it's prazapine, telazepine, uh, antimuscarinic like hyoscine, okay, and H1. Citrazine and loratadine and phenoxidine. Okay, so scopolamine is antimuscarinic, right? Okay. H1 antagonists treat hyperemesis gravidum. So you give that in pregnancy. Okay, so vomiting due to pregnancy. Okay, so on to sleep physiology. Okay, I do have a way to remember this, so it's from Dirty Medicine as well. Okay, let's get through this. Okay, so sleep physiology. Sleep cycle is regulated by circadian rhythm, which is driven by suprachiasmatic nucleus. You gotta remember that. This is the one SCN, that's sun sensing nucleus. Okay, so sun sensing for circadian rhythm. Okay, so or suprachiasmatic nucleus of the hypothalamus. Circadian rhythm controls nocturnal release of ACTH, prolactin, melatonin, norepinephrine. So sun sensing nucleus will release norepinephrine, and then that will go to pineal gland, which will then increase production of melatonin. Okay, so sun sensing nucleus is regulated by environment, for example, light. There are two stages. There's rapid eye movement and non-rapid eye movement. Okay, alcohol, benzodiazepine, and barbiturates are associated with decrease in REM sleep and N3 sleep. Norepinephrine also decreases REM sleep. Okay. Important to remember these. So alcohol, benzodiazepine, and barbiturates are associated with decrease in REM sleep and N3, whereas norepinephrine is associated with only the decrease in REM sleep. Benzos are useful for night terrors and sleepwalking by decreasing N3 and REM sleep. So that's good for night terrors and sleepwalking. Okay, so sleep stage percent of total sleep time in young adults, description and EEG waveforms and notes. Okay, let's do it over here. So you have consciousness, awake and asleep. Okay, so there are two for awake, and then these are for asleep, the REM and non-REM, right? So in awake, you're either alert or tired, right? So tired is when you're drowsy and about to go to sleep. Okay. In alert, you have beta waves. Okay, and they're B for busting out work, and this is what it looks like, the beta wave. Okay. In tired, it's alpha wave. So A for about to fall asleep. So tired and that. Okay. Let's read that. So awake, eyes open, you're alert, active, mental concentration. Beta, so highest frequency and lowest amplitude, right? So the frequency is increased, but the amplitude is really small, right? So highest frequency and lowest amplitude. In awake, it's alpha, right? But eyes are closed here, so when you're about to fall asleep. Okay, so they don't have alpha here, but anyways, I guess that's not important. Non-REM sleep. Okay. So now we are on to asleep. So when you're asleep, you either are in the non-REM or REM. Okay. In non-REM, you have stage 1 or N1. It's light sleep. Okay. That's it, and it's theta. Okay, so this is alpha wave, sorry. So drowsy. So alpha waves are prominent. Okay. There's increase in amplitude for that. Okay. And then stage 1, this is the theta wave. Okay. It's these things right here. Because these look similar to this. And then they slow down a little. And then they have, phases of theta waves in there. Okay. Then there's N2, which is deeper sleep with bruxism or teeth grinding or tooth grinding occurs. Okay, so stage 2 or N2 for tooth, because there's tooth grinding, which is known as bruxism. Okay, so here you'll see sleep spindles and K complexes. Okay, so N2. The way you remember that is in bruxism, you pronounce it this way, or you spell it out this way. So brew, KSSISM. So that's for K complexes and SS spindle or sleep spindles. Okay. These are your sleep spindles, and this right here is your K complex. Okay. Let me just make sure of that. Okay, so these are your K complex, and these are your sleep spindles. Okay, so these are your K complexes over here, and that's your sleep spindle. So sleep spindles and mixed EEG activity. Okay, this is 50% of the total sleep, and this is non-REM. That's rapid eye movement. So eyes are not moving in this stage either. Okay. You gotta remember these things, because they'll give you that in the question stand, that the person grinds his teeth. What stage is he in, right? And then you can tell, or what kind of waves will you see. So you can tell by these things. Okay. Then there is N3. This is the deepest non-REM sleep. Slow wave sleep. Sleepwalking, night terrors, and bedwetting occurs. Okay, so V and flee in N3. You see delta waves. These are lowest frequency and highest amplitude, and it's the deepest sleep stage. Okay, so lowest frequency, right? Now it's taking a long time to hit the waves compared to like this. Okay, and highest amplitude, right? It's telling by itself. Slow wave sleep, stage 3 and stage 4 sleep, progressively more delta waves, stage 4 shown. There's no stage 4. We don't need to worry about stage 4. We are only on stage 3 anyways. Okay, so in delta wave, it's V flee because it's scary in stage N3. Okay, scary because of night terrors, right? So you get bedwetting, sleepwalking, and night terrors. Delta is low frequency and highest amplitude. It's deepest sleep. And how do you differentiate between night terrors and nightmares, right? Uh, in night terrors, you forget them after you're awake. Okay, so a child who wakes up from night terror, he won't remember his dream or nightmares or whatever, night terror dreams. But if he remembers them, it's nightmare, and that's important because nightmare occurs in this stage, this stage. Okay, nightmare occurs in there, and night terror occurs in this one. Okay, that's why it's important. So stage 3 is delta wave. Okay, so let's just revise these before we go on to this one. So in awake, it's wide and open, you're alert. Okay, if you're busting out work and all that. So busting out work, B for beta wave. Okay, that's high frequency and low amplitude. Okay, uh, okay, high frequency and low amplitude. And then you have about to fall asleep, so eyes are closed, and these are about, so for that's A for alpha wave. Okay, and that's drowsy right there. Alpha wave are prominent. Then you have non-REM sleep, stage N1, N1 is theta. Okay, there's nothing for that. Uh, how would we remember that? I don't know. So just remember it. They don't really test you on it. Anyways, there's a lot better things they can test you on. So theta is that. It's useless. Uh, Ignore it. Stage N2 though. N2 uh, is bruxism, right? N2 stage has K complexes and spindle. Sleep spindles. So sleep spindle and K complexes. Okay. And this is the stage 2. So we went through beta wave, alpha wave, then theta wave. Okay, so that's bat. Okay, so bat, string blood. And then we're on to, sorry, S for sleep spindle, right? So bruxism happens there. And then delta wave. Here you get bedwetting, sleepwalking, and night terrors. Night terrors are the one where you don't remember it after you're awake. Okay, so this will be in the question stem. The kid is wetting the bed. He's sleepwalking and all this stuff. So it's because of N3 or delta wave is what you would see. Okay, this is normally decreased in older adults and in depression. Okay, in depression and older adults, you have shorter N3s, and that's why they usually wake up early in the morning compared to younger adults. Okay, asleep. Okay, now REM sleep. So REM sleep, lower loss of motor tone. This is important because you lose all your motor tone, basically, right? However, there is something about this that's important. It's atonic, but in Parkinson's disease, a person acts out their dream, so they will kick or punch in their sleep. Okay, and that's what the question stem will say. The wife is complaining about the husband kicking her in their sleep, and that's because of chances are the person is going into Parkinson's disease. Okay. So loss of motor tone, increase in brain oxygen use, variable pulse, or BP, increase in acetylcholine, right? And we saw over here that acetylcholine is increases in Parkinson's disease, right? Okay. REM is when dreaming, nightmares, and penile clitoral tumescence occurs. Okay, so you get the erections or clitoris tumescence. Nightmares. So nightmares again are the one where you remember after you are awake. Okay, it may serve memory processing function. Okay, extraocular movements due to activity of PPRF. PPRF is paramedian pontine reticular formation. Oh, they gave it here. Extraocular movement due to activity of PPRF, paramedian pontine reticular formation, or conjugate gaze center. Do I have that anywhere here? Okay, we'll look at this. Hold on. Okay, so this is where it is. This is PPRF. Okay. So what's the significance of that? Well, read it, I think, when we're doing this stuff. I guess it's in patho. Oh, wait. Okay, right here. Yeah, so in patho, that's PPRF. It's when the complications are that eyes look away. So it helps you look towards certain type. Okay, certain side. I'm not recalling it right now, so we'll learn about it later. Okay, but it's important to remember that extraocular movement occur due to activity of PPRF. I think it's when the left lateral rectus or looks to the left, then the right medial rectus also looks to the left, right? So the connection between that, I think that's what this is. So paramedian pontine reticular formation, the conjugate gaze center. Yeah, so it occurs every 90 minutes and duration increases through the night. Which time do I have? 8 minutes. Okay. So it occurs every 90 minutes and duration increases through the night. Uh, this is again a beta wave, okay? Because now your eyes are moving, right? There's rapid eye movement, and that's similar to when you were busting out work. So beta wave there as well. Okay, so in REM sleep, this looks a lot like that. Okay, so it's low voltage and high frequency waves. Uh, the changes in older adults, there's decrease in REM sleep, so that's why they wake up early as well. Decrease in N3, right? They wake up early because of that as well. There's increase in sleep latency, so that means they fall asleep later, and increase in early awakening. Okay. Changes in depression is you get into REM sleep really fast, so increase in REM sleep time, decrease in REM latency. You reach faster, you reach the REM stage faster in depression. You decrease in N3, that's why you get faster into REM sleep. And repeated nighttime awakenings and early morning awakenings as well. Terminal insomnia, so you wake up early during depression. Okay, changes in narcolepsy is there's decrease in REM latency. Okay, they reach there really fast, and that's why they fall asleep standing up, and then they fall. So all of this, there's an acronym. It's bad string blood or mnemonic, right? So B for beta, then alpha, then theta. We don't care about that one. S for spindles, sleep spindles. D for delta, and blood is B. Okay. So again, REM, beta wave, atonic, but in Parkinson's person acts out their dream, so they will kick or punch in their sleep. It's immobile. You remember your nightmares. Okay, so immobile because you're lost all your motor uh, tone. You remember your nightmares. Increase in oxygen demand for brain. It's autonomic, so increase in heart rate and pena clitoral tumescence. Extraocular movement due to paramedian pontine reticular formation. It's responsible for the conjugate gaze. The REM sleep is decreased in older adults. They fall asleep slower but wake up early. REM sleep is increased in depression, and they achieve REM sleep faster and they wake up early as well. It achieves you achieve REM sleep faster in narcolepsy. Okay, and that's your sleep physiology. On to hypothalamus. Let's take a break here. On to hypothalamus. Uh, so for this hypothalamus, I remember like hippos. So hungry hippos sit in the water to cool off. So they regulate temperature that way. Drink the water to quench the thirst. So regulate thirst. And Moto hits on Gloria in Madagascar. Remember Madagascar? Um, Near the water. So it regulates sexual urges over there. Uh, if you don't remember. This thing right here, watch the video. It's pretty hilarious, but yeah. Okay, so hypothalamus, it maintains homeostasis by regulating thirst and water balance, controlling adenohypophysis, so anterior pituitary, and neurohypophysis, so posterior pituitary, release of hormones produced in the hypothalamus, and regulating hunger, autonomic nervous system, temperature, sexual urges. Right. Inputs, areas not protected by the blood-brain barrier, so OVLT, senses change in osmolarity, area postrema found in dorsal medulla, response to emetics. Okay, so hypothalamus has multiple nuclei. Okay, so like these lateral hypothalamus, dorsal, PF, DH, all these. So that's what it looks like, all crumbled up into one. Okay, so we'll do those now. Lateral nucleus. If destroyed, you don't get hungry. Okay, so this is the hunger one. So this is the one that governs hunger, lateral nucleus. So destruction of this will lead to anorexia, failure to thrive, stimulated by ghrelin, the gremlin one. It's inhibited by leptin. Leptin is produced in the adipose tissue. Okay, so lateral injury makes you lean. Okay, so if destroyed, you don't get hungry. In ventromedial nucleus, satiety. So destruction of this, for example, cranopharyngioma, leads to hyperphagia. Is stimulated by leptin. Okay, so this is the one that tells you you're done eating, right? So VMN, it's VM is for very much. So thank you very much, but I'm done eating, like that. So a destruction of this, you won't say that. You'll keep eating. Okay, so ventromedial injury makes you very massive. Okay. Anterior nucleus, that's AC. So AC for cooling. It's parasympathetic. Okay. AC, anterior cooling. And then you have PN, that's heating. And this is sympathetic intervention. So heating controlled by posterior nucleus or hot pot. Okay. And then you have SCN or suprachiasmatic nucleus or sun sensing nucleus. Okay. It's for circadian rhythm. Right. It sends off NE to pineal gland to make more melatonin. Right. We just read about that somewhere here. So circadian rhythm controls nocturnal release of ACTH, prolactin, melatonin, and norepinephrine. How? This one sends NE to pineal gland, which increases melatonin. Okay. Then comes supraoptic and paraventricular nuclei. So this one we read in endo about this, right? So this is the paraventricular nuclei and this is the supraoptic. Okay, so paraventricular nuclei because it's outside of the ventricle right there. Okay, and then this is supraoptic because that's the optic chiasma or chiasm, and right on top of it. So supraoptic on top of the optic one. Okay, and that one makes ADH and oxytocin, and then they go down into this and get stored here. Okay, and it can get distributed by paraventricular capillaries. I mean, paracapillaries. So if there's an obstruction here, and this is not able to go here, there are still capillaries around here where it can travel through. Okay. So it synthesizes ADH and oxytocin, said POX. So superoptic makes ADH, and paraventricular one makes oxytocin. ADH and oxytocin are carried by neurohypophysins down axons to posterior pituitary, where these hormones are stored and released. Okay. Preoptic nucleus, thermal regulation. Okay. Thermal regulation, sexual behavior, and it releases GnRH. Okay. Failure of GnRH producing neurons to migrate from olfactory pit will lead to Kalman syndrome. We read about this in repro, right? Kalman syndrome decrease in GnRH, but leads to decrease in FSH, LH, and because of LH, it will lead to decrease in testosterone. This all leads to infertility, and you'll also see anosmia, or in female, you'll see amenorrhea and anosmia as the presentation in a question stem. Okay, so hunger center for hungry hippos. Sit in water to cool off, regulate temperature, drink the water to quench the thirst, regular thirst, and Moto hits on Gloria in Madagascar near the water, so it regulates sexual urges. So these are the function of hypothalamus. On to thalamus. Okay, just like hypothalamus, thalamus has nuclei as well. Okay, and that's how, so this is thalamus, okay, right there. So when you open that up, actually just dissect it out, it's gonna go look something like this, and this is usually what we see when in our books when we read about it. Okay, someone made an effort to write this. So anterior nucleus, lateral dorsal, lateral posterior, ventral anterior, ventral intermedial, and ventral lateral, ventral posterior lateral, and ventral posterior medial, and pulvinar nucleus, medial geniculate, and lateral geniculate over there. Okay. I don't know how many of these are important for us, so let's see if any of these come up. Okay. So ventral posterior lateral, right? That's over here, this thing. So VPL, okay, that's vibration, pain, pressure, proprioception, and light touch. Okay, so VPL, nucleus, spinothalamic and dorsal column. Okay, and so if you don't want to memorize that, you can just memorize this thing, which is easier. Okay, so input is from so it goes to this from the spinal cord, right? And the spinal cord is this is how the things travel up to the medulla, and then medulla is where it crosses. So spinothalamic tract, that's these parts right here. So spinothalamic tract is responsible for pain, pressure, temperature, and crude touch, right? We don't worry about crude touch here, I guess, but yeah, that, and dorsal columns and medial lemniscus. So that's this stuff. So again, pressure, vibration, fine touch, and proprioception, right? So these are the things you'll see over here carried into this nucleus. Okay, so spinothalamic is responsible for pain, temperature, crude touch, pressure, and dorsal columns are responsible for pressure, vibration, fine touch, and proprioception. Okay, so that's vibration, pain, pressure, proprioception, conscious, light touch, and temperature here. Destination is primary somatosensory cortex. So that's what this is. Parietal lobe. In the parietal lobe, okay. Parietal lobe of this, I guess. The thalamus. Or no, wait. Okay, I think it means parietal lobe of the brain. right here, somatosensory. Okay, so I guess we gotta take this back there too. Okay. Then we have ventral posterior medial. Okay, so ventral posterior medial is over here. Okay, trigeminal and gustatory pathway. So VPM, that's very pretty makeup. Okay, very pretty makeup goes on the face. So trigeminal and gustatory pathway, face sensation and taste. That's the pathway. Uh, these are the senses that it gets, right? So it also goes to somatosensory cortex or parietal lobe. Right there, over there, actually. Okay. Then we have lateral geniculate nucleus. That's cranial nerve 2. So optic nerve, optic chiasma, and optic tract. So L is for light. Okay. It gets vision inputs, and it goes to primary visual cortex in the occipital lobe. So that part right there is where it sends fibers to. Okay, so lateral for light and vision. Then you have medial geniculate nucleus, that's superior olive and inferior colliculus of tectum. Okay, so M for music, so primary auditory cortex, right over there. This thing. Okay. Part of the temporal lobe, and that. So superior olive and inferior colliculus. Is that here? The way you're supposed to remember that is that superior part, your eyes are above your ears. Okay, so superior colliculi is responsible for the eyes, and the inferior one are responsible for hearing, or something like that. It comes somewhere, we'll read it there. But yeah, so medial geniculate nucleus, it's superior olive and inferior colliculus. Oh, never mind. It's not olive. I mean, I think it was superior colliculus and inferior colliculus. So superior colliculus is responsible for the vision. Okay, and inferior colliculus of tectum is responsible for this, or the other way around. I'm kind of messed up on that right now, but we'll figure it out. Then you have ventral anterior and ventral lateral, right? So ventral anterior and ventral lateral over there. Nuclei. So these are coming in from basal ganglia and cerebellum. Okay, the input. And these are the motor input. Okay, so this is known for the coordination center, and this one is also that, balancing, coordination, and all that, right? So sensing, motor. Destination is motor cortexes. So premotor cortex right there, and this is the primary motor cortex in the, I guess, frontal lobe. The frontal lobe was here, but anyways. Okay, so Venus astronaut vowed to love moving. Okay, I gave them Indian names, so Vikram Antil and Vikram Lati. Both are in a gang, so for basal ganglia, and drive CRB motorbike. That's Honda or cerebellum, and motorbike for motor for motor. Okay. Probably won't work for you, but yeah, you have it there. Okay, so again, VPL, that's all the spinothalamic and dorsal inputs going to somatosensory. Then you have VPM, very pretty makeup. So the face ones, so trigeminal and gustatory. So face and taste, again, somatosensory. Lateral geniculate nucleus, or L for light, so vision stuff. So inputs coming from optic nerve, chiasma, and optic tract. Medial geniculate is M for music. and that's coming from superior olive and inferior colliculus going to auditory. And then you have ventral anterior and ventrolateral. Okay, so coming from basal ganglia and cerebellum, going into your motor cortices in the frontal lobe, and it senses motor stuff. Okay, limbic system. This is an easy one to remember because you just gotta remember the 5 F's. That's feeding, fleeing, fighting, feeling, and fucking. Collection of neural structures involved in emotion, long-term memory, olfaction, behavior modulation, and ANS function. Consists of hippocampus, right? So red arrow, this is your hippocampus. Red arrow is in A. Amygdala, mammillary bodies, anterior thalamic nuclei, cingulate gyrus. Yellow arrow in that. So that's your cingulate gyrus. Is that here? You need to know where that is actually, the cingulate gyrus. So we'll look at that. It's you can't miss it if they give you in a photo. Okay, it's this whole yellow thing. Okay, that's cingulate gyrus. Okay. Okay, so if they give you a scan, that's where it is. Okay. These are the surrounding structures. So that's the thalamus. This is corpus callosum. This is the posterior cingulate. This is the anterior cingulate, and this is the rostral anterior cingulate. Okay, and that's the lateral ventricle. Okay. Okay. So you need to be able to figure it out from here too. Okay, so superior frontal gyrus, that's over here. Septum pellucidum, third ventricle. Sorry, excuse me. Temporal horn over there. Vermis, thalamus, lenticular nucleus. This is the quadrate nucleus, and that's important one. Quadrate nucleus, because that's part of the basal ganglia. Frontal horn, cingulate gyrus over there, and falx cerebri. Okay. So for the limbic system, this is a photo that you look at. We'll go over that too. So this is the formix, cingulate gyrus right there, right? This is the cingulate cortex surrounding the cingulate gyrus. This is corpus callosum. This is thalamus. This is the stria terminalis. Okay. This is amygdala, and right under the thalamus you have hypothalamus right there, and right below that you would have the pineal gland, I guess. It's over there. Stria terminalis, amygdala. This is the memory body. That's an important landmark as well. Need to know about that. Olfactory is here. With the cribriform plate of the ethmoid bone, septum, and frontal cortex. Okay, so for this one you need to remember where. You don't really need to remember any of this as long as you remember the 5 F's. But it consists of hippocampus, the limbic system, right? Hippocampus, amygdala, mammillary body, anterior thalamic nuclei, cingulate gyrus, and entorhinal cortex. Okay, so that's where this olfactory bulb is. Okay, it's responsible for feeding, so eating, fleeing, running, right, or fighting. You still need your limbs for that. Feeling, you need limbs for that, and sex, you need limbs for that as well. So you need all your limbs to do the 5 F's in limbic system. Okay, so need all your limbs. Okay, so that's how you remember the 5 F's: feeding, fleeing, fighting, feeling, and fucking. Dopaminergic pathways commonly altered by drugs, for example, antipsychotics and movement disorders, for example, Parkinson's disease. Pathway symptoms of altered activity and notes. Okay. So before we read, let's look at these. So you have what is this? Pituitary gland. This is the ventral tegmental area of the pons, I guess. Then you have hypothalamus over there. This is the thalamus. This is substantia nigra over here. Okay. So let's go through that and this. Okay. So mesocortical. Decrease in, so we're doing pathway, symptoms of altered activity and nodes. Okay, so dopaminergic pathways commonly altered by drugs, for example, antipsychotics and movement drugs, for example, Parkinson's disease. Okay. Mesocortical. Okay, so that's a pathway that decreases activity, which leads to negative symptoms, for example, anergia, apathy, and lack of spontaneity. Okay, nodes. Antipsychotics have limited effect. Mesocortical is the blue one, so it goes from here to the cortex. Okay. Meso, I guess that's from mesoencephalon, right? Because mesoencephalon makes pons, or the midbrain actually. It makes the midbrain, right? Mesencephalon makes the midbrain. Okay. So it goes from mesencephalon to the cortex. Okay. Yeah. So symptoms and altered activity. If it was this, it's decrease in activity and all this stuff. Okay. On to mesolimbic. So here you have symptoms are increase in activity, positive symptoms, for example, delusions and hallucinations. So this is the primary therapeutic target of antipsychotics. It leads to decrease in positive symptoms, for example, in schizophrenia. So again, you have meso, but this time it's going to limbic system. Okay, so that's the red one. Okay, so it's going from here to this to nucleus accumbens. Accumbens, remember, accumbens, grab a cucumber, GABA gets made over there. Okay, so when you don't have GABA to take care of it, you get hallucinations and all that stuff as well. Let me just make sure. You get anxiety, decrease in GABA, and you get Huntington's when you decrease in GABA. Okay. Negrostriatal, right? So decrease in activity will lead to extrapyramidal symptoms. For example, dystonia, akathisia, Parkinsonism, and tardive dyskinesia. Okay. That's the yellow one. It's going from here to here. Okay, to the dorsal striatum from substantia nigra. Okay. So motor controls pronounced on nigrostriatal, significantly affected by antipsychotics and Parkinson's disease. Okay. And yeah, this is the one that's important for Parkinson's disease. For schizophrenia, it's this one, and the other one doesn't matter. Then you have tuberoinfundibular, decrease in activity, increase in prolactin. This is an important one. I'll talk about it. So decrease in activity, increase in prolactin, decrease in libido, and sexual dysfunction, galactorrhea, gynecomastia in males. Okay, so basically what this one is so you have a blockage, right here. So this pathway is responsible for what? It's responsible for dopamine to go in here. And what does dopamine do? It inhibits prolactin, right? So if you have some kind of growth here, for example, sarcoidosis happening here, right? There's a question like that. So what that will do is that will disrupt this pathway. So now dopamine is not making it to the pituitary, right? Because the green one is tuberoinfundibular pathway. So it's not going to make it from hypothalamus to the pituitary. So prolactin is no longer disinhibited. So because of this tumor, there's disturbance in the pathway, which will increase what hormone from the pituitary. It's going to increase prolactin because now it's no longer inhibited by dopamine. Okay. Moving on to cerebellum. So cerebellum, walk around like you don't ever give a fuck. Okay. That's just for this. So don't for dentate. E for emboliform. G for globus. F for vestigial. Okay. Cerebellum, it modulates movement, right? Cerebellum is known to do balance and movement. So modulates movement, aids in coordination and balance. Okay. So ipsilateral, it's unconscious proprioceptive information via inferior cerebellar peduncle from spinal cord. Okay. So on the same side of the lobe, it receives. So let me draw a dude here. Okay. With cerebellum here and this like that, and a vermis in the middle. Okay. Just pretend like you know what I mean. That's a leg. That's a leg. That's an arm. That's an arm. Okay. So when this side, let's call that the left side, and this is the right side. Okay. So in ipsilaterals, that means this area right here. Actually, let me change the color. So ipsilateral, this receives the proprioceptive information from this side as well of the limbs. Okay. And then yeah, so this side will receive from this side. Okay, proprioceptive information via inferior cerebellar peduncle from spinal cord. Okay. So that just means the fibers coming in. So from the inferior fibers. Okay. So this would be the inferior one. Okay. These are the middle one. Okay. And these are the superior peduncles coming into the cerebellum. Okay, so cerebellum, superior peduncle are over here, middle peduncle is over here from the pons, and inferior peduncle coming from the ipsilateral side of the information coming from the ipsilateral side of the limbs. Okay, like that. And this is your dentate, interposed, vestigial, all that stuff. All the other stuff don't really matter that much. Okay, so ipsilateral proprioceptive information. We know something about proprioceptive as well. Where does it come from? It comes from the dorsal column, right? So dorsal column is responsible for the proprioception, right? So that's where we saw that. So ipsilateral unconscious proprioceptive information via inferior cerebellar peduncle from the spinal cord. Make sense? Deep nuclei, lateral to medial. Okay. Dentate. Okay, so deep nuclei. So that's talking about these stuff. These are the deep nuclei. So it goes from outside to inside. So that's dentate, emboliform, globus, and then vestigial on the inside. Okay, don't eat greasy food or don't ever give a fuck. Lateral lesions affect voluntary movement of extremities, lateral structures. When injured, propensity to fall toward injured or ipsilateral side. Okay, let's see. Sorry. So lateral lesions. Okay. It affects voluntary movement of extremities, so lateral structures. When injured, the propensity to fall towards the injured or ipsilateral side. Okay. So if this area gets, slashed, let's make it green. So if yeah, there's a problem with this side, it's gonna fall towards this side, right? So lateral structures, lateral lesions. Okay, it falls on the ipsilateral side. If there's a medial lesion, so in the middle, like vermis, okay, uh, right. So vermis, so that's this part right here. This is the lateral cerebellum. This is the medial cerebellum, and this is the flocculonodular lobe. Okay, they give you this here too. So proprioceptive information comes from the spinal cord to inferior cerebral peduncle from down here. Then you have contralateral cortex, middle cerebral peduncle coming in from here, the fibers, and superior one is the one that goes outwards, right? So that's why the pink arrow is going outwards, or the orange one going outward, right? So deep nuclei, so those are your dentate, emboliform, globus, and fastigial. They will send out the information via superior cerebral peduncle to contralateral cortex, and this is important. So the right one will go give off to the left, and the left one gives off to the right. That's why when you have a medial lesion, for example, in the vermis or fastigial nuclei or flocculonodular lobe, truncal ataxia happens. That's wide-based cerebellar gait, nystagmus, and head tilting. Okay. Generally, results in bilateral motor deficits affecting axial and proximal limb musculature. Okay. Medial structure. I was hoping it would be like you fall towards the contralateral side or something, but that's not given here. But anyways, so that's important about that. So coming in, it comes into the uh, side of the lesion, right? So say you have a lesion over here, and then you're moving your arms, so now, or moving your legs, but the information is not coming in here. So this is not gonna, go into the deep nuclei, cross over to the contralateral side, and then, send the fibers here, and then it crosses, like, I guess, in the medulla to go back here. But since that's not happening, you're gonna fall on this side because of that, right? Because the information is not being received now. Okay, so that. So with medial lesions, you get nystagmus, head tilting, and all that stuff. Tests. So rapid alternating movement, pronation and supination, finger to nose, heel to shin, and gait. Look for intention tremor. This is important. If you find an intention tremor, it's because of a lesion in cerebellum. Okay. Let me see if I can find a lesion for this. Something that's fast. Okay. I don't want to go in. Okay, this one will work. So someone with a ataxic gait, this is what it's gonna look like. Okay, they're not able to keep the balance, and keep a coordinated movement, right? So when they start walking, they're gonna have a hard time. Okay, like that. Okay, and yeah, okay. Um, and yeah, done with that. So lateral lesion, you fall on the ipsilateral side. With medial lesion, you get nystagmus, truncal ataxia, and head tilting, right? Because head tilting, why? Because you're trying to, understand the balance basically. So that's why you're tilting to use your ears basically, because your ears also have those sensory fibers, right, that help you balance. Um, I guess that way. I don't know for sure, but that's that should help you remember it. Okay. Onto basal ganglia. Okay. Mm, okay. Basal ganglia. So it's important in voluntary movements and adjusting posture. Okay. It receives cortical involvement. It provides negative feedback to cortex to modulate movement. Okay, and this is important. This whole concept, uh, but I don't think it gets tested on. Like for step one, they don't really test you heavily on CNS stuff. What they'll test you is on like lesions and stuff like that. So if you don't understand basal ganglia, you can, you know, not bother with it and you'll still be good. Important involuntary movements and adjusting posture. Receives cortical input, provides negative feedback to cortex to modulate movement. Okay. So striatum, it's putamen or motor. Okay. So that's with quadrant nucleus. That's for cognitive. So quadrant nucleus, we looked at the anatomy of that. Right. It's over there. This is the lentiform nucleus. So lentiform is made up of putamen and globus pallidus. Okay, so here you have putamen, and this is globus pallidus. This is internal capsule right there, right? And this is your quadrant nucleus. Quadrant nucleus is the one attached to or at the periphery of the lateral ventricle. Okay, you might be asked about this, so you need to know where that is. This is the insula, and this is where the memory body is. So if they give you a scan of a brain like this, you should know where would be which thing. So quadrant beside the lateral ventricle, uh, far down will be your mammillary body. Thalamus is pretty easy to figure out, right? So thalamus is this. Between the thalamus, you have the third ventricle, right? That's below the lateral ventricle, and right below the third ventricle, you have hypothalamus, right? So right below, in between that. Then you have right beside the hypothalamus, you have subthalamic nucleus or STN, and right below that you have substantia nigra over there. This is your amygdala. That you need to know, and you need to know hippocampus as well. So, because this is part of the limbic system as well, right? So amygdala, hippocampus, substantia nigra, mammillary body, insula, globus pallidus. This is externus is the one outside, and in the middle you have the internus, right? So globus pallidus, internus. This is the putamen, thalamus, third ventricle, lateral ventricle, quadrant nucleus, and subthalamic nucleus, and substantia nigra. Okay. Onto the pathway. I do have a note on that. So basal ganglia, it coordinates movement and utilizes excitatory and inhibitory neurons. So excitatory is the glutamate, inhibitory is the GABA that it uses. In direct pathway, what it does is used to direct pathway is used to initiate movement, okay, and indirect pathway is used to terminate movement, okay. So dopamine attaches to D1 receptors or D2 receptors. If it attaches to D1 receptor, it's gonna use the excitatory pathway, okay, that's directly going down towards this. If it attaches to the inhibitory pathway, it goes through this indirect pathway, through this, and it inhibits or terminates this movement, okay, or something, and that leads to increase in movement. So apparently everything is about the movement, okay. Okay, so let's read this and then come back to this. So direct or excitatory pathway, cortical input via glutamate, so that's excitatory, stimulates GABA release, okay. So we have direct pathway cortical input, that's motor cortex, coming in with the green, which is glutamate, goes over here, okay, and that stimulates the release of GABA, okay. So GABA is going to go either from direct or indirect. If it goes directly, it passes through the globus pallidus externa into the internus, okay. So inside one is the internus and the middle one is the globus pallidus externus, okay. I'm messed up over there, okay, which inhibits GABA release, okay, from GPI, okay. So GPI's primary form of action or primary action is to release GABA and inhibit thalamus, right? So when this one releases glutamate, comes in and attaches to D1, D1 will inhibit this, so this is no longer inhibiting thalamus, right? And that's how you end up with movement, okay. So that's what they mean. The cortical input glutamate comes in, okay, goes here. It stimulates the GABA release from the striatum, okay. So GABA is the red ones, okay, and this is the direct pathway. It goes into the GPI, globus pallidus internus, which its only action is to release GABA, so it's gonna inhibit that, right? Because that's what this red thing is doing. It's going to inhibit this, so no more GABA is being released, so thalamus is no more inhibited, right? So, or you can say that thalamus is disinhibited by blocking GPI and disinhibiting or activating the thalamus, which leads to increase in motion, and that's why you get this motion, glutamate going out there, okay. Let's see the DAR. What I have here is motor cortex comes in with the glutamate, since it makes striatum, activates striatum to put out GABA, right? So GABA comes in, it inhibits this, and then if that happens, then it inhibits, no more GABA is coming out, so thalamus is gonna then make movement, okay. So direct pathway, it's like turning off the thing that causes inhibition, okay. Net effect is turning on the motor cortex. That's the net effect, to turn on the motor cortex, okay. Disinhibition of the thalamic control of motor planning. Disinhibition of thalamic control for motor planning, okay. So let's do that. And now on to indirect pathway. Okay, indirect inhibitory pathway. So cortical input via glutamate. So again, glutamate is coming in. It stimulates GABA release from the striatum. Again, it does the same thing, right? GABA release from the striatum. But this time it's going indirectly to this, right? So now it goes to GPE, right? And its primary function is to release GABA. And GABA then goes on to inhibiting substantia nigra, or wait, no, that's, sorry, subthalamic nucleus, STN. right? So globus pallidus externus primary goal is to inhibit subthalamic nucleus. So when GPE's being inhibited now, that means it's not going to be able to inhibit substantia nigra. Sorry, keep messing that up. Subthalamic nucleus. So then subthalamic's primary goal is to stimulate GPI, right? So when that gets stimulated, GPI will then start sending in GABA or inhibitory signals to thalamus, and that's how you terminate movement. So then this does not happen, right? That thing. Okay. So let's read that one more time. Cortical input via glutamate stimulates GABA release from the striatum, okay, which inhibits GABA release from GPE, okay, disinhibiting the disinhibiting, or also known as activating STN to send out GABA. So STN input via glutamate stimulates GABA release, right? So this is glutamate, the green one, and GPI then sends out GABA to thalamus. It leads to decrease in motion. 10 minutes, we should be done. Dopamine from substantia nigra or nigrostriatal pathway stimulates the direct pathway by binding to D1 receptor and inhibits the indirect pathway by binding to D2 receptor, which both lead to increase in movement, right? So what that means, remember I told you D2 is inhibitory and D1 is excitatory, right? And that's what it means over here. So sometimes it can come straight from the substantia nigra, okay? That's where the dopamine comes from. And dopamine are two types. One is inhibitory and excitatory. D1 is excitatory, okay? And D2 is inhibitory, okay? So when that comes in over here, it excites the direct pathway, D1, right? So stimulates the direct pathway by D1, so that's excitatory. So when D1 gets stimulated over here, it's gonna end up inhibiting this. So when this gets inhibited, the thalamus gets disinhibited and movement occurs. When there's inhibition of indirect pathway, this gets inhibited, right? So then you have inhibition of this. So when this is inhibited, it's no longer activating GPI, and when you don't have GPI sending in GABA, that means this is again disinhibited and there is movement in thalamus. And that's what I mean over here, that dopamine attaches to D1 or D2, and either way, D2 is the inhibitory pathway and D1 is the excitatory pathway. So both of them will lead to increase in motion. Okay. So motor cortex again comes in, but this time it attaches, it goes through the indirect pathway, so it inhibits globus pallidus externus. Okay, let me bring this down here. Okay, so it's coming to striatum, right? So normally it inhibits this, right, GPE, but if this is inhibited by the D2 receptor, then GPE will go on to inhibiting subthalamic nucleus, right? And subthalamic nucleus's primary goal is to send GABA to subthalamic nuclei, right? So that should be subthalamus nucleus over here. No, right there, sorry, right. And subthalamic nucleus's primary goal is to send glutamate to GPI, right? And GPI's primary goal is to send GABA to thalamus, so it's going to continue sending GABA, and that's how it's going to terminate movement over here. Okay, but now if D2 is coming in and it's inhibiting this whole thing, I mean, it's not able to inhibit this, what's going to happen? This is going to continue inhibiting this, so this does not send out glutamate to GPI, so GPI will not send out GABA anymore, right? So that will increase movement as well, and you get increases movement in that. Okay, so indirect pathway, net effect, turning off the motor cortex and activation of inhibition. Okay, so turning on the thing that causes inhibition. Okay, so you gotta separate the two. This pathway is different than this pathway. Okay, and you might have to revisit this a couple of times to understand it completely. But if you don't understand it, that's okay as well, because they don't get tested that much on. Anyways. Okay, so done with that. On to this. Let's take a break here. Okay, so yeah, when you're doing this, remember the two pathways are different. If you're using the motor cortex pathway, that's direct and indirect in this way, and that does not. Both of them don't include one, which is direct pathway. It's gonna increase the movement, and the indirect pathway is gonna decrease the movement. But if you're using the dopaminergic pathway, they both are gonna end up increasing the movement, right? Because if dopamine comes in too, it's gonna inhibit this right here. So then this is gonna continue inhibiting this, and then globus pallidus internus is not gonna be stimulated to release GABA. So if that doesn't get released, it's not gonna inhibit thalamus, so it keeps going in, right? And that's the difference between D2 and the indirect pathway from motor cortex. Okay. All right. So on to cerebral cortex regions. You need to know two cortex regions if you don't remember anything else. The Wernicke area and the Broca's area. Okay. And those two are the important ones. So Wernicke's in the temporal and Broca is in the frontal. And the fibers connecting the two are called arcuate fasciculus, okay, because they're like an arc. Okay, so then you have the frontal lobe. So frontal lobe, you have the prefrontal cortex. The frontal lobe has the frontal eye field. The premotor cortex, that means there should be motor cortex, so primary motor cortex right there. In front of it is the premotor cortex. Okay, you have the primary somatosensory cortex right there. The central sulcus is right there, and somatosensory association cortex over here. Okay, you have the sylvian fissure. That's this one right there. Attached to it is the Broca's area, and also back here it is. And you have the primary auditory cortex attached to the sylvian fissure as well on the temporal lobe. And this is the limbic association area right there. Okay, and the Wernicke's is part of the temporal over there. And in occipital, you have the primary visual cortex. So don't mess up primary visual cortex with the frontal field, eye field area. Okay, different parts of the brain. Okay, so cerebral perfusion relies on tight autoregulation. Okay, it's primarily driven by PCO2. PO2 also modulates perfusion in severe hypoxia. Okay, so that's important only when there's severe hypoxia. Otherwise, oxygen is not gonna do anything. Okay, it also relies on pressure gradient between mean arterial pressure, okay, and intracranial pressure, or ICP. So decrease in blood pressure or increase in intracranial pressure will lead to decrease in cerebral perfusion pressure. Okay. Cushing's reflex is triad of hypertension, bradycardia, and respiratory depression in response to increase in ICP. So this is another triad you gotta look out for, like all the other triads. So if you have hypertension, so increase in BP, along with decrease in heart rate or bradycardia, and respiratory depression, you have Cushing reflex, okay, in response to increase in ICP. So intracranial pressure, it pushes down into the vessel. This is a vessel, okay, in the brain. So when it pushes it in, Mean arterial pressure, if it increases, pushes outwards the walls. Right, so brain within the skull pushing inward pressure, ICP on the vessel. Okay. So the pressure gradient relies on the mean arterial pressure and intracranial pressure. Okay. The therapeutic, hyperventilation. So decreasing PCO2 will cause vasoconstriction. Okay. So partial pressure of carbon dioxide will lead to vasoconstriction, which leads to decrease in cerebral blood flow and decrease in intracranial pressure. Okay, so this mechanism is why we use this as a therapeutic thing, because if we give it when there is a, maybe used to treat acute cerebral edema, for example, secondary to a stroke, so unresponsive to other interventions. So when you give this, it decreases intracranial pressure at least. Okay, so cerebral perfusion pressure equals MAP minus ICP. Okay, so MAP is mean arterial pressure, that's 60 to 160, minus intracranial pressure, it's around 10 normally. So CPP normal is around 50 to 150, or cerebral perfusion pressure, right? It goes from 50 all the way to 150, okay? Because 60 minus 10 is 50 and 160 minus 10 is 150. So that's why that range is there. Mean arterial pressure is systolic blood pressure minus 2 diastolic blood pressure divided by 3, right? Or 1 over 3 systolic blood pressure minus 2 over 3 diastolic blood pressure. Okay, so CPP equals MAP minus ICP. If CCP equals 0, right, if there is 0, that means there is no movement, right? So there is no cerebral perfusion, which leads to brain death, coma, or absent brainstem reflexes or apnea. Hypoxemia increases CPP, or cranial perfusion pressure, only if partial pressure of oxygen is less than 50 mmHg. Why? Because if you have more oxygen, the brain's like, okay, we don't care about that. The more oxygen, the better anyways, so we don't need to worry about as long as it's above 50. But once it gets below 50, the brain's like, uh-oh, we don't have enough supply of oxygen, we need to do something. Okay, so that's when oxygen starts influencing perfusion, right? So we read that over here somewhere, right? So PO2 also modulates perfusion in severe hypoxia. So severe hypoxia when you have partial pressure of oxygen less than 50 mmHg. Okay, and CPP, or cerebral perfusion pressure, is directly proportional to carbon dioxide until carbon dioxide is more than 90 mmHg, because then it's so until you have the waste product, right? That's what this is. So as long as you have it going above this right here, 90, until it reaches there, it's going to increase the movement of the cerebral flow, right? The more waste product you have, the more you want to get rid of it, so that's why it keeps increasing as it increases, okay? But once you reach above 90, then something is wrong, right? So also there's not enough capability to increase the pressure or cerebral flow beyond this in the brain. Okay. Let's see what I have. So when MAP is between 60 to 160, a brain keeps the blood flow consistent by vasoconstriction or dilation. Okay, so it has the mechanism to do that, to control the pressure by vasoconstricting if it's slow, vasodilation if it's high. Okay, in chronic hypertension, MAP curve shifts to the right. Okay, mean arterial pressure curve. So this curve right here, it shifts to the right. uh, and chronic hypertension. Okay, because the pressure is going to increase in that, and it's no longer going to be between this and this, 60 and 160. Okay, because you have a higher systolic now, and diastolic is probably going to be the same. So if this top one goes up, that also increases this, right? The mean arterial pressure. So if that increases, this increases as well. So that will shift the curve to the right. That's why it shifts to the right. Carbon dioxide is a metabolic waste and require blood to remove it, so it makes sense that increase in carbon dioxide would increase cerebral blood flow. Brain doesn't mind increased oxygen, so it only reacts under severe hypoxia, that is less than 50 mmHg. So in hypoxia, brain will increase the blood flow as soon as the PO2 goes lower than 50. Okay, and that's what you see. Okay, so the cerebral blood flow, it's normal until 50, right? It's pretty steady, this thing. Okay, but as soon as it starts going lower than 50, or 60 in this case, the cerebral flow increases, right? Because this is the cerebral blood flow, so it increases as soon as it reaches like less than 50 and less than that. Whereas in PCO2, as this rises, the waste product of this rises, so does the cerebral blood flow, goes above as well, up till here, because then it can't keep up with it. Okay, and mean arterial pressure is from 60 to 160 normally, but in hypertension it shifts to the right, so it's gonna be like, I don't know, 80 to 180 or something. Okay, and that's because of a mean arterial pressure, right? So systolic blood pressure increases in that. So now that we have all this information, let's read this again. It relies on tight autoregulation, primarily driven by PCO2. PO2 also modulates perfusion in severe hypoxia, also relies on pressure gradient between the mean arterial pressure and intracranial pressure, right? So if you have increased mean arterial pressure, the gradient is going to go this way, right? So then the products from intracranial stuff, it's not going to come into the artery, it's going to rather go this way. So to prevent that, we keep the mean arterial pressure in the brain less than 160 at least, while it can regulate that, so that things can go into this and go out. So also relies on pressure gradient between mean arterial pressure and intracranial pressure. Decrease in blood pressure, so decrease in this, or increase in this intracranial pressure, will decrease cerebral perfusion pressure, right? Because now the blood coming in with the oxygen, it's not able to go into this, so it's low, and this is high, so it's going to push inwards, so the flow of the gradient is going to be into this. So now this is not able to perfuse the brain, right? So decrease in cerebral perfusion pressure, that's what it means. Cushing reflex. So Cushing reflex, this is because when brain starts to herniate, it pushes down on the vagus nerve, which in turn causes increase in blood pressure. Okay, so that's why you get hypertension. It decreases heart rate because of the vagus intervention to the heart, into the, what do you call it, the cardiac receptors that modulate that stuff. Okay, and respiratory depression, so that's Shan-Stokes breathing. If you don't know what that is, we'll look at that. It's respiration or rare abnormal breathing pattern that can occur while awake, but usually occurs during sleep. The pattern involves a period of fast, shallow breathing followed by slow, heavier breathing and movements without any breath at all, called apneas. Okay, so that's gonna look like that's apnea, hyperapnea. It's like that, or apnea and hyperapnea. So this is hyperapnea, so increased breathing, and this is decreased breathing. Okay, that's a better photo. Okay, so it's gonna be a waveform, like a crescendo decrescendo wave. Okay, so that's hyperapnea, so it increases breathing, and then there's shallow breathing on the end over there, and fast, right? So shallow and fast, or slow and deep. Okay, and then this is apnea, which is slow. Okay, so slow and fast, or high and slow. Sorry, fast and small, shallow, I mean, and deep and big, and then apnea, and that's stroke breathing. Okay, so that's what you get with this. Because of herniation of the brain, it pushes on the vagus nerve and does that. Herniation can occur due to hemorrhage and edema, okay, and etc. It can occur for various reasons, doesn't matter. Okay, hopefully that clears this up. Moving on to homunculus. I love this, and these questions are the easiest, and they do get asked a lot instead of something like basal ganglia or something, because they keep it simple. So homunculus is a topographic representation of motor and sensory area in the cerebral cortex. Distorted appearance is due to certain body regions being more richly innervated and thus having increase in cortical representation. Okay, so this is the motor side and this is sensory, but for our purposes they're similar anyways. So all the lower limb stuff is going to be in this area that gets perfused by anterior cerebral artery. So this area for the motor, same thing for lower limbs for the sensory. That's all you gotta remember. You don't need to bother reading into it, like toes, ankles, hip, because normally they're gonna be like, okay, there's a problem with right lower limb or left lower limb, right? And then you gotta figure out if it's left, it's gonna be something on the right. If it's right limb, then it's something going to be on the left. And if it's motor, then it's this side. And if they're saying that there's decrease in sensation for temperature or pain or tactile, something like that, it's going to be the sensory one, right? Okay, so anterior cerebral artery is perfusing this area of the cortex. Okay, and then you have the upper limb over here. Okay, and there's nothing for the posterior cerebral artery, so that's easy. So just have to remember that the foot, hip, and all that stuff is over here, and everything with the upper limb is middle cerebral artery. Okay, so if there's a problem, that means there is a clotting or thrombus, or there's some kind of occlusion over here, obstruction here, and that's what's causing problem with the motor or the sensory aspect of the knee, ankle, toes, or whatever, lower limb. Okay. Yeah, so pretty easy with that. So down here would be your lips, all the face stuff. This is upper limb stuff, and this is lower limb stuff. They don't go into details like this area is for ring finger or thumb for this area. They don't do that, so you don't need to bother memorizing that. Just memorize that this is the face area, this is the upper limb area, this is the leg area, the upper limb area, and the face area. Okay, moving on. Cerebral arteries, cortical distribution. Anterior cerebral artery supplies here, so it supplies the anteromedial surface. The medial cerebral artery supplies this area. Okay, supplies the lateral surface. Posterior cerebral artery supplies the posterior and inferior surface. Okay, so the inferior surface is supplied by that. Not that important. It kind of makes sense by itself, anyways. But they might ask you, okay, so temporal lobe on the outer side, what does it get supplied by, right? So then that gets supplied by the middle cerebral artery. But what about the inner side of the temporal lobe, right? That gets a little complicated, but I don't think they go into that much detail. So just remember it this way, and if it does, you'll figure it out in the question bank. It's okay. Watershed zones, these are important. You need to know about these, okay? So basically where it happens is right here between the communications, okay? So going from middle to anterior, between the anteriors, right, so right there, or between the middle and posterior, I think. Let's see, they'll tell us. Cortical border zone occurs between anterior and middle cerebral arteries and posterior and middle cerebral arteries, so areas in blue, right? So these are your posterior cerebral arteries, okay, and middle cerebral artery and the anterior cerebral artery. So between those two and between this, okay, so that's your cortical border zones. And the internal border zones occur between the superficial and deep vascular territories of the middle cerebral arteries, so the red areas right there. That's called the internal border zone. So common locations for brain metastasis is watershed area, influx due to severe hypoperfusion. Okay, so that will lead to infarction. That's, the same thing as myocardial infarction. When it doesn't get perfused, you get infarcts, right? Anterior cerebral artery and middle cerebral artery are the watershed infract. So proximal upper and lower extremity weakness. This is what you will get if there's an infract over here, okay? Again, that's anterior and middle. So somewhere here, right? So that's the upper limb and the lower limb, right? So if there's an infract somewhere here, the symptoms you'll see are proximal upper or lower extremity weakness. So proximal are your shoulders and hips, hips and shoulders, right? So somewhere here, if they say proximal upper and lower limbs, they're talking about shoulder and hips, and this is where the infract's happening, okay? So it's called men in a barrel syndrome. Why is it called that? It's because imagine a person sitting inside a barrel, and they can't use their hands or legs, and only their thorax is gonna be working. So you see how this is atrophied, right? So it's atrophied because of the syndrome. Okay. Don't confuse this one with the syringomyelia in a question stem if it comes. Syringomyelia, it was in the upper proximal areas and the upper limbs, right? Posterior communicating artery, cerebral artery and middle cerebral artery. So that's the watershed infract. Okay, so that's between this and this. So you have it over here, right? So if there's a problem here, you'll have something wrong with the face and face over here as well, right? So watershed infract, higher order visual disturbance, dysfunction. Okay, so visual dysfunction somewhere here, even though eye is over there, and where's eye? Eye is over here, but that still counts as this, okay? So basically you'll be asked to differentiate between this and this, so it's pretty easy. If it's something to do with the extremities, it's up there, right? Infracts over here. And if it's something to do with PCA and MCA, that's somewhere here, and high order visual dysfunction because of that. Okay, circle of Willis, system of anastomosis between anterior and posterior blood supplies to brain. Okay, so you have it starts with anterior cerebral artery, so that's this thing right here. Okay, that's a cerebral artery and that's an anterior cerebral artery, right and left. And the one communicating between the two is called the anterior communicating artery. Okay, and this one continues actually all the way here, so that's still anterior cerebral, and this is also anterior cerebral. Okay, it's just that there's a little bit of a bridge or communication between them, and that's called the communicating artery. Okay, then you have also, you need to know that the anterior communicating goes over this the optic chiasm. Okay, so if you remember optic chiasm, that's right over there, and that's what you're seeing, the anterior communicating over there, anterior cerebral over here. Okay, so the optic nerves are, going over here and over here, like that. So you need to know this in terms of landmarks as well. Then you have middle cerebral artery, okay, coming in from here into the optic chiasm as well. And this is given in from, it comes from the internal carotid artery, okay. So this is your internal carotid coming in up from here, from your common carotid artery, from the aorta, right? So external goes outside of the cranium, so that's why it's called external, and the one that goes into the cranium is called the internal carotid artery. It goes in over here, and it comes in and splits into the middle cerebral artery over there. Okay. The middle cerebral artery has the lenticulostriate artery, okay, because it's around the lenticular nuclei or lenticulate nuclei or whatever, and it's like this, so it looks like strias. So lenticulostriate artery over there, and then you also have anterior choroidal artery here, and you need to know that. That's an important artery. So it comes off of middle cerebral artery. Okay, so lenticulo and anterior cerebral artery, anterior choroidal artery. Okay, then the communication between the middle cerebral and posterior cerebral is called the posterior communicating artery. Okay, and then you have posterior cerebral artery over here. Okay, so that's this thing right here, or that. Okay, so that's the first part of the posterior communicating and the second part of it. Okay, yeah. Then comes the basilar artery. Okay, the basilar artery gives off these branches, so that's the basilar on top of the pons. So the artery that supplies the pons through the branches. So these are your pontine branches or pontine arteries. Okay. Between that and the posterior, you have cerebellar artery, right? Because this is the cerebellum. Okay. So on top of it, you have the superior cerebellar artery, and and right below the basilar one, you have the anterior but inferior. So why is it called anterior? Okay, so it's anterior to the cerebellum, right? This would be the posterior side. This is the anterior side, right? And this is the superior if you think of it in 3D like that. So superior cerebellar artery comes above the basilar artery. Basilar because it's at the base of the skull. Okay, that's why it's called a basilar artery. It's at the base of the skull. And it gives off the pontine arteries as well, so that's important. And then right below it, now, because if you think of a brain like that, then this is the anterior and inferior side, right? So anterior inferior cerebellar artery over there, and then you have the posterior inferior cerebellar artery. Okay, that's going this. So those are these going to the back, right? So they're going behind the medulla, anyways, to supply the back of the medulla into the cerebellum. So posterior inferior cerebellar artery, right there. Okay, and these are the vertebral arteries. Okay, that's this thing right there. It's coming from the vertebra, yeah. So it supplies the vertebra, right? So that's why it's called the vertebral artery. And they make another branch known as the anterior spinal artery, because between the vertebra you have the spinal cord, right? So a spinal artery goes there. uh yeah, and we're done. So review. You have anterior cerebral artery, middle cerebral artery, and the posterior cerebral artery. Middle and posterior cerebral artery are attached by posterior communicating. Two anterior cerebral arteries are attached by anterior communicating artery. Middle cerebral artery is made from internal carotid, and then it gives off three branches: one lenticulostriate, anterior choroidal, and anterior cerebral. Right, it comes from the middle choroidal, I guess, or I guess it's coming from internal carotid actually. So internal carotid goes into these. So internal carotid gives off this. So it gives off the anterior cerebral, the middle cerebral, and the anterior choroidal, and also this posterior communicating, I guess. Okay. Then you have, oh yeah, we need to know about this, that it's on top of the or under the optic chiasm. Okay, it surrounds that. Then we have superior cerebellar, anterior inferior cerebellar, and posterior inferior cerebellar. So right under the posterior cerebral comes the cerebellum. So superior cerebellar. Between superior and anterior inferior, we have basilar, because it's the base of the skull. It gives off the pons arteries, so pontine arteries to the pons. Then we have the vertebral arteries. They make the spinal artery, and the one all the way at the end are the posterior inferior cerebellar arteries. Okay, cool. Onto the venous sinuses. So dural venous sinuses, you have large venous channels, okay, that runs through the periosteal and meningeal layers of the dura mater. It drains the blood from cerebral veins. Okay, so these are the cerebral veins, all of these, and receives CSF from arachnoid granulations. That's the important part from this. Empty into internal jugular vein. So you have internal jugular vein here, and going from the jugular foramen. Sigmoid, because it's S, and that's known as sigmoid, right? From math. Then you have occipital sinus over here, and transverse sinus that transverses through this, area between the cortex cerebrum and the cerebellum. Okay. Then we have confluence of the sinuses, the transverse occipital and the straight sinus, right? So this is a straight sinus going into it, and this big huge one that goes through the sagittal sulcus is superior sagittal sinus. Main location of CNS returns via arachnoid granulation. And the straight sinus, great cerebral vein of Glen or Galen. And there's the inferior sagittal. So right under it, you have inferior sagittal. What is this? This is the communication going into the cavernous sinus over here. Cavernous sinus, this is sphenoparietal sinus. Okay, sphenoparietal sinus, because I guess it borders the parietal lobe. And then you have superior ophthalmic vein over there. Okay. They normally don't ask you and for anatomy questions to name these, but you should know about them. Okay. So large venous channel, that's what that is. Okay. Venous sinus thrombosis. It presents with signs and symptoms of increased intracranial pressure. For example, headache, seizures, and papilledema. That's increased pressure in the eye. Okay. So and that is caused by increased intracranial pressure due to any cause. The swelling is usually that. When palladium is found on a fundoscopy, further evaluation warranted because vision loss can result in underlying condition not treated. Okay, focal neurologic deficits may lead to venous hemorrhage associated with hypercoagulable state, for example, pregnancy, OCPUs, and factor V latent. That's the one where it doesn't listen to anticoagulant factors like protein C and S. Okay. So hypercoagulable states. That's how you end up with this. So when this happens, it's gonna block one of these areas, and then you'll see symptoms for infarct over there as well. Well, it's vein, it doesn't get drained, but same thing. It's not gonna, get rid of the carbon dioxide. So I guess it'll lead to headache, seizures, and when they say focal neurologic deficits, that's what it means. Focal neurologic deficits are, motor deficits for in ankles or toes or something like that. Okay. Ventricular system, we already went over these, but again, these are the lateral ventricles. This is your third ventricle, cerebral aqueduct of Sylvius, the fourth ventricle here, and the central canal of spinal cord here. This is the inferior horn. This is the anterior horn. Right there. Okay, inferior and anterior. The communication between these is called foramen of Luschka lateral aperture. Okay, and this is called cerebral aqueduct of Sylvius. Okay. So if you look at it from the side, this is the lateral ventricle, and the communication between lateral and third ventricle is this little foramen. It's called the interventricular foramen of Monroe. Okay, and then from here you go into the cerebral aqueduct of Sylvius. Then you have this over here. You have foramen of Luschka. That's the lateral aperture. And then you have foramen of Megandi or medial aperture. Okay, M for medial and lateral is for Luschka. Okay. So how does it flow? For CSF, how the flow happens is lateral ventricle goes to then it goes to the third ventricle via right and left interventricular foramen of Monroe. Third ventricle then goes to the fourth ventricle via cerebral aqueduct of Sylvius. Right, that's how it travels from that and then from fourth ventricle to subarachnoid space via foramen of Luschka if it's going laterally, and if it's going medially, it's going from foramen of Megandi. Okay. CSF made by choroid plexuses. Okay. Located in the lateral third and fourth ventricles. Okay, and these are your specialized ependymal cells, right? It travels to subarachnoid space via foramen of Luschka and Megandi and reabsorbed by arachnoid granulations. That's important. It gets reabsorbed in the arachnoid granulations, okay? And then it drains into the dural venous sinuses, so into these. Okay. Brainstem. This is important to understand and remember which part is where. Okay, so how would we do that? Let's go through this side. Okay, so if you remember your nerves, it's olfactory, optic, oculomotor, trochlear, trigeminal, abducens, facial, vestibular, cochlear, glossopharyngeal, vagus, hypoglossal, and accessory. Right, or accessory and hypoglossal, sorry. 11th is accessory. Okay, so olfactory is on top, and then comes your optic nerve, and then the third one, oculomotor, that is over here. Okay, and you have the fourth nerve, trochlear nerve, right? It arises dorsally and immediately decussates. Okay, so these are grouped into one, and they're known as the ones that are above the pons. So 4 cranial nerves that are above pons. So 1 olfactory, optic, oculomotor, and trochlear. Okay. And then you have 4 cranial nerves that exit the pons. Okay, so this is your pons right here. So you have your fifth nerve, right? So trigeminal nerve. So it has 3 branches: the ophthalmic, sorry, wait, ophthalmic, maxillary, and mandibular, right? Uh, that's the oculomotor. If I messed it up. Okay, so ophthalmic, maxillary, and mandibular. Okay, this one goes out of the pons. So don't confuse this, even though the picture shows it there, it's actually above the pons. Because if you were to, you know, hold this with your thumbs over here, then this is going to be above the pons, not in the pons coming out of it. Okay. So trigeminal nerve, and then the abducent. So sixth nerve is over there, coming out of the pons. And the seventh nerve is facial nerve, and the eighth nerve vestibulocochlear nerve, right? This is important because of the seventh nerve, or schwannoma, actually happens over there, at vestibulocochlear actually. Schwannoma, okay. It's a rare type of tumor that forms in the nervous system. Schwannoma grows from cell called Schwann cells. Schwann cells protect and support the nerve cells of the nervous system. Schwannoma tumor benign. But it can form anywhere. Okay, so brain, head, and that. Okay, it's gonna be related to the this thing. Okay, and they'll show you like one of them. They'll show you a photo of this, and then they'll show you, they'll ask you what's wrong with it, and then you gotta focus on the eighth nerve. Okay, vestibulocochlear nerve, and one side, or the contralateral side of the lesion, it's gonna be thicker than the other side. Okay, and it's gonna be because of schwannoma. Let me see. There's a specimen for it. Okay, something like that. So you would see it over here, right? You need to know where the pons is, and so you can locate the schwannoma, right? So up there, or yeah. Let me see if there's New World. Right there, right? They could give you a scan as well, or they could give you something like this, and you need to know where pons is, and then where you would see it. Okay. Yeah, that's Dandy Walker. But anyways, if you see it over here, you have bilateral schwannoma over there. Okay. Okay, so we did 4 cranial nerves that exit the pons. These are trigeminal, abducent, facial, and vestibulocochlear. Okay, that. And then you have 4 cranial nerves that are in the medulla. Okay, this is 9, 10, 11, and 12. Okay, so 9, 10, 11, and 12. These are coming out of, this is your medulla, by the way, so over there. Okay, however, the 11th one, which one is this? So this one right here, the 11th one, right? It's actually parallel to these, to the medulla. Okay, so it doesn't really come out of it, but it's at the level of medulla. That's why it's just, considered part of it, and it's grouped into that. So 4 cranial nerves are in medulla: 9, 10, 11, 12. because it's the accessory nerve. Okay, and forecranial nuclei are medial, so that's your 3, 4, 6, and 10. Factors of 12 except 1 and 2. You need to know which ones are medial and which ones are lateral, so that's why. We'll go over that as well. But remember at least these points. Which one goes above pons, which one exits the pons, and which one exits the medulla for now. Okay, this is the optic chiasm, the infundibulum, mammillary body is over here, pons is here, middle cerebellar peduncle is over here, pyramid and pyramidal decussation, and C1 over there. Okay. Brainstem, dorsal view. So cerebellum is removed from here, so you can see the brainstem. Okay, you have thalamus here. Between the thalamus, you have third ventricle. Right below the third ventricle, you have pineal gland, and this is the superior colliculus and inferior colliculus. Yeah, so this is what I was talking about. The superior one is for the eyes, and inferior one is because for the ears, and your eyes are above your ears, so you remember that way. Superior colliculus is eyes, and inferior is ears. Okay, and you have anterior wall of fourth ventricle. Superior cerebellar peduncle, that's the one, the fibers coming in from the cerebellum on the superior sides, right? Middle cerebellar peduncle, that's the one that's going from the pons into the cerebellum, and the inferior peduncle, that's the one coming from spinal cord into the cerebellum from the ipsilateral sides. And this is the medulla, and that's the anterior wall of fourth ventricle. Okay. Pineal gland, it secretes melatonin, and it's known for the circadian rhythms, right, or getting signals from SCN, suprachiasmatic nucleus or sun sensing nucleus. Superior colliculi, so direct eye movements to stimuli, right? Superior colliculi is because of is for the eyes. Movement to stimuli, so noise or movement or objects of interest. And then you have inferior colliculus, these are your ears, so auditory. Your eyes are above your ears, and the superior colliculus is above the inferior colliculus. Okay. Cranial nerve nuclei located in the tegmentum portion of the brainstem. Okay, between the dorsal and ventral portions. So they're just talking about this. I'll show you where that is on the brainstem. Okay. It should be somewhere here. Okay, so that's tectum, but we're looking for tegmentum. Okay, so this whole yellow thing is the tegmentum. Okay, it goes through the whole brainstem, not just the midbrain. So through the pons, through the medulla, and all that. Okay, so tegmentum is that. So it's located, cranial nuclei, nerve nuclei are located in the tegmentum portion of brainstem. Okay, because that's where the brain's, all the nerves are coming in. So it would make sense that the brain, the nuclei for these cranial nerves are somewhere here, right? And that's why it's in the tegmentum portion. 10 minutes, okay. Midbrain, nuclei of. So midbrain contains the nuclei for 3 and 4. That's oculomotor and trochlear. The pons contains for all the ones that, Okay, so it contains for 5, 6, 7, and 8. So these are the ones that come out of pons anyways, so that's easy to remember. Medulla nuclei are 9, 10, and 12. Because remember I told you that 11 is parallel to medulla. So spinal cord has the nucleus for 11th nerve, or the accessory nerve. Okay. Lateral nuclei is sensory, so LR plate, and medial nuclei are the motor ones. And this is important, basically. Okay. So I'll try connecting it with this. Hold on. Okay, so these are the lateral ones. Okay, and this is the basically sensory one, and the motor one is over here. Okay, so when the fibers come in from spinal cord, out of all with all these sensations and senses, it's gonna come through these. Okay, the ascending ones. Okay, so that's over here or over here. Okay, but either way, it's coming from the left and the right. Okay, so when it comes to the medulla, then it decussates to the other side, and then it goes to the nuclei and all that stuff. Okay, so it decussates at the tegmentum of whatever part the nerve is at. Okay, so when it comes from the lateral side. So sensories come from the lateral side, and then it does its thing. Then it goes to the corticospinal tract, the voluntary motor one, and then the motor one comes back into this, and then into the central canal, and then it goes down from there. Okay, or anterior cortical spinal, and it just brings it down there, and it either decussates over here, or it decussates at the level of the spinal root. Okay, that's why motor is in the medial part. Okay, so medial is motor, and lateral nuclei are sensory. And when we started this in the beginning, embryo, they told us sensory is the LR plate, right? And the medial is the basal plate. So that's where that comes from. Okay. Vagal nuclei, so nucleus, function, and cranial nerves. Okay. So there is nucleus tractus solitarius. See what that is. Okay. Chocolate, no, these are just that doesn't help. It's over here. Okay, that's where tractus solitarius is. Can't find a better photo, but okay, so tract is so tract and nucleus solitarius, so that's where that is, the inferior olivary complex. Okay, so nucleus tractus solitarius is visceral sensory information, for example taste, baroreceptors, gut distension, and may play a role in vomiting. Okay, so that's important. This is what we target with the drugs. So cranial nerves that go to it is 7, 9, and 10. So gustatory and taste ones, and the tongue ones basically, and that's where we read about it as well. Nucleus ambiguous. These are your motor intervention of pharynx, larynx, upper esophagus. For example, swallowing, plate, palate elevation. And then you have dorsal motor nucleus. That's it sends autonomic parasympathetic fibers to heart, lungs, and upper GI. So when we were reading about it, posterior most is supplied by the vagus nerve, and the palatoglossal is supplied by the 10th nerve, right? And palatoglossus is the one that arches the tongue during swallowing, so it makes sense that it's this one, right? And all the other one were supplied by hypoglossal nerve, or the 12th nerve, so that's not here. Okay, so palate elevation and that. So motor from nucleus ambiguous, solitarius as for sensory, so it's the vomiting center as well, and dorsal motor nucleus is this, and that's it. Let's take a break here. Cranial nerves and vessel pathways. These ones are really important. Not really important. It's just they might ask you on these, but I don't think I've came across questions really that much that needs you to know where the pathways or like anything of this sort. So you don't really get tested on it that much, but if you do, it's usually gonna be from these ones. Okay. Cribriform plate. That's cribriform plate of the ethmoid bone. So anterior cranial fossa through the ethmoid bone. You get olfactory nerve or the cranial nerve 1 from there. Then you have the middle cranial fossa. So over here you have optic canal, superior orbital fissure, foramen rotundum, foramen ovale, and foramen spinosum. Okay. So optic canal, you'll have the optic nerve and ophthalmic artery coming from there. But the nerve, it's the optic nerve from the optic canal. Then you have superior orbital fissure, right? So it's over here, right? So if it was like that, that's orbital fissure. And you have the ocular muscles supply coming from here. So lateral rectus, superior rectus, and other rectuses, right? So that's supplied by cranial nerve 3, 4, and 6. SO4, so superior oblique is supplied by the 4th nerve. LR6, so lateral rectus is supplied by the 6th nerve, and all the other ones are supplied by the 3rd nerve. So all of them come out of the superior orbital fissure. Okay. Along with that, you have the ophthalmic nerve as well, branch of the trigeminal nerve, right? So ophthalmic branch of the trigeminal nerve comes from there. Okay, so right there, so that branch right there is going into the superior orbital fissure. Then you have foramen rotundum. Rotundum is the one with the maxillary branch of the trigeminal. Okay, and you have foramen ovale. Ovale is like O, and that's like if you make a face, then that would be the mouth, and the mouth is the mandible. Half of it is the mandible, right? So mandibular branch of the trigeminal nerve comes from the ovale. Okay. And spinosum, foramen spinosum, it's like you spin an artery, right? You can spin an artery around. So middle meningeal artery comes out of the foramen spinosum. Okay. Then comes the posterior cranial fossa through the temporal or occipital bone. Okay. So you have internal auditory meatus, that's over there. Okay. From that one, you get the 7th nerve, the facial nerve, and the 8th nerve, the vestibulocochlear nerve. Okay, coming out of the internal auditory meatus. The jugular foramen, this is the important one. So cranial nerve 9, 10, and 11. Right, so that's glossopharyngeal, vagus, and accessory. And the jugular vein coming out of the jugular foramen, obviously. Okay, so that just leaves the 12th nerve, which is the hypoglossal nerve and hypoglossus nerve, and it comes out of the hypoglossal canal. So the 12th nerve. Okay. You have foramen magnum. The brainstem comes out of it, comes through it. The spinal root of the 11th or the accessory nerve, and the vertebral arteries that go through that as well, along with the spinal artery, I guess. That's made by the vertebral artery, right? That takes care of that. On to this, cranial nerve and arteries. So you need to know which one is associated with which. So if there's a problem somewhere here, and there's infraction, it might be affected the nerve nearby, something like that, right? You also need to know which ones are medials and which ones are the lateral ones. Okay, the medial and lateral. Okay, So let's keep a score of which ones are laterals and which ones are the medial ones. We have been told it's the multiple of 12 besides the 1 and 2, right? But let's see. So you have medial one, that's 3 and 4 and 6, right? And then 12. So multiples of that. So 3 times 4 will give you 12, right? 6 times 2 will give you 12, or 12 times 1 will give you 12. So besides 1 and 2, it's the multiples of 12. Okay, and lateral ones, that leaves 5, 6, 7, 8, 9, 10, and 11. Okay, so 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. Okay, that takes care of that. Alright, so medial one, as we know, we talked about it, it's the motor one, and the lateral one is the sensory one. Okay, so if there's a problem with sensory part of it, it's going to be the lateral. And if it's motor, something's wrong with the motor, it's going to be something with the medial ones. So when they say medial ones, it's going to be these nerves that are affected if there's a problem with the motor one. So the third cranial nerve, fourth or sixth, these ones are the oculomotor ones, right? Extraocular muscle supplying ones. And then the hypoglossal nerve over there. Okay, and if there's something wrong with the sensory aspect of your body, it's going to be one of these nerves, right? So the trigeminal nerve or the facial nerve or vestibulocochlear, 9, 10, and 11. Okay, and to understand this, there's a Dirty Medicine video that you should look at. This one, is by Dirty Medicine, strokes and the rule of fours. And before we start battle, you should watch this because it really helps you out with what we're going to do tomorrow. Okay, so now that's done, let's look at these. So anterior cerebral arteries, anterior communicating artery, ophthalmic artery over here, middle cerebral artery, internal choroidal, and then you have anterior choroidal, and you have this posterior cerebral over here. You have the cranial nerve here as well, the third one. The second one's over here, and the first one's over here. The basilar artery with the pontine, right? So pontine arteries are also known as the labyrinthine artery. Okay. Anterior inferior cerebellar. Okay, so it goes anteriorly, inferiorly to the cerebellum. Then you have the vertebral and the posterior, inferior, and anterior spinal. So you have the third nerve here and the fourth nerve over here. The trochlear one, the trigeminal is over here. That's not associated with any of that. But this one right here, all of these are associated to one another through the artery because they're right where the vertebral artery is as well, right? So you have the medial one, that's, what do you call it? Sixth nerve, okay? So when they say medial, they just mean, the medial aspect of this whole thing. So which ones are medial and which ones are on the sides. That's all it means. Okay. So lateral ones is on the side. So 7 and 8 over there. Then you have the 9, 10, and 11, right? And then 11 is over there. Okay. So you need to know about these, basically, right here. And normally they test you on the 7th nerve because of schwannoma or whatever. And which arteries would be, compressed because of a schwannoma. So it could be this, right, which is the vertebral artery. Or it could be this one, the anterior inferior cerebellar artery. Okay. Cranial nerves. So you can memorize it or just understand which one's which, and you don't have to bother memorizing it. So smell, right? Olfactory, cranial nerve 1, that's smell, so that's sensory. Only cranial nerve without thalamic relay to cortex. Okay, it's sensory. Optic is second nerve, that's sight, right? So that's also sensory as well. Oculomotor, we know that's third nerve. Third nerve supplies to the eye movement one, so that's a motor nerve, right? So it supplies the superior rectus, inferior rectus, medial rectus, and inferior oblique. Okay, and pupillary constrictor as well, accommodation for ciliary muscle, eyelid opening, and levator palpebrae. Okay, uh, yeah, so that would be motor. Again, trochlear, it's SO4 for superior oblique. That's what it supplies. So SO4 is again motor. Trigeminal, it has 3 branches, so it's bound to be mixed, right? So trigeminal nerve, mastication, we looked at it for the facial sensory for the anterior tongue, right? So sensory there, and mastication is motor, so you know it's mixed. So mastication, facial sensation, ophthalmic, maxillary, and mandibular divisions. Somatosensory, from somatosensation from the anterior 2/3 of the tongue. Dampening of loud noise, right? Tensor tympani is supplied by that too. Then LR6, so abducens applies the lateral rectus, sorry. And it's eye movement, so that's motor, right? And then facial, you know, facial has a lot of branches, so that's bound to be mixed as well. Facial movement, eye closing, orbicularis or oculi, auditory volume modulation, like it supplies to stapedius, that's the important one. Taste from anterior 2/3 of the tongue, that's important too. It's responsible for lacrimation, salivation, submandibular and sublingual glands are innervated by cranial nerve 7. Vestibulocochlear, that's 8th nerve, hearing and balance. Okay. Glossopharyngeal is 9th nerve, taste and sensation from posterior 1/3 of the tongue, swallowing, salivation, posterior gland, monitoring carotid body and sinus, chemo, and baroreceptors, and elevation of pharynx, larynx, and stylopharyngeus. So this is going to be your mixed one. Okay, I think I missed this one, so that one is sensory. Okay, hearing and balance, that's it. Glossopharyngeal is the tongue one, so it does both, right? It's sensory and the taste one. Remember when we were doing the tongue? So that's both. Vagus is going to be both as well. We see it everywhere for both sensory and motor, right? So taste from supraglottic region, swallowing, soft palate, elevation, midline uvula, talking, cough reflex, parasympathetics to thoraco-abdominal viscera, monitoring aortic arch, chemo, and baroreceptors. So mixed again. Accessory, that's the one that supplies the muscles, sternocleidomastoid. So then 11th nerve, head turning, shoulder shrugging. So sternocleidomastoid and trapezius are the ones that get supplied by accessory nerve. So those are muscles, so it's going to be motor. And then hypoglossal, that's the one that supplies the genoglossus, styloglossus, and hyoglossus. So it's involved in tongue movement, so that's motor as well. Right. This one's involved in palatoglossus, right? Soft palate elevation due to that. This is important. They do test you on this part right here. So cranial nerve reflexes, reflex, afferent and efferent. So accommodation is done by afferent, so it comes in from optic nerve. The information comes in via optic nerve, and so this one is gonna be sensory, right? And this one's gonna be motor nerve. So all the motor ones are gonna be this side, and sensory ones are gonna be on this side. So optic nerve is sensory, and third nerve is motor. Okay, so accommodation is that. Why? Because third nerve is innervating the ciliary muscles as well as the constrictor muscles. Okay. Then you have the corneal reflex, right? So that's the one where you touch a feather across the white part of your eye. That will be taken in by ophthalmic branch of the trigeminal nerve, so the nasociliary branch. And then the efferent ones are going to be the seventh nerve. So that's going to be the eyelid one, right? The seventh nerve. Okay, so eye closing one. So orbicularis oculi. So that's how you get the temporal branch of the seventh nerve, orbicularis oculi. So then it closes the eye. Okay, the cough reflex. This is the 10th nerve for afferent and efferent. Okay, so vagus. So vagus nerve is involved with the cough reflex. That's important to remember. It's also phrenic and spinal nerves. Okay, doesn't matter. But remember, vagus nerve is for cough reflex, afferent and efferent. However, gag looks, so G in gag looks like 9, right? So gag reflex is going to be 9th nerve for afferent, and efferent is going to be the 10th nerve. Okay. And that's because don't mess it up between these two. So that's why I used the mnemonic for that. So G looks like 9. So gag reflex is the afferent is 9th nerve, and the efferent is the 10th nerve. Cough is this and this. Okay. And then the jaw jerk. Jaw jerk is when you do a reflex hammer on you put a thumb in the middle of your jaw and then you strike it with a hammer at the back of your thumb and it does a jaw jerk. So afferent for that is the mandibular branch of the trigeminal nerve, right? And we know that it's mixed, right? So it's going to be that for that, as well as the motor is going to be through that as well. So it goes to the masseter. Lacrimation, so that's the one, the tearing one. It's from this B1. That's the ophthalmic branch of trigeminal. Loss of reflex does not preclude emotional tears. So if you have loss of reflex because of this, it doesn't mean that you don't have tears at all. You can still have tears because of emotional response. Okay. And efferent is the one that produces the tears or stimulates the thing, right? Okay, so afferent is B1 and 7 for that one. Now, important one here is cough and gag, and maybe corneal. Okay. Then you have pupillary. So afferent is again second or optic, and efferent is this as well. So we looked at that. Okay. Good to go to the next one. Muscles of mastication or mastication muscles. There are 3 muscles that close the jaw. So masseter, that's masseter. Temporalis, okay, so it goes through the maxilla, and then it goes through that, and then it comes out of here as well, but you don't see it. Okay. So 3 muscles that closes the jaw. So masseter, temporalis, and medial pterygoids. Okay, so these are your medial pterygoid, and then there's lateral pterygoid, which protrudes the jaw. Okay, so all are innervated by mandibular branch of trigeminal nerve, so that's easy to remember. Spinal nerve, there are 31 pairs of spinal nerve, 8 cervical, 12 thoracic, 5 lumbar, 5 sacral, 1 coccygeal. Nerves C1 to C7 exit above the corresponding vertebra. Okay. For example, C3 exits above the 3rd cervical vertebra, and C8 spinal nerve exits below the C7 and above T1. All other nerves exit below. For example, L2 exits below the 2nd lumbar vertebra. Fair enough. There's no, C9, so everything above between this will go above it, and between C8 and T1, right? So C8 spinal nerve exists below C7 and above T1. So there's no C8. So we just pretend like it's the one built between C7 and T1. Okay, C7 is the one that's popping out at the back of your neck, the one you can feel. That's the C7. So below that will start T1. Okay, for example, L2 exists below the second lumbar vertebra. Okay, spinal cord lower extent. Okay, so before we read this, uh, the layers that we go through when we pass a needle, um, we'll go over that. So skin is the first layer, then comes the fascia and fat. Okay, and then you have ligaments. So first ligament you come is the supra spinous ligament. Okay, so supraspinous ligament, because that's on the superior side of the spine. If you were laying down, and then you would see it from, so if you had a person facing down and then legs like that, and then those are arms, so he's facing downwards. So if you were to open up, cut this right here and then look at it from the side, so this is how it will look, right? So the superior side of the spine is the supraspinous ligament. Okay, and then you have the interspinous ligament below it. Okay, so that's between the supraspinous ligament and the spinal cord, so that's interspinous ligament. Okay, then you have the ligament of flavum. That's this one right here. That's a ligament as well, right? So that's the one that pops when you go through it. Okay, so again, you have skin, fascia, and fat, then supraspinous ligament, then the interspinous ligament, then the ligamentum flavum. Okay, so it pops. Now you're entering the space, right? So the first space you enter is the space above dura. So above dura, so that's epidural space. So epidural anesthesia, needle stops here. As soon as it pops, you feel the pop with the needle, you stop and you just apply the anesthesia over there, or you administer it there at the epidural space. Okay, if you go in further than epidural space, you'll meet dura mater, right? Through the dura you'll find subdural space, and then arachnoid matter, and arachnoid matter, under that you'll find subarachnoid space, right? And that's the space we collect CSF from. Okay, so it goes all the way here, and we try to do it below this, the conus medullaris, right? Because then you don't have chances of damaging the nerves, as these ones are important ones, and it's easier to damage them basically if you go above this line. Okay, so and all these little ones that you're seeing are the quada equina, and they all exit the spinal cord through the as phylum terminale, the terminal fiber. Okay, anterior longitudinal ligament over here, posterior longitudinal ligament over here. Remember, that's why you get a thicker, since you have a thicker one here. If you have compression in this, you send the gel or whatever it was, intervertebral process, I forgot what it's called, but it goes this way because this is thinner and this is thicker, so you get a radiculopathy because of that. Okay, okay, let's read that now. So spinal cord in adults, spinal cords and at lower border of L1 and L2 vertebra in adults. Okay, so subarachnoid space, which contains the CSF, extends to the lower border of S2 vertebra. Okay, so this is S2 right here. So lower border of that's from here to here. Okay, so lumbar puncture is usually performed between L3, L4, or L4 and L5, level of quada equina. Okay. Goal of lumbar puncture is to obtain sample of CSF without damaging the spinal cord. To keep the cord alive, keep the spinal needle between L3 and L5. And it's true because it's rhyme, it's rhyming, or it rhymes. Okay. So for L3 and L4, I think that's for adults, and L4 and L5 is for kids that we use. But either way, just to be safe, do it in L4 and L5 between that. Okay. Spinal cord and associated tracts. Legs, lumbosacral are lateral and lateral corticospinal. Okay, so these are the corticospinal, so they're just talking about that area. And sacral area is, part of the lower part of your body, and cervical area is part of your upper body. So that's what they're talking about. So the lateral part of this corticospinal is going to be for the lower limbs, and the cervical part is going to be for the upper limbs. Okay, so legs, lumbosacral, are lateral in the lateral corticospinal and spinothalamic tract. So this is spinothalamic tract. Again, this one is sacral, and this one is cervical. Okay, so sacral near the lower limb and cervical near the upper limb. Okay, thoracic spinal cord in section A. Okay, dorsal columns are organized as you are, so with hands at the side, arms outside, and legs inside. So here it's the opposite. The sacral part is on the inside, unlike this one's. These, right? They're like this. So you have this on the inside of these. Okay, so sacral on the inside and cervical on the outside. So the cervical and thoracic ones are known as fasciculus cutaneous. That's the one it gives off. Those are the fibers it gives off. Fasciculus cutaneous, so upper body and arms. And over here, it's called fasciculus gracilis, L for lower body, and that. Okay. So this is the central canal. This is the posterior horn. This is lateral corticospinal tract, right? That's the motor one. These are going to be your descending ones, the one that go into your spinal cord. Ascending ones are the ones coming in from your spinal cord into the brain. These ones are going from the brain into the spinal cord. Okay, so the ones that go from brain to spinal cord are the motor ones, right? So these are the motor ones, and the one coming in from the spinal cord to the brain are going to be your sensory ones. So these are all your sensory ones. Okay, sensory ones are lateral, medial ones are the motor ones. Okay, posterior horn, lateral corticospinal tract, anterior white commissure, right there, and anterior horn is this. Lateral spinothalamic tract is over here, and anterior is over here. This is the intermedullary column, sympathetic, T1 to L2 to L3, not important. And these are your dorsal ones, dorsal columns. Okay, so if you were to draw a picture of it, this is what it would look like. Okay, so since we have looked at these multiple times, I'll just go through it now. It should be fairly easy to understand. Okay, so starting from anterior spinothalamic tract. Spinothalamic tract is known for crude touch and pressure. Okay, so all of this is going to come through this, and the pain and temperature ones from depending on upper limb and lower limb is going to come from here. If it's upper limb, it's going to be on the inside, and if it's lower limb, it's going to be the lateral sides. Right? Sorry, lower limb is going to be the lateral sides, so lower ones. So it's called the lateral spinothalamic tract. Pain and temperature come from here. Okay, this one doesn't matter. This is the gray matter. The white part is the white matter. So dorsal column. So from the senses of pressure, vibration, fine touch, and proprioception, they come in from the spinal cord. If it's coming from the upper limb, upper body, it's going to be these ones, the thoracic and cervical. If it's coming from the lower body, these sensations, it's going to be over here, or fasciculus gracilis are the ones that bring it. Okay, then after it does that, it goes into the nuclei and all that stuff that it needs to do, right, into the brainstem from wherever it goes in, and then it crosses over it gets the signal coming back from the brain, and then now it's gonna go through this downwards. So it goes through the lateral corticospinal tract. Okay, so it takes the voluntary movements from here. Because what happens if it's involuntary movement? Involuntary movements are the reflexes that happens right at the level of the spinal cord through the dorsal root ganglions, right? That's why they differentiated that. So voluntary movement, so sacral and cervical over here, and then anterior corticospinal tract over here. That's also motor ones. Okay, so anterior horn, and the white stuff is the white matter. Gray one is this. Syringomyelin will push this downwards and press the tracts over here. So that's why you get decrease in pain and temperature senses in the upper limb and shoulders and proximal upper limbs, right? Okay, so now going into details with this one. We have 1, 2, and 3 pages. Or is that it? No, so we have 1 and 2 pages left. Okay. How much time do I have? Still have time. Okay. Spinal tract anatomy and functions. So spinothalamic tract and dorsal column, ascending tracts and ascending tracts, right? So let's bring this down here while we're talking about it. Okay. And also let's look at this bit right here as well. Okay, so spinothalamic tract, right? So let me do that over here instead. We'll talk about that one first. So function is pain and temperature. Okay. First order neuron, that's sensory. Okay. Nerve endings. So you have A delta, so that's the fast one, and C fibers, so that's the slow one. Unmyelinated, and these are myelinated. Of pseudo unipolar neurons in dorsal root ganglion. It leads to it goes into enters spinal cord. Okay, it goes into the spinal cord. Okay, so it comes from here, down here. It goes into the dorsal root ganglion, and then it goes on the side of the spinal cord, and that's where it attaches, right? So that's the first part. So that's the first synapse. It's at the posterior horn of the spinal cord. This is the posterior horn, so that's where it's showing. That's where the first synapse is happening. Then it actually decassettes. So decassettes just means crosses the spinal cord. Okay, so second order neuron, it decassettes in the spinal cord as the anterior white commissure. Okay, so it does that by going through the white commissure from here to here. Okay, so it decassettes in the spinal cord as the anterior white commissure. So then it ascends contralaterally. So it goes contralaterally to the other side, and then it ascends upwards through the lateral spinothalamic tract, right? Okay, so that's the second one, and then there's third one that's happening here at the thalamus, right? This is again just for spinothalamic tract, okay, and it's only for the pain and temperature ones. Okay, so it's gonna attach to the VPL, or what was VPL? Vibration, pressure, proprioception, light touch, and all that stuff, right? In the thalamus that we read about it. So it attaches over there. And third order neuron happens at it projects to primary somatosensory cortex. So remember, that's where the primary sensory cortex was, on the parietal lobe, when we were doing that. So that's where it's going. So it goes from here to here and decassettes at the level of the spinal cord. Okay, and that's important to remember because it's different decussessions happening for different things. Okay, so this one, so if there's a problem here on this side, or lesion on this side, anywhere in the brain, it's going to affect the contralateral limb, right? So if it's a lesion on the left side of the brain, you'll have problem with the right side of the limb, right? With their pain and temperature senses, and vice versa. Okay, on to dorsal ones, these ones. So these ones are responsible for pressure, vibration, fine touch, and proprioception. Okay, first order neuron. This is going to be hard to do. Let's make that smaller. Okay. So first order neuron, that's going to be sensory. Okay, so it's coming in from here. It's going through the dorsal root ganglion. It's going into the spinal cord, and then it ascends upwards into the medulla. And medulla is where it's gonna. That's where the tractus solitarius. It was near that area, right? Anyways, it's however going to where? So sensory nerve ending of pseudounipolar neuron in dorsal root ganglion. Right there, and then it enters the spinal cord, and then it ascends ipsilaterally. Okay, so this one was contralateral, this one's ipsilateral. Okay, so it's going ascending ipsilaterally into the dorsal columns. Okay, so into the dorsal columns of the medulla, I guess. Okay, because it looks similar to this anyways, so medulla. Okay, then you have first synapse happening there at the nucleus gracilis. Okay, and that's what they mean by that. Fasciculus gracilis is just that, part of nucleus gracilis. Okay, so first synapse happens at there, or nucleus cutaneous, or fasciculus cutaneous is the fibers that go into it. So ipsilateral medulla. Okay, it's still on the same side. Okay, then you have second order neuron that decussates in the medulla. So this one decussates through the medulla. Okay, so in the sensory ones, they decussate before they go into the brain. Okay, one spinothalamic happens at the spinal, and it's in the name, right? Going from the spine to the thalamus, so spinothalamic. Okay, and it decussates over there. Over here, it decussates in the medulla. That's the important thing to remember. Okay, and ascends contralaterally as the medial lemniscus. So medial lemniscus is just part of the group of fibers that go to the brain. Okay, so it's going to the thalamus, and that's where it happens again, VPL, right? So we read about that. That's vibration, pressure, light touch, and all that stuff. Third order neurons, it projects to primary somatosensory cortex. Over there again, same thing. Okay, we read about that over there as well when we were reading about thalamus. Okay, so one more time, it comes in dorsal root ganglion, it ascends ipsilaterally up to the medulla, then in medulla it decussates, and after decussates goes to the other side of the dorsal column, and then into the thalamus at the VPL nucleus, and then to the somatosensory cortex. Okay, so now onto the corticospinal tract. Okay, so we have corticospinal tract. That's the motor one, right? That's these ones. These are going to be the okay. So function is voluntary movement. Okay. Now first order neuron is upper motor neuron. So primary motor cortex descends ipsilaterally. Okay, so it comes from primary motor cortex area of the brain. It comes down all the way to the medulla on the ipsilateral side. Okay, so descends ipsilaterally through the posterior limb of the internal capsule and cerebral peduncle, and then it decussates at the caudal medulla. Okay, so there's a caudal medulla. It decussates on the other side, although there's still no synapses here. Okay, and that's important to note. Okay, so it's all just one fiber. So through the posterior limb of the internal capsule. If you don't remember that, let's look at internal capsule. We looked at it when we were doing basal ganglia. Okay, so this white part right here is internal capsule. Okay. That's what it looks like. Okay, so this is the posterior limb, this is the anterior limb, okay, and the genu. Okay, so through the posterior limb of the internal capsule and cerebral peduncle, it decussates at the caudal medulla, pyramidal decussation. So pyramidal is just the thickest part of the medulla, and it decussates through that. Okay, and it descends contralaterally. Okay, so it just comes down from there, and then the first synapse happens at the anterior horn of the spinal cord, or right there. The anterior cord is right there. Okay, so it comes in, and then it synapses over there. Then the second order neuron, this is lower motor neuron. It leaves the spinal cord from there, and the second synapses happens at the neuromuscular junction, where it will then send out the neurotransmitters to depolarize the muscle. And that's it. So it comes from the primary motor cortex, goes all the way down to medulla, decussates to the other side, still no synapses, all the way down here to the anterior horn, and that's where it will synapse. And then the second order neuron will go into the neuromuscular junction, into this. Okay, in this too, the third order neuron is to the somatosensory. Okay, this one decussates at the level of spinal cord in the spinal thalamic tract, and this one, in the dorsal one, it decussates at the medulla and goes to the other side of the dorsal column, and then it goes up above. Here it decussates again in the medulla, coming down, but it doesn't synapse. It's just one long fiber going like that. Okay. Clinical reflexes. So reflexes count up in order: main root, nerve root, and bold. These are important, but that's it. That's all they will ask you, if they do ask you. But normally this is what's important, because they'll tell you that there's 2+ reflex, and you'll think that's increased, but that's actually normal. Okay, so the normal is 2+, so anything lower than that is hypoactive reflex or absent reflex, or hyperactive reflex and then clonus. Okay, so reflex count up in order: main, nerve root, and bold. Achilles reflex, for example, these are your... Okay, so it's carried by S1 and S2. That's the one that it does. So S1, S2, buckle my shoe. Okay, so Achilles ones are right there. Patellar ones are the knee ones. So L2, L4, kick the door. And that's, I remember that one. So L2 to L4. Okay. Then you have biceps and brachioradialis. This is the important one. C5, C6, pick up the sticks. And C6 to C8, you lay them straight. So C6, C7, C8 are tricep reflexes. So C6, C7, C8, you lay them straight. Additional reflexes are cremasteric reflex. Okay, so that's the honeymoon one. L1 and L2 makes the testicles move. Okay, and anal wink reflex. So S3, S4, winks galore. Okay. Reflex grading: 0 absent, 1+ hypoactive, 2+ normal, 3+ is hyperactive, and 4+ is clonus. Primitive reflexes, so these are CNS reflexes that are present in healthy infant but are absent in neurologically intact adult. Normally disappear within first year of life. These primitive reflexes are inhibited by a mature developing frontal lobe. They may re-emerge in adults following frontal lobe lesions that leads to loss of inhibition of these reflexes. So with a frontal lobe lesion, that's when it will reappear in adults, but otherwise It's normal in infancy, but then it disappears in intact adult. It disappears within 1 year of life. So moral reflex, that's a cute one if you want to Google it. Moral reflex, it's a hang on for life reflex. So they abduct and extend arm when startled and then draw together, right? So if you just hold the person, actually, let me go look at it. If you hold the baby or infant in your arms, in your palms, sorry, and then you just drop the palm, that's what they will act like. Okay, so when you drop it like that, you hold them in the arm and then just drop your arms. So they will abduct their arms and then they extend it when startled. Okay, so you'll see that. Rooting reflex is a movement of head towards one side of the cheek or mouth is stroked. So nipple seeking, right? So that's how they find the nipple. When it abrases their cheek, their head moves towards it. Sucking reflex, sucking response when roof of mouth is touched. Okay. Palmar reflex is curling of fingers if palm is stroked. Plantar reflex is, this is an important one, dorsiflexion of large toe and fanning. So let's look at Babinski sign. Actually, let's look at that as well. So dorsiflexion of large toe and fanning. So what does that mean? So this is dorsiflexion, okay, and that's dorsiflexion of the large toe. Okay, so if someone strokes on the side of your foot right there, and it goes across like that, you'll see dorsiflexion. Okay, so dorsiflexion of large toe and fanning of other toes with plantar stimulation. Babinski sign is presence of this reflex in adult though, which may signify an upper motor neuron. Because normally when this happens in a normal person, you'll see the opposite of it. It goes down and then, they pull away. And this is actually doing a plantar flexion. Okay. So, write that. Plantar reflex, sorry. So in a person, normally this is what you would see, okay? But in someone who has upper motor neuron lesion, okay, and upper motor neuron lesion, is anywhere here up till here, right? So all of this is a lesion anywhere here is gonna be upper motor neuron, okay, or yeah, right? So primary cortex, motor cortex to this, at least it descends contralaterally. So up till here, it's all upper motor neuron, and this green one is the lower motor neuron. So anywhere here will lead to this. Okay. Fanning out of low toes and dorsiflexion of the big toe. Okay. So dorsiflexion of large toe and fanning of other toes with plantar stimulation. Babinski sign, presence of this reflex in an adult, which may signify a upper motor neuron lesion. And then there is gallant reflex. This is stroking along one side. This is pretty cool too, because babies are cute. So look at this one. So when you stroke him on this side, he's the whole body's gonna turn that way. Okay, so if you stroke it that way, the baby's turning this way. Okay, so that's basically what it is. Okay, so when you stroke it like that, this is going up, this is going that way, and the body is moving that way. That's called the gallant reflex. So stroking along one side of the spine while newborn is in the ventral suspension face down causes lateral flexion of lower body towards the stimulated side. Okay. Dermatomes are really handy and you should know them. It's pretty good to know them. It's helpful. So dermatome and characteristics, C2, that's over here. right? So posterior half of the skull. C3 is high turtleneck shirt. Diaphragm and gallbladder pain referred to this right shoulder by a phrenic nerve. So C3, 4, and 5 keeps the diaphragm alive, and that's important. Here we didn't see that. Okay. How much? 10 minutes. Cool. Okay, so that's an important one to remember. You don't need to remember this one. It's pointless. But this one is important because it has a significance to it. Okay, so C3, 4, and 5 keeps the diaphragm alive because phrenic nerve comes from there, and it refers the pain to the shoulders. Okay, C4, this is low collar shirt. Also, it's where the common carotid bifurcates as C4. Okay, that's C4. Okay, so that's the significance of that, of C4, but not of this for dermatome. C6, it includes the thumbs. So when you put up a thumbs up sign on the left hand, it looks like 6. So that should help you with the C6 one right there. T4 is at the nipples, so T4 at the T4 pore. It's also the place where trachea bifurcates. Okay, so trachea bifurcates at T4. So C4 is carotid, T4 is trachea, T7 is the xiphoid process right there. Okay, so at the xiphoid process, 7 letters in xiphoid. Remember the nipple though. T4 is the nipple. T10 at the umbilicus, belly button. Point of referred pain in early appendicitis. Then you have L1 at the inguinal ligament, right? So L1 or inguinal ligament, like that. Sure. So this is L1 right there. That's where the inguinal region is. Then you have L4. It includes the kneecaps. Okay. Down on all fours. So L4 is for the kneecaps. That should be easy to remember. Also at L4, up here, so right there. L4 is where the abdominal aorta bifurcates at L4. Okay, so abdominal aorta bifurcates at L4. So we did C4 for common carotid, T4 for trachea, and now L4 for abdominal aorta. Okay. S2, S3, S4 keeps the penis off the floor. Sensation of penile and anal zone. So you see S2 and S3 over there, and on the back, you see S3, S4, and I don't know, 5 over there too. But S2, S3, and S4 is the anal zone as well. Structures perforating diaphragm. So if you have a diaphragm, this is from I think GIT. It's just I put it here because we're talking about all the dermatomes. At T8 you have IVC, right phrenic nerve penetrating or perforating the diaphragm. At T10 you have esophagus, vagus, cranial nerve, 10 and 2 trunks. At T12 you have aorta, red, thoracic duct, which is white, and azygous vein, which is blue. So red, white, and blue. At T1 and 2, it's the red, white, and blue. Okay. Yeah, that's it. So T10, esophagus. That's the important one, and the 10th nerve. All right, and on to patho. So we'll continue this tomorrow. So watch this by tomorrow if you get the time, because it will help you follow along. Because I use this for strokes. Okay, so by dirty medicine and that. And Neuro. That's it. Patho, common brain lesions, area of lesion and complications. So if you have lesion in the prefrontal cortex, remember the cortex. Where that cortex at? Alright. So prefrontal cortex. That would be this area right here. So lesion over there, frontal lobe syndrome, disinhibition, hyperphagia, impulsivity, loss of empathy, impaired executive function, akinetic mutism, seen in frontotemporal dementia. So he's gonna lose all his inhibitions, so he's gonna have like a vulgar language. He's gonna, yeah, and he's gonna be impulsive and loss of empathy and basically disinhibition. So it's something like that. It's gonna be frontal lobe syndrome. Okay. Frontal eye field. Okay, that's this area. So lesion over there. It looks for the lesion. Okay, so basically, if this was a just normal eye and a lesion is on this side, the eyes are gonna be going towards the lesion. That's what it is. Okay, so eye looks towards the brain lesion that is away from the side of hemiplegia, right? So if the lesion is on this side, the contralateral side is gonna have hemiplegia, right? So it's gonna look towards it. So that's FEF. Okay, it's seen in middle cerebral artery stroke, right? MCA. When we did homunculus, we came across that bit. Okay, and then PPRF. This is the one that I was confused about, right? So what does it do? Before we go on, let's look at this one. So normally this is what you have for the eye. You get the signals coming in from the right frontal eye field. It comes here, and this thing right here is called the paramedian pontine reticular formation, PPRF. Okay, so what does it do when you want to look at left, right? So it's going to invoke the left lateral rectus. However, if you did lateral rectus for the right one, it would look the other way, right? So to have the medial rectus on the right side look left as well, that's what this one does through the sixth nerve, which then transfers to oculomotor nucleus via MLF. Okay, that's medial lateral longitudinal fasciculus. Okay, so that's MLF right there. Okay, and then it goes top to the oculomotor nerve nucleus, and then oculomotor nerve goes here. So LR6 is this one, right? So lateral rectus, sixth nerve, and the third one supplies to all the other ones other than the SO4. Right. So if there's a lesion here, it prefers to look the other way. So PPRF prefers to look the other way, whereas frontal eye field looks for the lesion. Okay, so eyes look away from the brain lesion that is towards the side of hemiplegia. So if you have a stroke on this side, the contralateral part is going to be hemiplegic, right? So it's going to look towards that side. So it's just, this dude right here, he has a stroke on this side, on the left side. So his right side of the body is going to be hemiplegic, right? So if it's looking towards the hemiplegia or away from the lesion, the lesion is in PPRF, paramedian pontine reticular formation. And if he looks towards the lesion, it's FEF, right? And away from the hemiplegia, that's frontal eye field. Okay. Then you have dominant parietal cortex. Okay. That's you get Gretzman syndrome. Okay, and that's easy to figure out because he won't be able to, do calculations right or even identify his fingers. Okay, so agraphia, acalculia, can't do calculations. Finger agnosia, that's Can't identify or name fingers touched by the examiner. Left-right disorientation as well. So right-handed people get left parietal cortex dominant lesion. Okay. So dominant just means people who use their right hand, they have a left-sided parietal cortex that's dominant. People who are left-handed have a right-sided cortex, parietal cortex dominance. Okay. So what happens when a right-handed person gets lesion in the right side of the cortex? That's non-dominant parietal cortex, right? So here you will have hemispatial neglect syndrome. It's agnosia of the contralateral side of the world. So they don't acknowledge it at all. Okay, so this is a famous picture of someone who suffers from this, and they were asked to draw a clock. So this is how they ended up drawing it, from 12 to 12, and there's nothing on this side, right? So something like that. There's also like if they're doing their shirt or something, they'll only be able to do it on the side of the lesion, and the other side of the lesion it's not going to be properly buttoned up, or it's going to be vague, or seem unkept. Kept. Okay. Okay. Basal ganglia. That was this thing that we spent some time on, right? So when you don't have, GPI inhibiting thalamus, or continuously inhibiting it, you get tremor at rest, right? So a lesion over here, anywhere, you will get tremor at rest, chorea, ethystoses. It's seen in Parkinson's disease and Huntington's disease. Okay. Subthalamic nucleus. This gives you subthalamic nucleus, so the green part. So when you don't have that, you won't be stimulating GPI, and if you don't stimulate GPI won't give off GABA, or the inhibitory neurotransmitters to the thalamus. So thalamus is not being inhibited anymore. So that's how you end up with the contralateral hemibolismus. Okay. Subthalamic nucleus, contralateral hemibolismus. Right. So mammillary body. If it's bilateral lesion, you get Wernicke-Korsakoff syndrome. It's due to thiamine deficiency. Okay. Then we have amygdala. That's bilateral lesion, which leads to Culver-Bushy syndrome. Okay. So remember, it's part of the limbic system. So disinhibition. So you'll have hyperphagia, hypersexuality, hyperorality, seen in herpes simplex virus 1 and syphilitis. Need all limbs to do 5 Fs: feeding, fleeing, fighting, feeling, and fucking. Okay. Hippocampus. A way to remember what hippocampus does is hippos can't make new memories of us. Right, so hippo can't make new memories of us. Like that. Okay. Bilateral lesions. It leads to anterograde amnesia. So no new memory formation. It's seen in Alzheimer's disease. Okay. Dorsal midbrain. So you get the Perinod syndrome with this one. So it's often due to pineal gland tumor. Okay, so what is Perinod syndrome? It's compression of the dorsal midbrain, triad of upward gaze palsy, convergence retraction nystagmus, and light near dissociation. Okay. That's usually what they'll give you in dorsal brain. Dorsal midbrain lesion, so that's why I added it. Reticular activating system, that's reduced levels of arousal and wakefulness, coma. Okay, so the reticular activating system is a bundle of nerves that sits in your mid brainstem, right? So reticular is net-like or mesh-like. Okay, so it's just a network of that sitting in the mid brainstem, and its job is to regulate behavior, arousal, consciousness, and motivation. So when there's a lesion in that place, you get the opposite of that. So reduced level of arousal or wakefulness and coma. MLF, we just looked at that. That's this thing right here telling the right eye to look to the left when you're looking at the left. Right, so lateral rectus for this will give off fibers to this and signal for this one to look to the left, so contracting the medial rectus. Okay, so MLF, internuclear ophthalmoplegia, impaired adduction of ipsilateral eye. Okay, so if this one is looking, the lesion is on this side, right side, this one is not going to be able to adduct, right? So if you're looking to the left, this eye is going to look to the left, you get the lateral rectus contraction, but no right medial rectus contraction because of impaired MLF. Okay, so internuclear ophthalmoplegia, impaired adduction of ipsilateral eye to the lesion, nystagmus of the contralateral eye. So you'll get nystagmus of this eye with abduction. Okay, so this one's abducting while this one's supposed to adduct, but no, not gonna happen. It's seen in multiple sclerosis. Okay, cerebellar hemisphere, intention tremor, and this way. Sorry. Cerebellar hemisphere, intention tremor, limb ataxia, loss of balance, damage to cerebellum. It leads to ipsilateral deficits, fall towards side of lesion. Cerebellar hemispheres are laterally located, so it affects the lateral limbs. Okay. And cerebellum is known to do balance and all that stuff, so a problem with that will give you ataxic gait. Cerebellar vermis, you get the truncal ataxia. Okay. White base drunken sailor gait. Okay, so you get ataxic gait with this one. Nystagmus and difficulty speaking or dysarthria. Degeneration associated with chronic alcohol overuse. Vermis is centrally located and affects central body. Okay, so good enough. Abnormal motor posturing. So if you can have decorticate or flexor posturing, or you can have decerebrate extensor posturing. Okay, so if it's decorticate or flexor posturing, you have core in it, so the hands are going to go towards the core. Okay. Site of lesion is above red nucleus, above often cerebral cortex. For that, we need to know where red nucleus is. Okay, so that would be the red nucleus over there. Okay. Trying to find a better photo. The midbrain. Okay, so if you were opening up from, or you took off the cerebellum and then you're looking at it from the down here, so it's that area right there, right under the optic chiasm, right? So this area where you would have the brainstem coming in, right under this, so right there would be the red nucleus. Okay, so it's above red nucleus, often the cerebral cortex. So that's important. Okay, it's not part of the midbrain or brainstem. Okay. Overactive tracts, rubrospinal and vestibulospinal tracts. Presentation, upper limb flexion, lower limb extension. Okay, so that's what you're gonna see. You're gonna see upper limb flexion and lower limb is extension. Okay. Notes: your hands are near the core. Okay. And then you have decerebrate extensor portioning. Okay. Site of lesion is between red and vestibuli nuclei. Okay, so we know where the red one is, and now we need to know where vestibular is. Okay. So vestibular is like the seventh nerve, so it should be like somewhere in the pontine region. Retrovestibular nuclei, right? So right over there. So this is the pons, right? This thing. This is the midbrain, brainstem, medulla. So where the pons is where you have that. Okay. So it's going to be somewhere in the middle over there with the fibers going through it, between the red and vestibular nuclei in the brainstem. Okay. Overactive tracts are vestibulospinal tract. Presentation here, you will have upper and lower limb extension. Notes: worst prognosis. You celebrate birthdays standing up. Okay, so like that. If this doesn't work for you, then you can remember it that way, because this is fully extended. So you need to know if someone's doing this in the question stem. This is the presentation. Then what kind of injury it is, where the lesion is, right? So it's going to be above the red nucleus. And for this one, it's going to be between red and vestibular nuclei. Ischemic brain disease and stroke. Irreversible neuronal injury begins after 5 minutes of hypoxia. Most vulnerable: hippocampus, CA1 region, neocortex, cerebellum, Purkinje cells, watershed areas. Vulnerable hippos need pure water. Okay. So that's important. Most vulnerable ones are the hippocampus, neocortex, and cerebellum. So that's important to remember. Okay, and the watershed areas, obviously. Okay. Stroke imaging, non-contrast CT to exclude hemorrhage. Okay. Because if it's hemorrhage, then we can't give TPA, right? Because if it's hemorrhage, there's whatever minimum amount of clotting that's happening. If you give TPA, it's gonna unclot that stuff, right? It's gonna break it down, so it's gonna worsen the hemorrhage then. So we gotta make sure that the stroke is not because of hemorrhage. Okay, so non-contrast CT to exclude hemorrhage before TPA can be given. CT detects ischemic changes in 6 to 24 hours. Diffusion weighted MRI can detect ischemia within 3 to 30 minutes. Embolus can be found in the brain from the legs in ASD, right? So how would you get a embolus coming to the brain from deep vein thrombosis in the leg? It bypasses the lungs via atrial septal defect, and that's how you end up with it in the brain. Okay. So time since ischemic event, histologic features, 12 to 24 hours. It's okay. So in one day, you'll have eosinophilic cytoplasm plus pycnotic nuclei. So remember pycnotic, it's fragmentation, I think. No condensation. Okay, so irreversible condensation of chromatin in the nucleus of cell undergoing necrosis and apoptosis. Okay, so in the next day, it's gonna be necrosis plus neutrophils. So eosinophil comes first everywhere. Then you get the neutrophils. Then you get the macrophages. Right. So 24 to 72 hours necrosis and neutrophils. 3 to 5 days you get macrophages, macroglia. In this case, because CNS macrophages are called macroglia. 1 to 2 weeks, you get reactive gliosis, astrocytes, plus vascular proliferation. And then more than 2 weeks, you get glioscar. Ischemic stroke, ischemia, infarction, and liquefactive necrosis. 3 types. Thrombotic, due to a clot forming directly at site of infarction, commonly the middle cerebral artery, usually over a ruptured atherosclerotic plaque. Okay, so that's how you get the thrombotic one. Embolic one, it's due to an embolus from another part of the body. So we just talked about that over here. I should just bring that up here then. Oops. I broke my thing. Hold on. Okay. Embolic. It's due to an embolus from another part of the body. Can affect multiple vascular territories. For example, atrial fibrillation. It can happen because of that. It can happen because of carotid artery stenosis, deep vein thrombosis with patent foramen ovale, paradoxal embolism, and infective endocarditis. Hypoxia, it's due to systemic hypoperfusion or hypoxemia. Common during cardiovascular surgeries, tends to affect watershed areas. Treatment is TPA. If right, so TPA was this thing right here, right? Converts plasminogen to plasmin, and plasmin breaks down the uh, clot or the plug or whatever into this, right? So if it's any of these, it can do that. So, but first you gotta make sure it's not hemorrhagic stroke, right? So TPA if within 3 to 4.5 hours of onset and no hemorrhagic risk of or risk of hemorrhage, and or thrombectomy if large artery occlusion occurs. Reduce risk with medical therapy, for example, aspirin and clopidogrel. Okay. This is ADP. Was it ADP one? It was the platelet thing, but I can't recall it right now. The ADP receptor one, or was it the other one? Let me just go make sure. Yeah, okay. So ADP receptor, clopidogrel, prasugrel, and all that stuff. Cool. 529. Okay. So you can give that to prevent the platelet aggregation. Okay. So reduce risk with medical therapy, for example, aspirin, which blocks the thromboxane or COX, right? And clopidogrel to prevent platelet aggregation or formation of clot. Optimum control of blood pressure, blood sugar, lipids, smoking cessation, and treat conditions that increase risk. For example, atrial fibrillation and carotid artery stenosis. transient ischemic attack or TIA. It's a brief, reversible episode of focal neurologic dysfunction without acute infarction, negative MRI, with the majority resolving in less than 15 minutes. Ischemia, for example, embolus, small vessel stenosis, may present with amaurosis fugax. Transient visual loss due to retinal artery emboli from carotid artery disease. Fair enough. The thing about transient ischemic attack, it causes episodes of focal neurologic dysfunction. Okay, so for a while they're gonna feel it, and then they'll say that there was transient visual loss as well, right? But then after a while, like 15 minutes, and the person's okay. So that's how we differentiate between TIA and a stroke. Whereas a stroke will be more, it's still going to be focal, I guess, but it's not going to resolve in 15 minutes. Okay. It's due to retinal artery emboli from carotid artery, this thing, the transient visual loss. Okay. Cerebral edema, it's fluid accumulation in brain parenchyma that leads to increase in ICP. Types are cytotoxic edema, intracellular fluid accumulation due to osmotic shift, for example, sodium potassium pump dysfunction, which leads to increase in intracellular sodium. Okay, so intracellular fluid accumulation due to osmotic shift. It's caused by ischemia early, hyperammonemia, SIAD. Vasogenic edema, that's extracellular fluid accumulation due to disruption of blood-brain barrier. It increases permeability caused by ischemia, late trauma, hemorrhage, inflammation, and tumors. Also mannitol, right? So it's caused by that too. So all of these will cause increase in ICP. Effects of stroke. Okay, so artery, area of lesion, symptoms and notes. Anterior circulation. Okay, so anterior cerebral artery. So if there's a problem with the anterior cerebral artery, we know where that is, right? It's all when we did the homunculus. Where that homunculus at? This part. Right. So if you watch the video, Dirty's video, he tells you there are two types of stroke. One, it's gonna be cortical, or the other one's gonna be brainstem, right? So this is the one with okay, hold on. Actually, let me open that up. Okay, so stroke can be cortical or brainstem. If it's cortical, it's going to be focal, right? So it could be this, a stroke here or here, and depending on where it is, you'll see the symptoms associated with that area, right? So ACA is associated with the lower limbs, right? So you'll see motor and sensory cortices, lower limb. That's where anterior cerebral artery goes. So there, the symptoms are going to be contralateral paralysis and sensory loss, lower limb, and urinary incontinence. Okay, so when you get in urinary incontinence and it's neurogenic reason, you'll figure out that it's not due to stress or or UTI or something, right? So then that leaves neurogenic bladder. So that means it's something to do with CNS, right? And then if you get lower limb, so say there's weakness on the right side of the lower limb, it's gonna be something wrong with the left side of the brain, right? Because it decassettes the motor fibers, uh, right? And we looked at that over here. It decassettes at the medulla, so if if the problem is with the left limb, it's because there's a problem with the right brain, right? So it causes that and goes there. Okay, so that's why it's the contralateral one. Okay, middle cerebral artery. So that's all your upper limb and face ones, right? So motor and sensory cortices, upper limb and face. Temporal lobe, it's gonna be Wernicke's area. Okay, uh, if you get a lesion in temporal lobe, you'll affect the Wernicke area, and if you affect there's a lesion in the frontal lobe, you get the Broca's area. Okay, so what are you going to see? So contralateral paralysis and sensory loss of lower face and upper limb. Okay, so lower face, why not upper face? Because upper face receives intervention also from the ipsilateral side of the brain. So that's why it takes care of that. But the lower brain gets intervention from the contralateral side of the brain. And we'll do that in Bell's palsy. Okay, of upper limb. Aphasia, if in dominant, usually left hemisphere. Okay, so because everyone's right-sided, right-handed, right? So left would be the dominant one. So you get aphasia in that. Okay, and aphasia is loss of ability to understand or express speech caused by brain damage compared with aphonia. Okay, hemi-neglect if lesions affects non-dominant, usually right-sided hemisphere. Okay. So that's similar to what we saw over here. Okay, so that's hemispatial neglect syndrome on the non-dominant side if it affects that. Okay. I'm just trying to figure out this. Hold on, give me a second. On the contralateral side, right? So if the lesion is on this side, they're gonna ignore everything on this side. Okay. Wernicke aphasia is associated with right superior quadrant visual field defect due to temporal lobe involvement. Okay. So with right superior quadrant visual defect. Cool. Lenticular striate artery. So that one comes out of middle cerebral artery, right? So it supplies the striatum and internal capsule. So a problem with that, you'll have contralateral paralysis, absence of cortical signs, for example, neglect aphasia and visual field loss. Okay, so neglect aphasia and visual field loss. I don't think you'll have to, go into details like that. They'll give you something, and usually the answer is going to be either this, or right or left side, and something like that. But if they tell you, I don't know, questions might be getting harder now that it's pass and fail, so they might get it into details with these. Poor motor stroke. Pure motor stroke, most common location of lacunar infarcts due to microarthroma and hyaline arteriosclerosis, secondary to unmanaged hypertension. Okay. We'll do these, but just remember that this one causes lacunar one. So lenticular makes lacunar one. And that's lacunar right there. Okay, it looks like a half a moon. That's why lacunar. Okay. Bring that up there. Okay, so middle cerebral artery one was this, right? A. And then B is the lacunar influx over there. We'll read about that in detail after. Posterior circulation, so somewhere here, right? And Dirty went over that too. Where'd that go? So if it's on this side of the thing, it's gonna be, what was it? Something deep. Hold on. Okay, it was something there, and oh, posterior deep artery, I guess, and anterior choroidal over here. Then goes into talking about what happens because of it. Okay. Anyways, so posterior cerebral artery is the occipital lobe, right? So you're gonna get something to do with that. So contralateral hemianopia. So yeah, with macular sparing. Alexia without agraphia, because of dominant hemisphere extending to splenium of corpus callosum. Okay, so alexia is when the inability to see words or to read caused by defect of the brain. And then you have agnosia. Okay, so that is a neurologic condition characterized by the inability to recognize the faces of familiar people. Okay, if it's in the non-dominant hemisphere. So if they can recognize the faces, it's non-dominant hemisphere of the posterior cerebral artery. If it's the dominant one, it's gonna be alexia without agraphia. So they can write it down, but they can't read what they wrote. And they'll also have contralateral hemianopia with macular sparring. Okay, so blindness of half of the field, the contralateral side. Basilar artery. So basilar artery was the one in the base of the skull, right? So it was giving off pontine arteries and arteries to the medulla and lower midbrain. So pons, medulla, lower midbrain, corticospinal and corticobulbar tracts. And let me get the circle of Willis down here too. That's it. Yeah, right there. Actually, let me get a better one. This one's better. Okay. So basilar artery, that's this thing right here, right? On top of the pons, medulla, and lower midbrain. So it's gonna also supply to the corticospinal, that's the motor area, and the corticobulbar tracts. Ocular cranial nerve nuclei, paramedian pontine reticular formation as well. So PPRF, right? It prefers to see the other side of the lesion, so towards the contra hemiplegia. Right. So what are you going to see? If RAS is spared, so retinal are, what is RAS? I hate when they do this. I can't function. I think that's it. But if RAS is spared, consciousness is preserved. Okay. Quadriplegia, loss of voluntary facial except blinking. Okay. Okay, so quadriplegia, loss of voluntary facial except blinking, mouth and tongue movement. So they can do that stuff. They can blink, they can move the tongue or mouth, but everything else. Oh, never mind. They lose everything except for blinking. Oh, I think there was an episode of uh, this locked in syndrome in House MD. It was pretty interesting. Loss of horizontal but not vertical eye movement as well. Okay. So locked in syndrome is because of basilar artery. Okay. Anterior inferior cerebellar artery. So anterior inferior is this one, right? That's superior cerebellar artery. This is the anterior inferior, and this is the posterior one right there. Okay, so anterior inferior cerebellar artery, facial nuclei, facial nerve nuclei. That's where you find it. You find it at vestibular nuclei, spinal thalamic tract, spinal trigeminal nucleus, sympathetic fibers, middle and inferior cerebellar peduncle, and inner ear. The symptoms you'll see if this one is affected: paralysis of the face, lower motor neuron lesion versus upper motor neuron lesion in cortical stroke, uh, decrease in lacrimation, decrease in salivation, decrease in taste from interior two-thirds of the tongue, vomiting, vertigo, nystagmus, decreased pain and temperature sensation from contralateral body, ipsilateral face, ipsilateral Horner syndrome, ipsilateral ataxia, and dysmetria. Ipsilateral sensory neural deafness and vertigo. So lateral pontine syndrome, that's facial nerve nuclei effects are specific to anterior inferior cerebellar artery lesion. So that's all you gotta remember about this one. All the other ones, it could be anything, and it doesn't really pinpoint to this. But what does is when the facial nerves are affected only. Okay, so lateral pontine syndrome, that's what it's called. Supplied by labyrinthine artery, a branch of AICA. Posterior inferior cerebellar artery, that's this one down here, between the 9, 10, 11, and 12 nerves. Okay. So nucleus ambiguous, cranial nerve 9, 10, and 11. I guess not 12. Vestibular nuclei, lateral spinal thalamic tract, spinal trigeminal nucleus, sympathetic fibers, and inferior cerebellar peduncle. Right? So the lower part of the cerebellum. Symptoms are going to be dysphagia, hoarseness, decrease in gag reflex, hiccups, vomiting, vertigo, and nystagmus. Decrease in pain and temperature sensation from contralateral body, ipsilateral face, ipsilateral Horner syndrome, ipsilateral ataxia, and dysmetria. Here you end up with a lateromedullary syndrome. Okay. Lateromedullary syndrome. So nucleus ambiguous effects are specific to Picas lesion. So don't pick a lame. So lateromedullary, horse that can't eat. Okay, so hoarseness is dysphagia, hoarseness, and decrease in gag reflex and hiccups. These are classic presentation of Pica syndrome, okay, or lateromedullary syndrome. And if you looked at the video, right, the dirty one, where'd it go? He goes on to telling you how to differentiate between them, right? So if it's cortical, it's the focal one. If it's brainstem, it's going to be diffuse. Okay. So rules of 4. So wait, there's one more. You look at the midline nerves. So midline nerves were 3, 4, 6, and 12, and the lateral ones were 5, 7, 8, 9, 10, 11. Okay, so if they tell you that there's a problem with the let's see, the 12th and 11th nerve or the 10th nerve, right? So 11th nerve is accessory, so that would be trapezius and sternocleidomastoid. So something wrong with that. So that's going to tell you that it's one of the lateral nerves. So lateral nerves are part of the sensory ones, right? So these are the lateral nerves. So lateral nerves will give off sensory ones, and the medial ones are the motor ones. And we talked about that in detail before too, because motor ones go from the middle, and the lateral ones are ascending ones. So they're bringing in the sensory ones, right? Sensory signals, and that's why it's like that. So you don't have to know these names. You just gotta know if it's right or left, which nerve is affecting what, and then where does the nucleus of that nerve rely or are based in, and then that part of the thing. So if it's these, it's gonna be medulla, right? That's why it's the lateral medullary syndrome. Okay. Anterior spinal artery, that's this one right here, between the two vertebral arteries. Corticospinal tract, medial lemniscus, caudal, medulla, and hypoglossal nerve. Contralateral paralysis, upper and lower limbs. Decrease in contralateral proprioception. Ipsilateral hypoglossal dysfunction. Tongue deviates ipsilaterally. Okay. So medial medullary syndrome caused by infarct of paramedian branch of ASA and or vertebral arteries. Okay. So for sensory ones, you can have something affecting the spinothalamic tract, the pain and temperature one, or spinocerebellar tract, the RAM, or sympathetic chain, dilation, sweating, etc., and sensory cranial nerves. Okay. For the motor ones, it's the motor nerves, nuclei of the cranial nerves, medial lemniscus, so that's the dorsal one. Right, so dorsal one is the proprioception vibration one. Motor tract of the upper motor neuron, that's the one that's going from the thalamus to the no, from the cortical spinal tract. Okay, so that's that one. My bad. Cortical spinal tract, that's the motor one, and the medial longitudinal fasciculi. So that's MLF. That's the one that tells the eye to look to the left. The right eye, while the left eye is also looking to the left with the lateral rectus. So it, invokes the right medial rectus. Okay. So contralateral paralysis, upper and lower limb, decrease in contralateral, and all that stuff. Okay. C was what? Kind of missed looking at that. So occipital lobe. Okay, so infarct in that, and then D is lateromedullary one. Okay, let's get at that and that. Neonatal intraventricular hemorrhage, bleeding into ventricles. Arrow in A, like that, shows blood in intraventricular spaces on ultrasound. Increased risk in premature and low birth weight infants. It originates in germinal matrix, a highly vascularized layer within the subventricular zone. Due to reduced glial fiber support and impaired autoregulation of BP in premature infants. Okay, so that's why it leads to this. So it's due to reduced glial fiber support, and impaired autoregulation of BP. Remember the 60 to 160 thing in premature infants. Can present with altered level of consciousness, bulging fontanelle, hypotension, seizures, and coma. Okay. Let's take a break here. Intracranial hemorrhage, epidural hematoma. That's okay. So for intracranial, it can be epidural, subdural, or subarachnoid, or intraparenchymal. Okay. So each one there are differentiating factors, so it will help you differentiate which one it is. If it's on the okay, so let's read this first. A rupture of middle meningeal artery, branch of maxillary artery. Okay, we came across that when we were reading something. Often secondary to skull fracture, circle in A. So there's a fracture over there involving the pterion, and this is important. If you have an epidural hematoma, they give you a scan of this. They'll ask you, which place would possibly the fracture be in, right? And it's going to be pterion, and you need to know where that is. Let's look at that. So it's that area right there. It's where all the sutures are, coming together. So that's called pterion. Okay. Over there. So involving the pterion, thinnest area of the lateral skull, might present with transient loss of consciousness, which leads to recovery or lucid interval, and then rapid deterioration due to hematoma expansion. So transient loss of consciousness, then they recover. So this is the lucid interval, and then they get worse rapidly. Okay, and that's the presentation of it. Scalp hematoma. So arrow in A again. Okay, so you see how there's clear over here, but then a little bit of blood you can see over here. So that's the scalp hematoma, because blood is leaking out from here, middle meningeal arteries. Okay. So scalp hematoma and rapid intracranial expansion. Arrow in B. So that under systemic arterial pressure, transtentorial herniation, cranial nerve 3 palsy as well. Why? Because we'll do that when we're doing herniation somewhere. But basically, cranial nerve 3, it's part of, it's right above pons, right? So it gets squished when this is pushing towards it. It gets squished over there. That's why you get the palsy. CT scan, biconvex, lentiform, hyperdense blood collection. B, like that. It does not cross the suture lines, and that's the differentiating factor with subdural hematoma. That one crosses, I guess, but this one doesn't. Okay. Subdural hematoma, rupture of bridging veins. It can be acute, traumatic, uh, high energy impact, which leads to hyperdense on CT, or chronic, associated with mild trauma, cerebral atrophy, increase in age, chronic alcohol overuse. This will give you hyperdense on CT. Also seen in shaken babies, and that's important to remember. That's where you would see it. Rupture of bridging veins, right? So small veins right there, and the subdural, right? So subdural space, I guess, right before arachnoid. And arachnoid is it's called arachnoid because of the bridging veins and stuff, right? So that's where you start getting ruptures. So it can be acute, traumatic, high energy impact, right? So an accident with a seatbelt on, right? Or concussions and playing football or something. Okay, so hyperdense on this, on chronic, associated with mild trauma, cerebral atrophy, increase in age, chronic alcohol overuse, leads to hypodense on CT, also seen in shaken babies. Crescent-shaped hemorrhage, red arrow in C over there, so it looks like a crescent. Shaped hemorrhage, that crosses suture lines. So that's the differentiating factor between subdural and epidural. They'll tell you this, that, or even in the scan, you'll see it like this, right? This looks like it's stopped here. So that's where the suture lines are. Because then the parietal lobe starts, and here the frontal lobe starts. So it's right where the temporal lobe is. It's contained in it. Okay, so like that. But here, it's in the frontal, temporal, and a little bit of parietal as well. And this one has a scalp hematoma as well. This one's not going to have scalp hematoma. Okay, it can cause midline shift. Okay, yellow arrow in C. So you can see the ventricles moving to the side, right? So the hemispheres are squished outwards, whereas it's basically moving the whole hemisphere. Whereas this, it does not move the hemisphere, it just compresses it. Okay, so if it moves, it's subdural. Findings on acute chronic hemorrhage. Okay, blue arrow. Okay, so since it's like that, it's moving it this way. Okay. Uh, okay. Then subarachnoid hemorrhage. So this is between the arachnoid and pia mater, or pia membrane, right? So subarachnoid hemorrhage, bleeding, E and F, straight over there, and that. It's hard to make out just with the scans, by the way, because that looks like neurocysticercosis as well, or PML, you know. So you need the history for that. So it's bleeding due to trauma or rupture of aneurysm, such as saccular aneurysm or atriovenous malformation. Rapid time course. Patients complain of worst headache of my life, and this is important for SA. Okay, and for SA, uh, there's a specific treatment that we give. Okay, nimodipine, I think. Uh, yeah, nimodipine. The way I remember it, it might not work for you, but there's congressman in India, Amit Shah. So Shah is always with Namo. Namo is like Narendra Modi, the prime minister. So Sa with Namo. So nimodipine for Sa. That's how it works for me. Okay, so rapid time course. Patients complain of worst headache of my life. This is going to be the buzzword. If they give you this, that the patient's complaining that he has the worst headache of his life, it's hinting towards this. So then you got to differentiate between this and something else. Then maybe a vasculitis or something. I don't know. Bloody or yellow, xanthochromic lumbar puncture. Okay. Vasospasm can occur due to blood breakdown or rebleed 3 to 10 days after hemorrhage. It leads to ischemic infarct. Nimodipine used to prevent reduce vasospasm. Increase in risk of developing communicating and or obstructive hydrocephalus. Okay. So again, vasospasm can occur due to blood breakdown or rebleed 3 to 10 days after hemorrhage. So you can get a reactivation of the symptoms, right? And you'll get ischemic infarct. So nimodipine used to prevent or reduce vasospasm. Increased risk of, so that's what that is used for. Increased risk of developing communicating and or obstructive hydrocephalus. Okay. Moving on. For this, the scans don't really help. So you gotta understand the question stem or the vignette for that. Intraparenchymal hemorrhage, most commonly caused by systemic hypertension, also seen with amyloid angiopathy, a recurrent lobar hemorrhagic stroke in older adults, atriovenous malformations, vasculitis, neoplasms. May be secondary to reperfusion injury in ischemic stroke, hypertensive hemorrhages, that's Charcot-Bouchard microaneurysms. Okay, most often occur in putamen of basal ganglia. lenticulostriate vessels, followed by thalamus, pons, and uh, cerebellum. Okay, this is also the one causing lacuna infra. Right, read that again. Most commonly caused by systemic hypertension, also seen with amyloid angiopathy, recurrent lobar hemorrhagic stroke in adults. That's not important. This one is systemic hypertension. Uh, Also seen with atriovenous malformations, vasculitis. Atriovenous malformations were here too, so you would see that with this as well. Vasculitis, so you would have to differentiate between this and this with the vasculitis one, I guess. Neoplasm may be secondary to reperfusion injury in ischemic stroke. Okay, so when it you know what that is. So hypertension, hypertensive hemorrhages. So Charcot, Bocard, microaneurysm. I need to look that up. Hold on. Minute aneurysms in the brain that occur in small penetrating vessels with a diameter that is less than 300 micrometers. Lenticulostriate branches of the middle cerebral artery. Okay, so that most often occurs in the putamen of basal ganglia. So if it's anywhere over here, this is usually what they're gonna give you for the basal ganglia. Or it could be with the thalamus, pons, or cerebellum. Anywhere if you see it like that, they're talking about the intraparenchymal uh, hemorrhage. For this, you should understand why it's intraparenchymal hemorrhage. Okay, so the parenchyma goes. Let's see. Uh, okay, so they're not showing it. I don't find it anywhere. Okay, no, that's not gonna work. So, anyways, it's inside the parenchyma that surrounds that area. So it surrounds this area. That's why it's called hemorrhage within that parenchyma, right? It's most often in the putamen of basal ganglia. So you don't have to differentiate like that. Which one's putamen, which one's globus pallidus. Just know it's basal ganglia, and that should work. Or followed by thalamus, pons, and cerebellum. Okay, so thalamus would be somewhere here. Uh, then pons would be below this, and this is the cerebellum itself, right? So you gotta figure out which layer the scan is for. So between scans of how would you differentiate between the brainstem and cerebellum and all that area. So let's look at that. Okay. So here this is still a brain scan, but you don't see the cerebellum differently, right? Why? Because you're lower now, lower into the scan, and that's why. Okay, so you're seeing the brainstem now over here, and I don't know what the other ones are, but that's what I mean when you need to know which one's where. Because then when they give you something like this, you know exactly where that is because you know what the scan is of. So you see a little bit of cerebellum over here, right? But you're seeing the bottom part of it. Okay, and this is the medulla oblongata. So this is right at where the medulla is, right? So medulla has which ones? It has 9, 10, 11, and 12 nerves coming out of that, or nuclei for those, right? Not the 11, but 9, 10, and 12. Okay, so it's going to be something to do with that. Okay, so like that. Okay. Central post-stroke pain. Neuropathic pain but due to thalamic lesion. Initial paresthesia followed in weeks to months by allodynia. This is ordinarily painless stimuli causing pain. Okay. And dysesthesia, altered sensation on the contralateral side. It occurs in 10% of stroke patients. Okay, so it's nothing painful, but it still causes pain. Okay, so when you start seeing that, or you start seeing altered sensations, these are post-stroke symptoms of central post-stroke pain. Then there's phantom limb pain. This is sensation of pain in a limb that is no longer present. Okay, there was a thing about this in House as well. So sensation of pain in a limb that is no longer present, common after amputation, associated with reorganization of primary somatosensory cortex, characterized by burning, aching, or electric shock-like pain. Diffuse axonal injury. So it's you're seeing what you're seeing is shearing over here. So it's getting ripped apart, right? And why would that happen? So diffuse axonal injury, it's traumatic shearing of white matter tracts during rapid acceleration and or deceleration of the brain, so motor vehicle accident. Usually results in devastating neurologic injury, often causing coma or persistent vegetative state. MRI shows multiple lesions, punctate hemorrhages involving white matter tracts. Okay, so diffuse axonal injury, that's what that is. Aphasia. Aphasia is higher order language deficit, inability to. Oh, for this, there's like a nice little chart that they give. Let me see if I can find it. Okay, so aphasia. This chart really helps you understand it. Uh, did I unmute you guys? Yeah. Okay. Aphasia, higher order language deficit, inability to understand, produce, use language appropriately, caused by pathology in dominant cerebral hemisphere, usually left. Dysarthria, motor inability to produce speech, and movement deficit. Okay. So that's what that means. So Broca's, that's expressive. So Broca area in hold on, let me check my notes if I have better notes for this. No, I don't. Okay. Continuing. Broca area in inferior frontal gyrus of frontal lobe. It's associated with defective language production. So patients appear frustrated and insight and tact. Okay. So Broca is broken boca, and boca means mouth, so broken mouth. Okay. So they understand you. Okay. But they're not able to talk. And it's not that they can, it's just the mouth is not able to, the muscles in the mouth are not able to organize together to speak. basically, and what what your brain is telling them to say and function. So it's not able to connect that. Okay, so you have good comprehension, insight is intact. However, it's non-fluent, right? And so when I ask them to say what I'm saying and repeat what I'm saying, they won't be able to repeat it. So even if I tell them like, okay, so say dog, cat, they won't be able to say it, something like that, I guess. Okay, so that's Broca's aphasia. Wernicke or repetitive. So Wernicke areas in superior temporal gyrus of temporal lobe associated with impaired language comprehension. Patients do not have insight. Wernicke is a word salad and makes no sense. Okay, Wernicke area and superior temporal gyrus of temporal lobe. That makes sense. Associated with impaired language comprehension. Patient do not have insight. Okay, so here they'll, when you're talking to them, how's the weather today, and they'll be like, playing, falling, rain, fan, boxes, teddy bear, something like that, right? So it makes no sense. So that's what a word salad is, right? So it makes no sense. Actually, I use rain. They won't say rain because that would make sense a little. But it's, just jumbled up words of something unrelated. So poor comprehension, they won't understand what you're saying. Uh, However, the words they're saying, they're legit words. It's just they're not spoken uh, in a proper manner. Okay, and if you ask them to repeat something, they won't be able to repeat it either. Then there is conduction. So it can be caused by damage to arcuate fasciculus. So you have good comprehension and fluent speech for that, but it can be repeated. So when you ask them to repeat words, they won't be able to repeat it. Okay, and this is conduction. So remember, arcuate fasciculus is the one connecting the Wernicke to Broca's. Okay. Then there's global. So global is Broca and Wernicke area affected together. Okay, so both of them. Then there's also transcortical motor aphasia, transcortical sensory. That is not given here. So basically, sensory, motor is, I guess, the mouth one, if I remember correctly, and sensory one is, they have poor comprehension of it, so it's transcortical. Hold on, let me just look it up. They give it to you. It's a type of non-fluent aphasia that means the speech is halting with a lot of start and stops. People with TMA typically have good repetition skills, especially compared to spontaneous speech. For instance, a person with TMA might be able to repeat a long sentence. Okay, and what about sensory? Sensory is a kind of aphasia that involves damage to specific areas of temporal lobe of the brain, resulting in symptoms such as poor auditory comprehension. So they can't hear you, that's why they're having trouble. Or they hear you, but they're not able to register it. Relatively intact in repetition and fluent speech with semantic paraphasia presence. Okay. So they can't comprehend it actually, but they will be able to repeat it. Okay. And then a problem with both of them would be mixed transcortical aphasia. Okay, where is that happening? Transcortical motor is going to be this, the whole transcortical, and transcortical sensory is all of this. Okay. Good to go. Next, aneurysms. Abnormal dilation of an artery due to weakening of vessel wall. Okay, so you can have saccular aneurysm. It's also called berry aneurysm. It occurs at bifurcation in the circle of Willis. Most common site is junction of ACOM, that's anterior communicating artery, and anterior cerebral artery. It's associated with ADPKD, and that's important as well. So this whole topic is important. So you gotta remember all of it. It's associated with ADPKD, Ehlers-Danlos syndrome. Other risk factors are advanced age, hypertension, and tobacco smoking. Usually clinically silent until rupture, most common complication. It leads to subarachnoid hemorrhage, worst headache of my life, or thunderclap headache. Right? This will lead to focal neurologic deficit. Can also cause symptoms via direct compression of surrounding structures by growing aneurysm. Anterior communicating artery compression, bitemporal hemianopia, compression of optic chiasm, visual acuity defects, rupture, leads to ischemia and ACA distribution, contralateral lower extremity hemiparesis, and sensory deficit. All of that should make sense now. MCA rupture, middle cerebral artery rupture, ischemia and middle cerebral artery distribution will lead to contralateral upper extremity and lower facial hemiparesis and sensory deficits. Right, it's just your homunculus ones, and then posterior communicating, that's between the MCA and PCA. So compression of that will lead to ipsilateral cranial nerve 3 palsy or mydriasis, blown pupil. May also see ptosis, down and out eye. Okay. So PCOM or anything to do with the posterior one, it was to do with the visual stuff, right? So that. Charcot Bouchard microaneurysm, we looked that up, but it's common associated with chronic hypertension, affects small vessels, for example, lenticulostriate arteries in basal ganglia and thalamus. It and can cause hemorrhagic intraparenchymal strokes. Not visible on angiography. Fever versus heat stroke. So fever and heat stroke. So what's the difference? In fever, pathophysiology is that you get cytokine activation during inflammation, for example, infection. Remember, it's interleukin 1, 6, and TNF alpha. Those were your inflammatory ones. And then anti-inflammatory one were interleukin 10 and transforming growth factor beta, TGF beta. And yeah. Temperature is usually less than 40 degrees Celsius. Okay, so 104 degrees Fahrenheit. Complications are febrile seizure, benign, usually self-limiting. Management is acetaminophen or ibuprofen for comfort. Does not prevent future febrile seizures, however, and antibiotic therapy if indicated because of infection. Heat stroke is pathophysiology for that is inability of body to dissipate heat, for example exertion. So temperature is going to be more than 40 degrees Celsius, so 104 degrees Fahrenheit. Complications are CNS dysfunction, for example confusion, rhabdomyolysis, myolysis, acute kidney injury, ARDS, and DSE. Okay. Then management is rapid external cooling, rehydration, and electrolyte correction. This one is important because it has DIC in it, so you should know why that's occurring and why it's this. Okay. During a heat stroke, if something goes this high, I think your what temperature does DNA coagulate or denature? Approximately 90. Uh, when we're doing the lab techniques, they told us that it denatures at like 90 and then you cool it down to 75 and all that stuff, right? But once it goes above a certain degrees, it becomes unstable, I think. And that's the thing that's going to cause uh, majority of these things. And yeah, DIC is just, gotta remember that one. Seizures, characterized by synchronized high frequency neuronal firing, variety of forms. Okay, so you can have partial seizures or focal seizures or generalized seizures. Okay, so what does partial or focal mean? It just means it's at one specific point and it's not diffuse. So if it's at a specific point, wherever it is at, you'll get symptoms of those areas, right? So partial focal seizures. So then you ask yourself, is it impaired? Does the person have, or did the person have consciousness or not? If they did, then it's simple, and if they lost consciousness, then it's complex. Okay. So affect single area of the brain. Most commonly originate in medial temporal lobe. Types are simple partial, consciousness intact, motor, sensory, anatomic, and psychic. Complex partial is impaired consciousness and automatism. Okay. Generalized seizures. Uh, Consciousness, motor, sensory, and anatomic, psychic. Okay. And it only affects the single part of the brain. Okay. Generalized. Okay, this one can also lead to secondary generalized tonic-clonic, or you can have any of these. So, absence seizure. Okay, that's petit mal. Uh, Blank stare, no posictal confusion. Okay, so absence mal, petit mal, 3 hertz spike and wave discharge, short, usually 10 seconds, and frequent episodes of blank stare. No posictal confusion, can be triggered by hyperventilation. Okay, so for this, you gotta be able to differentiate between all of these. So for this, it's going to be single with consciousness is this, and if it's single area without consciousness, it's this. If they tell you that the person was standing there and just blinking, right, and after it was done, then they had no confusion, it's absence. So absence because it just seems they're zoned out, right? Uh, or they're not at the place basically, but they didn't collapse or anything. Okay, so it can be triggered by hyperventilation. Then you have myoclonic, which is quick. Oh yeah, so this just means tiredness. Okay, altered state of consciousness after and this. The post-ictal state is the altered state of consciousness after an epileptic seizure. Okay, so that's what that is. So none of that is happening. No disorientation. Okay. Myoclonic is quick, repetitive jerks. No loss of consciousness either. Okay, so that's myoclonic, quick and repetitive jerks. Like that. So, myo is muscles, right? And clonic is just jerks. Then you have tonic, which is contraction, and clonic, which are jerks. Okay, so tonic, clonic, like that. Alternative stiffening and movement. Okay, so stiffening is the contraction and movement is the clonic part, the jerk. So tonic, clonic, it's in the name. Grand mal. Alternating stiffening and movement. Post-ictal confusion happens, so there is disorientation there. Urinary incontinence and tongue biting. Okay. This is important. They will give you that the dude wet his pants or something, uh, or hurt his tongue or something, or there was stiffening and relaxing of the body. That should tell you it's tonic clonic. Okay. And then if it's just stiffening, it's tonic. And atonic is drop seizure. That's fall to the floor, commonly mistaken for fainting. Okay, so it seems like narcolepsy, but it's seizures. Okay, so what's the difference between epilepsy and seizures then? We just learned about seizures, so what is epilepsy? It's disorder of recurrent unprovoked seizures. Febrile seizures are not epilepsy. Febrile, that's seizures due to fever, right? So that's not epilepsy, but if you have recurrent generalized seizures or focal seizures, then you have a disease called epilepsy. So this is a symptom, and this is the disease. Okay, so status epilepticus is continuous more than 5 minutes, or recurring seizures without interictal return to baseline consciousness that may result in brain injury. It causes of seizures by age: children less than 18, genetic, infection, trauma, congenital, metabolic. Adults 18 to 65, it's tumor, trauma, stroke, or infection. And adults more than 65 are stroke, tumor, trauma, metabolic, and infection. This bit is important. This is not as important, as far as I remember. They do test you on this stuff, but they don't really test you that much on this. They might ask you what is epilepsy, or they might give you epilepsy and the thing and this. And if they tell you this person's never had uh, anything like this happen before, then it's not going to be epilepsy, right? It's going to be this. Status epilepticus is just something that they have seizure longer than 5 minutes, or they had it for a minute, then rest, and then again, and then rest, and then like after 2 minutes they had it again. So in total it was longer than 5 minutes, right? Or recurring seizures without ictal return, so interictal, so they didn't become conscious in the middle, right? Okay, so yeah, did all of them. Just know the symptoms, so with that you'll figure out which one type of seizure it is. Okay, for the focal one, it's gonna be like the dude is has right hand tremoring, or because if it's generalized tremor like Parkinson or something, it's going to be bilateral, but this one's going to be just unilateral. Or there's jerking of the jaw, or shaking of the head or something like that. That's going to be focal seizure. Okay. Headaches: pain due to irritation or intra or extracranial structures. For example, meninges, blood vessels. Primary headache includes cluster, migraine, and tension. Uh, wait. Primary headache include cluster, migraine, and tension. Migraine and tension headaches are more common in females. I just felt like I was having deja vu reading that. Okay. So migraine and tension headaches are more common in females. Okay, so migraine and tension, but that doesn't really help you because it could be a male or female. It's not gonna understand. Like, you're not gonna get that from that. Secondary headaches include subarachnoid hemorrhage, meningitis, hydrocephalus, neoplasia, or giant cell temporal arteritis. That's an important one. Remember, it's the one where you're supposed to give corticosteroid to prevent blindness. Okay. Cluster unilateral. It's 15 minutes to 3 hour, and it's repetitive. Okay. And description is excruciating periorbital pain or suicide headache with autonomic symptoms. For example, lacrimation, rhinorrhea, conjunctival injection may present with Horner syndrome, more common in males. Treatment is acute sumatriptan, 100% uh, oxygen, and prophylaxis is verapamil. Gotta remember the treatment for these, okay? They ask you that. So it's more common in males. So if it's a male, chances are it's cluster, but it's a female, it's not gonna help you. It could be any of these. Migraine, it's again unilateral, okay, and this one happens it lasts 4 to 72 hours, okay. So if it touches 4 or more, it's going to be migraine, and if it's less than 4, it could be cluster or tension. But cluster, it's unilateral, whereas tension is bilateral. Okay, so need to learn how to differentiate between those. Unilateral, 4 to 72 hours. Pulsating pain with nausea, photophobia. Photophobia is unique to migraines and or phonophobia, so that's sound. May have aura, so they feel it coming on, right? So that only happens in migraine as well. Due to irritation of the fifth cranial nerve, the trigeminal one, meninges or blood vessels, release of vasoactive neuropeptides, for example, substance P, calcitonin, gene-related peptide, acute NSAIDs, triptans, dihydroergotamine, antiemetics, for example, prochlorperazine, metoclopramide as well. Okay, so you gotta know all these drugs for this. Prophylaxis, life changes, for example, sleep, exercise, and diet. This is the one they give you in options, and you're gonna look over it because it's beta blockers, but you gotta remember that it's given in migraines. Okay, because calcium channel blockers are, you know, I think it's okay. So it's only in that. Then for that, verapamil, and then this. Okay, amitriptyline, topiramate, valproate, botulinum toxin, anti-CGRP, monoclonal antibodies. Botulinum toxin, so you can, prevent irritation of this. Pound, pulsatile, 1 day duration, unilateral, nausea, and disabling. Okay. Tension, it's going to be bilateral, more than 30 minutes, typically 4 to 6 hours. Constant, it's going to be steady, bend like pain. Okay, wait, so yeah, it could be any of these. Steady, bend like pain, no photophobia or no phonophobia, so and no aura. Acute analgesic, NSAIDs, acetaminophen. Prophylaxis is TCAs like amitriptyline or behavioral therapy. Compare with trigeminal neuralgia. So that was given where? Okay, cluster. Compare cluster with trigeminal neuralgia, which produces repetitive unilateral shooting shock-like pain in the distribution of cranial nerve 5, triggered by chewing, talking, touching certain pain parts of the face, lasts typically for seconds to minutes, but episodes often increase in intensity and frequency over time. First line therapy is carbamazepine. Okay. It's a benzo. Uh, Movement disorder. Okay, we'll just go through this because the ones you need to know you probably already know. Uh, Akathisia, that's restless and intense urge to move. Notes can be seen with neuroleptic cues or as an adverse effect of Parkinson's syndrome. Hysterexis, that's extension of wrist, causes flapping motion associated with hepatic encephalopathy, Wilson's disease, and other metabolic derangements. Uh, ethos, Ethetosis, that slow snake-like writhing movement, especially seen in the finger. For this one, look up a YouTube video for that. It's uh, pretty cool. But you need to know that this happens in Huntington's disease, and characteristic lesion is in basal ganglia. Just like chorea, it's sudden, jerky, purposeless movement. Lesions in basal ganglia. Chorea, dancing. So it's also seen in Huntington's disease and in acute rheumatic fever as well. The Sydenham chorea. So you gotta remember that one. Dystonia, sustained involuntary muscle contraction. So writer's cramp, blepharospasm, torticollis. Treatment is botulinum toxin injection. Essential tremor, high frequency tremor with sustained posture. For example, outstretched hand. Worsened with movement or when anxious. So this is the one where they go to pick up a glass and they, start shaking as soon as they get close to the glass. Uh, so when they have an intention of doing something and they get close to it, the tremor increases in frequency. Okay. Often familial. Patients often self-medicate with alcohol, which decreases tremor amplitude. Uh, Treatment is non-selective beta blockers, for example, propranolol and barbiturates and primidone. Wait, that's essential tremor. Never mind. What I was explaining was intention tremor, right? So slow zigzag motion when pointing, extending towards a target. Okay, and cerebellar dysfunction. So that's just a high frequency tremor, essential tremor. This one you gotta know for Parkinson, because that's how you differentiate. No, you gotta differentiate between essential tremor and resting tremor. That's the one with Parkinson. Oh my, I'm forgetting my tremors. Okay, so intention tremor, that's slow zigzag motion when pointing or extending towards a target. So that's the one where, you know, they have the intention of picking up a glass or something and they start moving. Otherwise, at rest, they're not moving. So that's called intention tremor. If they're moving at rest, it's gonna be resting tremor. And if they're moving at rest and when they're doing something, it's called essential tremor. Okay. So intention tremor it's because of a lesion in cerebellar dysfunction. Okay. Or characteristic lesion is cerebellar dysfunction. Okay. Resting tremor, it's uncontrolled movement of distal appendages, most noticeable in hands. Tremor alleviated by intentional movements. Okay, so when they're doing something, the tremor goes away. Lesion, characteristic lesion is substantia nigra, Parkinson's disease, occurs at rest, pill rolling tremor, or Parkinson's disease when you park your car, it is at rest. Hemiballismus, that's Huntington, right? I think. Didn't say it. So hemiballismus is sudden, wild flailing of one side of the body. Contralateral subthalamic nucleus, for example, lacunar stroke. Okay, pronounced half of body is going ballistic. Myoclonus, this is sudden, brief, uncontrolled muscle contraction, right? So the jerks, right? Clonus is jerks and myo is muscles, so muscle jerks. So uncontrolled muscle contraction is going to be sudden and brief. so it won't last for long. So it's not tonic. So jerks and hiccups it's common in metabolic abnormalities, for example, renal and liver failure. Creutzfeldt-Jakob disease, that's the one under prions. Restless legs or syndrome. Restless leg syndrome. It's uncomfortable sensation in legs causing irresistible urge to move them, relieved by movement, worse at rest and nighttime. It's associated with iron deficiency, chronic kidney disease, diabetes, especially with neuropathy. Treatment is dopamine agonists, pramipexole, and ropinirole. Okay. We finished that. On to neurodegenerative disorders. These are decrease in cognitive ability, memory, or function with intact consciousness. Must rule out depression as a cause of dementia, called pseudodementia. Other reversible causes of dementia are hypothyroidism, vitamin B12 deficiency, neurosyphilis, normal pressure hydrocephalus. Okay. Disease description and histologic and gross findings. So Parkinson's disease, Parkinson traps your body. So you get tremor, pill rolling tremor at rest, rigidity. This is cogwheel rigidity, akinesia or bradykinesia, so slow movement, partial instability, shuffling gait, and small handwriting or micrographia. Dementia is usually a late finding. MPTP, a concomitant contaminant. All right, so that's yeah, methamphetamine. That's the one. Dementia is usually a late finding. MPTP, contaminant in illegal drugs, is metabolized to MPP, which is toxic to substantia nigra. Okay, so that's where substantia nigra is, right? That's hypothalamus over there. That's memory bodies, amygdala and hippocampus over here. So substantia nigra, and that's subthalamic nuclei over there. Quadrate nucleus, thalamus, and your basal putamen and globus internus and globus pallidus externus over there. And this is your internal capsule. Okay. Histologic gross findings on loss of dopaminergic neurons, that is depigmentation of substantia nigra pars compacta. So, and Lewy bodies. These are important because that's how you will figure out his Parkinson's. They are composed of alpha synuclei or synuclein, intracellular eosinophilic inclusion. So this is also a inclusion body. So I guess whatever those are, Lewy bodies are. Okay, so those things. Okay. Huntington's disease. So this is, it seems like it's quadrate and putamen. So Huntington's, it's autosomal dominant trinucleotide or CAG, right? Can't aim great or can't aim good. CAG, repeat expansion in the Huntington gene of chromosome 4. So 4 letters for Hunt. Toxic gain of function. Okay, toxic gain of function. Symptoms manifest between age 20 and 50. Chorea, ethystoses, aggression, depression, dementia, sometimes initially mistaken for substance abuse. Anticipation results from expansion of CAG repeats. That's important. So CAG also quoted loses acetylcholine and GABA. Atrophy of caudate and putamen with ex vacuo ventriculomegaly. Okay. So I don't know, do they have it? Nope. See a scan for this. Okay, so that's ventriculomegaly ex vacuo. Okay. Uh, Same thing with this. Gets bigger. There's increase in dopamine, decrease in GABA and acetylcholine in brain. Neuronal death via NMDA binding and glutamate excitotoxicity. Okay. Alzheimer's most common, so that is amygdala, right over there, and most common cause of dementia in older adults. Advanced age is the strongest risk factor. Down syndrome patients have increased risk of developing early onset of Alzheimer's disease. This is important. People with Down syndrome, they have increased risk of getting early onset of Alzheimer's disease, as APP is located on chromosome 21. Decrease in acetylcholine for this as well. It's associated with the following altered proteins: the ApoE2, so decreased risk of sporadic form. In ApoE4, there's an increased risk of sporadic form, and APP, presenilin 1 and presenilin 2, familial forms 10% with earlier onset. So ApoE2 is protective, and ApoE4 is for Alzheimer's disease. There's a widespread cortical atrophy. So this is a normal cortex. Let's look at these. Bring it up there. Okay, so widespread cortical atrophy, normal cortex. This is what it looks like. In Alzheimer's disease, this is what it becomes. Okay. So, especially hippocampus. Okay. So hippocampus. Isn't hippocampus down here? Did I mess up the hippocampus and amygdala? Let me just make sure. Was it here or somewhere else that we were looking at that? And I don't think we were looking at it here. In limbic system. Yeah, it's not given here. Let me look that up as well. Okay, I'll just look that up. Give me a second. So Well, that doesn't really help us. So I guess it's just, over there. Amygdala. Okay, so it's part of it. So amygdala and hippocampus is like that. They don't have amygdala here. Okay, continuing. Uh, so back to this. Widespread cortical atrophy, normal cortex and cortex in Alzheimer's disease, especially hippocampus, arrow in B and C, narrowing of gyri and widening of sulci. You'll see senile plaques like these. Okay, if you see those in a photo, it's Alzheimer's. Okay, it's extracellular beta amyloid core may cause amyloid angiopathy, which leads to intracranial hemorrhage. A beta amyloid beta synthesized by cleaving amyloid precursor protein APP. Okay, amyloid precursor protein. Neurofibrillary tangles. Okay, so that's this. Okay, intracellular hyperphosphorylated tau protein, which equals to insoluble cytoskeletal elements. Number of tangles correlates with degree of dementia. Hiranu bodies, these are intracellular eosinophilic proteinaceous rods in hippocampus. Okay. Let's see if we can see what these are like. Gotta go zoom in long. Okay, so that thing right there. Okay, and let's look at tau protein. What was it? Tau. It's called inflammation. Where did I get tau from? Tau protein, yeah. Okay. Okay. Usually it's gonna look like that, so we don't. They don't have other photos. Okay, so you gotta know about the senile plaques, and it's because of amyloid deposition there, beta amyloid deposition. Okay, and then if you have tau, these are intracellular hyperphosphorylated insoluble cytoskeleton elements. Okay, it correlates with the degree of dementia, and then Hirano bodies are eosinophilic inclusion bodies. Okay, so frontotemporal dementia, um, formerly called the Pick disease. It's early changes in personality and behavioral variant, or it could be aphasia, the primary progressive aphasia variant. Okay. May have associated movement disorders, so frontotemporal lobe degeneration. F, it's gonna be like that. Okay, horrible. Inclusions of hyperphosphorylated tau, round pick bodies. Okay, round pick bodies like that. All right. Or ubiquinated TDP 43. So tau protein is usually going to be for this one. They're not going to use it for this. For this, they'll tell you what's happening in that area, and they'll give you symptoms of these, and then you should be able to figure out its frontotemporal from that. Lewy body dementia. These are visual hallucinations or hallucinations. Dementia with fluctuating cognitive alertness, REM sleep behavior disorder, and Parkinsonism, called Lewy body dementia if cognitive and motor symptoms onset is less than 1 year apart, otherwise considered dementia secondary to Parkinson's disease. Intracellular Lewy bodies, uh, so these things, primarily in cortex. Okay. So it's called Lewy body dementia if cognitive and motor symptoms onset is less than 1 year apart. Otherwise, it's considered dementia secondary to Parkinson's disease. Okay. Vascular dementia, result of multiple arterial infarcts and/or chronic ischemia. Stepwise decline in cognitive ability with late onset memory impairment. Second most common cause of dementia in older adults. So multiple arterial infarcts and/or chronic ischemia. MRI or CT shows multiple cortical and/or subcortical infarcts. Okay. So this is the prions one, Creutzfeldt-Jakob disease. It's rapidly progressive, so weeks to months. Dementia with myoclonus, startle myoclonus, and ataxia. Okay, associated with periodic sharp waves of an EEG and increase in 14:33 protein in CSF may be transmitted by contaminated material, for example, corneal transplant or neurosurgical equipment, because prions don't get destroyed in autoclave, and fatal. Spongiform cortex, vacuolization without inflammation. So prions, PRPC, PRPSC sheet. So beta pleated sheet resistant to proteases. That's what they'll give you. That there's a beta pleated sheet that's resistant to breakdown or degradation. HIV associated dementia, subcortical dysfunction associated with advanced HIV infection characterized by cognitive deficits, gait disturbance, irritability, depressed mood, diffuse gray matter, and subcortical atrophy, microglial nodules with multinucleated giant cells. Okay, so you'll get microglial nodules with multinucleated giant cells. That's the presentation. This could be anything, so that's not gonna help. They'll give you oral thrush or something that defines HIV. Okay. Get this and depressed mood. Okay. Moving on. Idiopathic intracranial hypertension, so also called pseudotumor cerebri. Increase in ICP with no obvious finding on imaging. Risk factor include female sex, tetracycline, obesity, vitamin A excess, and denazole. So female toad. Associated with dural venous sinus stenosis. Okay. Right, because that's how you end up with hydrocephalus. Anyways, so that's going to increase that. Finding is headache, tinnitus, and diplopia, usually from cranial nerve 6, so that's your abducent palsy, right, because that affects lateral recti or rectus. No change in mental status, impaired optic nerve, exoplasmic flow leads to papilledema. Visual field testing shows enlarged blind spot and peripheral constriction. Lumbar puncture reveals increase in opening pressure and provides temporary headache relief. Temperature is weight loss, acetazolamide, invasive procedures for refractory cases, for example, CSF shunt placement, optic nerve sheath fenestration, surgery for visual loss. Hydrocephalus, that's increase in CSF volume, lead to ventricular dilation with or without the increase in intracranial pressure. Communicating, so you have communicating hydrocephalus. That's okay. So basically, communicating is if the flow is still, uh, you know, still there between lateral third and fourth ventricle. If anywhere else it can't, if there is an obstruction, then it's called non-communicating. Okay. Uh, so hydrocephalus increase in CSF, which leads to ventricular dilation with or without increase in ICP. So communicating hydrocephalus is decrease in CSF absorption by the arachnoid granulation. For example, arachnoid scarring post meningitis, right? So because of that, there is scarring on arachnoid layer, and then it can absorb the CSF. So there's increase in ICP. You get papillary edema and herniation, and then you have normal pressure hydrocephalus without the increase in ICP. It affects older adults, idiopathic, CSF pressure elevated only episodically, does not result in increased subarachnoid space volume, expansion of ventricles. I think if they give you something like this, you gotta differentiate between this and Alzheimer's disease, because they have if whether it's atrophied or it's because of this, you can't tell from just that. So you gotta be able to figure it out from the question stem itself. Expansion of ventricles distorts the fibers of the corona radiata, so it leads to triad of urinary incontinence, gait apraxia, and cognitive dysfunction. So wet, wobbly, and wacky. Symptoms potentially reversible with CSF drainage via lumbar puncture or shunt placement. Non-communicating or obstructive non-communicating hydrocephalus caused by structural blockage of CSF circulation with ventricular system, for example, stenosis of aqueduct of Sylvius, colloid cyst blocking foramen of Monroe, tumor, right? So we know all of that. Right, so it's caused by structural blockage of CSF circulation within the ventricular system. For example, stenosis of aqueduct of Sylvius, that's between the third and the fourth, right? And then colloid cyst blocking foramen Monroe, so that's between the medial part of the CS spinal and fourth ventricle. So fourth ventricle draining to the medial parts of the layers or whatever, it goes through the Monroe, or it could be anywhere. It could be lateral too, but on both sides, which is rare. So B. So that's a tumor. Hydrocephalus mimics ex vaccio ventriculomegaly. Okay. Ex vaccio ventriculomegaly. Appearance of increase. All right. So this is the one you gotta differentiate with Alzheimer's, not this one. Sorry. So ex vaccio ventriculomegaly. It's hydrocephalus mimics. So appearance of increase in CSF on imaging, but it's usually due to decrease in brain tissue, right? So it looks like there's increase in CSF on imaging, but it's actually because there's decrease in brain tissue and neuronal atrophy. For example, Alzheimer's, advanced HIV, frontotemporal dementia, or Huntington's disease. Intracranial pressure is normal in these, and NPH, normal pressure hydrocephalus triad, is not seen. Yeah, so never mind, I was right. So between this and this, you gotta differentiate between them. So for this one, you're gonna see this triad, but it actually looks like a triad for someone who has Alzheimer's as well, right? But for Alzheimer's, they might give you something else as well, like amyloid deposition or tau protein or in eosinophilic intracellular eosinophilic inclusion bodies or something like that. But if they give you these, it's gonna be this. So this is another triad you gotta look out for: urinary incontinence, gait apraxia, and cognitive dysfunction. Okay. That's it. Multiple sclerosis. It's autoimmune inflammation and demyelination of CNS, brain, and spinal cord with subsequent axonal damage. It can present with optic neuritis. This is important. So, optic neuritis, acute, painful, monoocular visual loss associated with relative afferent pupillary defect. Brainstem cerebellar syndrome, for example, diplopia, ataxia, scanning speech, intention tremor, nystagmus, INO. Bilateral more than unilateral. We'll read about that later. Pyramidal tract demyelination. Okay, so weakness, for example, and spasticity. That's what you'll see. Spinal cord syndrome, for example, electric shock like sensation along cervical spine on neck flexion. Neurogenic bladder, paraparesis, sensory manifestations affecting the trunk or one or more extremity. Okay, so this is also important: electric shock like sensation, and that's actually a buzzword. Okay, and if you get neurogenic bladder, that's also a buzzword for this. What else is a buzzword? This is okay. That's okay. I guess no, not really, because this could be a vasculitis thing too. Yeah. Symptoms may exacerbate with increased body temperature, for example, hot bath or exercise. Relapsing and remitting is most common clinical course. So remember, there was another one with hot shower. So intense itching after hot shower. I think it was polycythemia vera. Okay. Relapsing and remitting is most common clinical course. Most often affects female in their 20s and 30s. More common in individual who grew up farther from equator and with low serum vitamin D levels. Okay. So for multiple sclerosis, you will see this, but most importantly, they'll give you a history that tells you that the person had these symptoms and then they felt better for a while, and then again now it's much worse, right? So they don't have that. Let's see if they give a chart for this. Yeah, that too. Uh, so so in relapsing one and secondary one and all that, right? Uh, you don't need to know the difference. You just need to know that there'll be symptoms, then they'll feel better, then they feel the symptoms, and the symptoms are much worse than before now. Okay, and then they're gonna feel better, and then symptoms again, they feel better, and then uh, it doesn't get better. And sometimes the drugs will still affect it a little bit, so it might improve a little more, but some of them it doesn't. Drugs can't affect it anymore. Okay. Findings are increase in immunoglobulin G levels and myelin basic protein in CSF. So these are the things that you'll find in the vignette. Increase in immunoglobulin G level and myelin basic protein in the CSF. Uh, Oligoclonal bands aids in Diagnosis: MRI is gold standard. Periventricular plex, that's A right there. So when they say periventricular, it means around the ventricles. Okay, and this is classic for this as well. It was for something else as well. Uh, we'll look at it after. Uh, so areas of oligodendrocyte loss and reactive gliosis, multiple white matter lesions disseminated in space and time. Treatment is stop relapses and halt slow progression with disease modifying therapies, for example, beta interferon, gledaramir, and natalizumab. Okay. Treat acute flares with IV steroids. Symptomatic treatment and neurogenic bladder, that's catheterization, muscarinic antagonists, botulinum toxin injection. Spasticity, baclofen GABA receptor agonists. Pain and TCAs, anticonvulsants. Okay, so all of these things. So neurologic fatigue, you'll find that. Depression, ataxia, and intentional tremor. Speech, dysarthria and scanning speech. Optic neuritis, diplopia, nystagmus, INO. Spinal cord, sensory symptoms, weakness and spasticity, and urinary incontinence. Okay, so paraventricular plex, remember that if they give you a scan. Let me look up what else causes paraventricular plex. Scleroderma. Let me look it in here. This thing, right? CMV, so that has paraventricular calcification as well. So it's like that. Okay. But you can probably, differentiate between CMV and a child, because this is torch, right? Or this. But just wanted to remember. I remembered that something happens there as well. Something else does that as well. Okay. Other demyelinating and dysmyelinating syndromes. So osmotic demyelination syndrome. This is important. It's when an intern or a resident, you'll see. Also called central pontine myelinolysis. It's massive axonal demyelination in pontine white matter. Okay. That. It's secondary to rapid osmotic changes, most commonly iatrogenic correction, right? So when they're trying to correct hyponatremia, but also rapid shifts of other osmolytes, for example, glucose. Okay, so when that happens and they do it too fast, there's a rapid osmotic change which causes this. Okay. Acute paralysis, dysarthria, dysphagia, diplopia, loss of consciousness. It can cause locked-in syndrome. Okay. Correcting serum sodium too fast. So from low to high, your pons will die. So osmotic demyelination syndrome, and from high to low, your brain will blow. Cerebral edema or herniation can occur because of that. Okay. Acute inflammatory demyelinating Neuropathy. Most common subtype of Guillain-Barré syndrome, autoimmune condition that destroys Schwann cells via inflammation and demyelination of motor fibers, sensory fibers, peripheral nerves, including cranial nerve 3 and 3 to 12, all of them. Okay. So this is autoimmune condition that destroys Schwann cells by inflammation and demyelination of motor fibers, sensory fibers, and peripheral nerves. So all of them from 3rd to 12. So it's just sparing 1 and 2. Okay. This happens because of Campylobacter. I remember that from Sketchy. Because and if you have done Sketchy, it's when the guy slaps his knee, it's because of Guillain-Barré. That's what it represented. Likely facilitated by molecular mimicry and triggered by inoculations or stress, despite association with infections, for example, Campylobacter jejuni, viruses, for example, Zika. No definitive Zika virus. Zika virus is a flavivirus, right? No definitive causal link to any pathogens. Results in symmetric ascending muscle weaknesses, paralysis, and depressed or absent DTRs, beginning in lower extremity. So DTRs, deep tendon reflexes. Sorry. Okay, so it results in symmetric ascending muscle weakness. So this is going to be the thing that you'll see in the question. They'll give you that the person has muscular weakness and paralysis and absent reflexes in the lower extremity, and the person went camping or something. Facial paralysis, usually bilateral, and respiratory failure are common. May see autonomic dysregulation, for example, cardiac irregularities, hypertension or hypotension, or sensory abnormalities. Most patients survive with food functional recovery. Good, not food. Good functional recovery. Increase in CSF protein with normal cell count, albuminocytologic dissociation. Respiratory support is critical until recovery. Disease modifying treatment is plasma exchange or IV immunoglobulins. No role for steroid. They do ask you about Guillain-Barré, so you need to know about that stuff. Okay. Acute disseminated post-infectious encephalomyelitis. So this is multifocal inflammation and demyelination after infection and vaccination. Presents with rapid progressive multifocal neurologic symptoms, altered mental status. They don't ask you about that much, so you can move on from that one. Charcot-Marie tooth disease, CMT, can't move my toes. Also called hereditary motor and sensory neuropathy. Okay. Group of progressive hereditary nerve disorders related to defective production of proteins involved in the structure and function of peripheral nerves or the myelin sheath, typically autosomal dominant and associated with foot deformities, for example, pes cavus or hammer toes. Lower extremity weakness like foot drop and sensory deficits, so can't move toes. They ask you about that, so remember these. Also remember the most common type is this, and it's caused by this. I don't think they ask you about these, but they'll give you this and they'll ask you what's going on. Then you tell them it's this. Okay. Progressive multifocal leukoencephalopathy or PML, that happens because of JC virus. Okay. Demyelination of CNS due to destruction of oligodendrocyte, secondary to reactivation of latent JC virus infection. It's associated with severe immunosuppression, For example, lymphomas and leukemias, AIDS and organ transplantation. I'm just trying to remember which one was this. What class? Let me just go check. Be quick. JC viruses. Shit. What was JC virus, man? I can't see it. Oh, it's polyoma virus, right? It's a DNA virus. Okay, so it's a DNA virus, polyoma virus. Okay, so demyelination of CNS, you gotta be able to recognize this from the brain scan, because there are only like 3 or 4 things you need to know that depends on the brain scan. So this is one of them. Okay, because all the symptoms are very vague, so you won't be able to pinpoint it with the symptoms, but this will help. So demyelination of CNS due to destruction of oligodendrocytes, secondary to reactivation of latent JC virus infection, associated with severe immunosuppression, for example, lymphomas and leukemias, AIDS, or organ transplantation. Rapidly progressive, usually fatal. Predominantly involves parietal and occipital areas. Visual symptoms are common. Increased risk associated with natalizumab. Other disorders: Crab disease, metachromic crab disease. That was the one with the globus and all that stuff. The crab. And one of the storage diseases, right? I'm just trying to remember the. I guess we'll go look at that too. The details on that. Okay. Peripheral neuropathy. Destruction of oligodendrocytes in this galactocerebroside and galactocerebroside. Okay. Hold on. The globe of gooey crab meat is out of this world. Okay. Just trying to remember the mnemonic for that. Okay. Metachromatic leukodystrophy, and that's the metapod one. Similarly, over here as well. Right. Metapod is aerial broken Pokemon. So aerial for aerial sulfatase. Okay. And adrenal leukodystrophy. Neurocutaneous disorders. So these are disorder, genetic, presentation, and notes. So that's the stuff, the port wine stain one. Okay, so Strudge-Weber syndrome, genetics. So congenital non-hereditary anomaly of neural crest derivatives. Somatics mosaicism of an activating mutation and one copy of GNAC gene. So presentation, you'll have capillary vascular malformation that will lead to the port wine stain, and that's an important one because it only happens in this. So port wine stain, that's a buzzword for Strug-Weber syndrome. So you need to know what that is. That's this congenital non-hereditary anomaly of neural crest derivative and somatic mosaicism of an activating mutation in the one copy of the GNAC gene. Okay, so that's Nevis flemmis or non-neoplastic birthmark in cranial nerve V1, so ophthalmic trigeminal nerve or maxillary trigeminal nerve distribution. Okay, so it's here in ophthalmic and maxillary part of the brain, face, the supply by the trigeminal nerve. Okay, distribution: ipsilateral leptomeningeal angioma and calcifications. So like that. Seizures, it will lead to seizures, epilepsy, intellectual disability, episcleral hemangioma, increase in intraocular pressure, early onset of glaucoma. It's also called encephalotrigeminal angiomatosis. Okay. They will give you all of this, but this is the buzzword, so they'll have to give you that if they want you to figure out it's this. If they don't want you to get the marks, they'll give you all of this and not this. Okay. Tuberous sclerosis. Autosomal dominant, variable expression, mutation in tumor suppressor gene, TSC1, so that's tuberous sclerosis, it's in the name, so that's pretty cool. TSC1 on chromosome 9, hemartin, and then you had TSC2 on chromosome 16. This is the tuberin type. It's pronounced tuberin. Okay, so hematomas in skin, CNS and skin angiofibromas. Okay, so these little hematomas. You'll have mitral regurgitation, ash leaf spot as well. So that's important as well. They'll give you that. That's a buzzword. Cardiac rhabdomyoma. That is a buzzword, but they won't say ash leaf spot. I don't think they do that. They might show you this spot, or they'll, describe it. Other than that, I'm giving it away. Okay, so it looks like that. Cardiac rhabdomyoma, intellectual disability, renal angiomyolipoma, seizures, and chagrin patches. Okay, so renal angiomyolipoma is this, and it happens in tuberous sclerosis. There's increase in incidence of subependymal giant cell astrocytoma and fibromas. Not important. Neurofibromatosis type 1, autosomal dominant, 100% penetrance. This is an important one as well, right? It's a mutation in NF1 tumor suppressor gene on chromosome 17. It encodes neurofibromin, a negative RAS regulator, the RAS gene, right? Cafe alert spots, that's important to know what those are, so let's go look at that. We saw these in gastric cancer as well, I think. Okay, nope, not in gastric cancer, somewhere else. Mosaicism, okay, that's where we saw it. Okay, let me just confirm it. McEwen-Albright syndrome, right? I was mistaken. Okay, so this is a buzzword for neurofibromatosis type 1. Okay, so you'll have that intellectual disability, cutaneous neurofibroma, Lish nodules. These are pigmented iris hematomas. Okay, so H like that. Okay, cutaneous neurofibromatosis. That's what this is. Uh, and if you get a photo of something that's this, you will know for sure that looks like this, that it's neurofibromatosis type 1. Optic gliomas, pheochromocytomas, seizures, focal neurologic signs, often from meningioma, bone lesions, for example, sphenoid dysplasia. It's also called von Recklinghausen syndrome. Screw that, just remember 17. You don't need to worry about which chromosome actually. They don't really test you hard on these. They test it for the trisomies and all that stuff. For this, just NF1, or if they give you this, you gotta know that it's this or mutation in this. Okay. And then you have neurofibromatosis type 2. It's also autosomal dominant. Right? Yeah. Mutation in NF2, tumor suppressor gene, Merlin on chromosome 22. Bilateral vestibular schwannoma, and that's important. So vestibular, so that's the 8th cranial nerve. So wherever that is, it's going to be thicker, and on both sides. So if you have that, it's this. Since it's 2 sides, it's type 2. Okay, bilateral vestibular schwannomas, juvenile cataract, meningiomas, and ependymomas. NF2 affects 2 ears and 2 eyes. Okay. One Hippolinda disease, VHL. It's autosomal dominant. Deletion of VHL gene on chromosome 3P. PVHL, ubiquitinates hypoxia, inducible factor 1A. Hemangioblastomas, high vascularity with hyperchromatic nuclei. Okay, that's not gonna help us. Okay, so for this one, alright, let's finish reading first. Hemangioblastomas, high vascularity and with hematochromatic nuclei in retina, brainstem, cerebellum, spine, angiomatosis, bilateral renal cell carcinoma, and pheochromocytoma. Okay. So if they give you something wrong with the adrenal or the kidney as well as angiomatosis, okay, benign vascular malformation involving skin, it's this. Normally when they're asking this, it's very obvious. I just can't remember what it was. Numerous tumors, benign and malignant. So heart. Yeah, I think this is the presentation you'll see. Okay, so hemangioblastomas, that's high vascularity. And this thing's not helping. Okay, you'll see it in the spine and here as well. Okay, let me see what that is. Okay, so it's a tumor that grows in blood vessel on your brain and that. So a tumor there, a tumor in or cancer in your kidneys, and a tumor in your adrenal glands, and angiomatosis. So this stuff. Okay. They'll tell you it's mutation in VHL or deletion of VHL. Deletion of VHL gene on chromosome 3p. And done with that. Okay. So these were your neurocutaneous disorders. Let's take a break here. Adult primary brain tumors. Tumor description and histology. Glioblastoma. Okay. Glioblastoma, a grade 4 astrocytoma, commonly highly common, and it's highly malignant primary brain tumor with approximately 1 year median survival. It's found in cerebral hemisphere. It can cross corpus callosum, and this is going to create a butterfly appearance, so it's called butterfly glioma. Okay, associated with EGFR amplification. So it looks like a butterfly, like that. So that's why it's called that. Let's bring this there. Okay. Astrocyte origin, GFAP, positive. Pseudopellisating pleomorphic tumor cells. Border central area of necrosis. Okay, so this one. Or central areas of necrosis, hemorrhage, and or microvascular proliferation. For this one, you gotta know about the GFAP, and glioblastoma multiforme. Just pronounce it that way because P for pseudopellisating tumor cells, and they'll give you that in the question stem. So that's like the buzzword for that, pseudopellisating tumor cells. Okay. They might tell you that it's crossing corpus callosum, then you know it's a butterfly glioma or glioblastoma. So you need to know about that. You need to know, so it's in the name, glioblastoma, G for GFAP, P for pseudopellisating tumor cells, and M for it's going to be midline and it's going to be malignant. Okay. Oligodendroglioma, that's relatively rare, slow growing, most often in frontal lobes. Okay, so over there. Often calcified. Oligodendrocyte origin of fried egg cells, round nuclei with clear cytoplasm. Okay, like that. So for this one, it's about the fried egg appearance, right? Because of oligodendrocytes, it's fried egg cells, and chicken wire capillary pattern. Okay, so I don't know if that's visible. Okay. For this one, they'll give you that egg, fried egg shell. No, egg cell. Yeah, I thought I was messing that up. Right, appearance and chicken wire capillary pattern. They might give you that as well. So all egg, androglioma or whatever. Okay, that's the buzzword there. Meningiomyoma. This is common as well. Typically benign. It occurs more in female than males. It occurs along surface of brain or spinal cord. It's extraaxial, external to brain parenchyma, and may have a dural attachment, so tail, like that. And that's the best way to remember that, because nothing else is going to give you that appearance. So if you see a tail like that, it's not a subdural hemorrhage or anything, or you know, what was it? Hematoma, subdural. This meningioma. So it's common. That's important. Okay, and it has a tail. That's important. Often asymptomatic, may present with seizures or focal neurologic signs, resection and or radiosurgery. Arachnoid cell origin, spindle cell concentrically arranged in a whorl pattern. So you see the whirling over there. Somoma bodies. Okay, and that. Okay, hold on. For this, you need to know men have problems. Okay, no idea what that was. So for this, so arachnoid cell origin, spindle cells, concentrically whorl pattern, and somoma bodies. So meningioma. Okay, benign near surface, arachnoid cells, spindle cells, somoma bodies. So somoma. So that's, I don't know. Oh right, PSA. That's how you remember that. These are from Dirty Medicine as well. So they're not mine, so I don't remember them. So men have uh, problems with PSA when they have increased PSA or whatever, right? So PSA for somoma bodies. So men is for meningioma. That's where men comes from. And PSA, P for somoma bodies, S for spindle cells, A for arachnoid cell origin, right? So these three things you gotta remember, and you will be able to figure out it's meningioma. But I think for this, they normally give you this thing. They'll show you a photo, and then they'll tell you there's a tail. So when there's a tail, it's meningioma. Okay, hemangioblastoma, most often cerebellar. Right there. Associated with one Hippolyndau syndrome when found with retinal angiomas. Can produce erythropoietin. For example, it leads to secondary polycythemia. Okay. Blood vessel origin, closely arranged thin-walled capillaries with minimal intervening parenchyma. Okay. So hemangioblastoma of blood vessels origin, right? It has angio in it. It's okay. EPO producing, associated with one Hippolyndau. Okay. So it's associated with that. Found in renal and erythropoietin, secondary polycythemia. Okay, so that's hemangioblastoma right there. So if there's any kind of tumor in the cerebellum, it's going to be hemangioblastoma, because the other ones don't happen in the cerebellum. Okay. Pituitary adenoma may be non-functioning, silent, or hyperfunctioning, hormone producing. Non-functional tumors present with mass effect, for example, bilateral hemianopia, due to pressure on optic chiasm. Okay, so let's look at that stuff now. Right, so pituitary adenoma, pituitary, it's right above the sella tunica. Right. Tunica. Right there. So, this is a sella tunica sphenoid bone, and right there you have the okay, so it goes right there under it. So when this okay, so that's optic chiasm. So this is the, okay. Hold on. So that's the optic nerve. All right. That was different in my head. But okay, so pituitary and optic nerve over here, and optic chiasm over there. Okay. So it may be non-functioning, silent, or hyper-functioning. Okay, so the tumor, it could be non-functioning, so you won't realize it unless you start seeing physical manifestations of it, or it's hyper-functioning, so you'll see hormones in the serum and it will do stuff to you. So non-functional tumors presents with mass effect, for example, the effects due to the mass itself, right? The physical structure. So that will cause bitemporal hemianopia due to pressure on the optic chiasm. Okay. Pituitary apoplexy can happen, and this will lead to, or you should do that. So it will lead to hypopituitarism. Wait, apoplexy was what? Unconscious incapacity resulting from cerebral hemorrhage or stroke. Okay, so right. Uh, that was due to, I think, after pregnancy you get that, right? It was an endo. I'll look at it after. So with that, you can you'll have hypopituitarism. Prolactinoma classically presents as galactorrhea and amenorrhea, decrease in bone density due to suppression of estrogen in females, and as decrease in libido, infertility in males. Treatment is dopamine agonists, for example, bromocriptine, carbagoline, transsphenoidal resection. Hyperplasia of only one type of endocrine cells found in pituitary, most commonly from lectotrophs, prolactin. Okay, and so right there, leading to hyperprolactinemia, less commonly from somatotrophs, growth hormone, acromegaly, gigantism because of that, corticotrophs, ACTH, Cushing syndrome because of that, rarely from thyrotrophs, TSH, or gonadotrophs. Okay, so hyperplasia, only one type of endocrine cells found in pituitary. So it's gonna be one of these. Schwannoma, right? So that thing right there. Okay, classically at the cerebellopontine angle, and that's important to remember. It's where the cerebellum and pons meet in that angle. It's benign. It involves cranial nerve 5, 7, and 8. It's usually going to be 7 or 8. I think it's 7. Yeah, so 7 or 8. But can be along any peripheral nerve. Often localized to cranial nerve 8 and internal acoustic meatus. Yeah, so it's 8, not 7. It's usually going to be this because that's what they're going to give as a symptom. Okay, so you'll have vestibular schwannoma. It can present as hearing loss and tinnitus. So that's going to be in the question stem, the vignette. Hearing loss and tinnitus. Bilateral vestibular schwannomas found in neurofibromatosis 2, resection or stereotactic radiosurgery. Schwann cell origins give you S100 plus positive, biphasic, dense, uh, hypercellular areas containing spindle cells, alternating with hypocellular and myxoid areas. So S100 is for schwannoma, whereas GFAP is for glioblastoma. Okay. Meningioma, you have the tail. Hemangioma only happens in the cerebellum. Pituitary adenoma is a fairly easy one to figure out because of the symptoms. Okay. So blindness in the lateral sides of this, it's because of the pituitary adenoma. Okay. Childhood. Uh, Wait, do I have anything else left here? No. Oh, okay. So here, for pituitary adenoma, it's gonna be lectotroph or somatotroph or non-functional. Okay. So lectotroph, you will have with lectotroph cells, you'll have prolactinoma, increase in prolactin, and decrease in FSH. Right. Galactorrhea, amenorrhea, gynecomastia, decrease in libido. With the pituitary adenoma, you'll have somatotrophs, growth hormone, and TSH, and FSH or LH. These are your tyrotroph. That can't be right. But anyways, so that so if you have these, it's somatotroph, right? So corticotrophs are ACTH ones, and non-functional you'll have mass effect, headache, or bitemporal. That's just me putting it into charts for this. Okay, and then childhood ones. Childhood primary brain tumors. Uh, Pilocystic astrocytoma. Low-grade astrocytoma, most common primary brain tumor in childhood, usually well circumscribed. In children, most often found in posterior fossa. So in over there. For example, cerebellum. So it's going to be in the posterior fossa. It may be supratentorial, benign, good prognosis. Histology, it's going to be astrocyte origin, GFAP. It's GFAP positive. Okay. Bipolar neoplastic cells with hairline projections, associated with microcysts and Rosenthal fibers, eosinophilic corkscrew fibers. Okay. Cystic plus solid. So gross. Okay. Pleocystic astrocytoma. So astro, you gotta remember Rosenthal fibers and GFAP basically. I guess he gave us a story to remember that, but at this moment I don't remember it. So astrocyte. Gotta remember these because this is what you'll see in the question stem, and you gotta figure out it's pleocystic, pilocystic astrocytoma. Okay, medulloblastoma. It's most common malignant brain tumor in childhood. Okay, so tumor in the medulla. So commonly involves cerebellum. Never mind, not medulla then. It involves cerebellum. C. There. It can compress fourth ventricle, causing non-communicating hydrocephalus, which leads to headache and papillary edema. Can involve the cerebellar vermis and give you truncal ataxia. It can send drop metastasis to spinal cord. It forms primitive neuroectodermal tumors, PNET, homocyte rosettes, small blue cells surrounding central area of neuropil, or it's synaptophysin positive. Okay, so that's your uh, marker, homocyte rosette. Okay, and that's also seen in pheochromocytoma, I think, right? Okay. turn that off. Let me just go make sure about that one. Whoops. Neuroblastoma, that's where we saw it. Not pheochromo. Where's pheo? That's here. Okay, so we saw it over here, neuroblastoma. Okay, it's an amptophysin positive, so that should help you if they give you that. But if they give you just this, that should be a giveaway to medulloblastoma. Okay, appendomyoma, that's the one with the CSF stuff. So most commonly found in the fourth ventricle. It can cause hydrocephalus, poor prognosis. Ependymal cell origin, characteristic perivascular pseudo rosettes. So F, that's not gonna help us. Rod-shaped blepharoplast. Basociliary bodies found near the nucleus for this. Perivascular pseudorosettes. That's the buzzword for that one. Okay. Craniopharyngioma. So, wait, this was E. Okay. Craniopharyngioma, most common childhood supratentorial tumor. It may be confused with pituitary adenoma. Both causes bitemporal hemianopia. It's associated with high recurrence rate, derived from remnants of Rethke pouch, ectoderm, right? So that's why it's hard to differentiate. So if there are remnants of Rethke pouch, it's gonna, tumor of that is gonna be craniopharyngioma, because Rethke pouch makes the pituitary as well. I remember anterior, posterior, either of those. Okay. Calcification is common. G and H. Okay, so it's gonna look like that and that. Cholesterol crystals found in motor oil, like fluid with tumor. Okay. So remnants of Rethke. They might just give you that, and then you know it's this. Papilloma, it's Perrot syndrome. Okay, so pineal gland tumor. Most commonly extragonadal germ cell tumor, increased incidence in males, presents with obstructive hydrocephalus, compression of cerebral aqueduct. Perrot syndrome, compression of dorsal midbrain, will lead to triad of upward gaze palsy, convergence retraction nystagmus, and light near dissociation. So this is a triad you gotta look out for as well. Okay, nystagmus, light near dissociation, and gaze palsy. I don't know what this is. Gonna have to look it up. Sign that occurs when the pupillary light reaction is impaired while the near reaction, so common response remains intact. Okay. So that. It's similar to testicular seminoma. Okay. Seminoma was normal AFP, but increase in HCG, right? Beta HCG. It was increasing beta HCG and normal AFP for seminomas. Okay. Herniation syndrome. Okay. So this is the reason why we would have problems with uh, third cranial nerve. Remember I told you we'll do that. It gets compressed, so it's because of that right there. So there's compression of that. So we'll read about that. So herniation syndrome. This is the Fox cerebri, lateral ventricle over there, supratentorial mass, uncus, and tentorium cerebelli over here, and Kernohan notch over there, and direct hemorrhage over here. Okay, so the most important one is the uncle one. Okay, so one, cingulate or subfalcine herniation under Fox cerebri. It can compress anterior cerebral artery. Second, central or downward tentorial herniation. Okay, so second is downwards. It's caudal displacement of the brainstem. So this will lead to rupture of paramedian basilar artery branches, which will lead to direct hemorrhages. It's usually fatal. Okay. Third point is uncal tentorial herniation. So uncus, which equals medial temporal lobe. Early herniation will lead to ipsilateral blown pupil, unilateral cranial nerve 3 compression, contralateral hemiparesis. Okay. Late herniation leads to coma, Kernohan phenomenon, misleading contralateral blown pupil, and ipsilateral hemiparesis due to contralateral compression of Kernohan notch. Okay, so basically what it's saying is that since this thing is pushing this way, right, for the third one, so that's going to do that. So it's going to squish this over here. So you will get symptoms of this thing instead of, on the you'll get things on the ipsilateral, you'll see symptoms over there instead of the contralateral side, right? So it's late herniation will lead to coma and Kernohan phenomenon. Okay, so what is Kernohan phenomenon? Look that up. Compression of the contralateral cerebral peduncle, right? So it's since this is pushing this way, it's pressing on the contralateral side of the fibers that are connecting between coming in from the cerebellum, right? So that's why you get the contralateral one and tentorial and that diffusion tensor. Not important. Okay, so it's important to know the Kernohan phenomenon. Okay, so misleading contralateral blown pupil if you have that, and ipsilateral hemiparesis due to contralateral compression of the Kernohan notch. Okay, otherwise, in early herniation, it's on the ipsilateral blown pupil with the contralateral hemiparesis. But if it turns out to be, in later stages, it turns out that the person is going into coma, and then they have all of these, and then it's going to be this Kernohan phenomenon. So that's late herniation. Okay, so that's the important one that you gotta remember. And number 4 is cerebellar tonsillar herniation into the foramen magnum. Coma, death results with when these herniation compress the brainstem. Okay. Motor neuron signs. So signs: upper motor neuron lesion, lower motor neuron lesion, and comments. Okay. So lower motor neuron. Okay. So let's do this first. Upper motor neuron lesion, it's gonna be anything connected to the brain, right? And then lower motor neuron is from the spinal cord to whatever the neuromuscular junction is, wherever that is. Okay, So from brain to the spinal cord is going to be upper motor neuron lesion. So anywhere, if there's a problem over there, let me bring that down here. Okay. So motor neuron signs, upper motor neuron lesion. So that's this part right here, right? Anywhere along the red. You will have weakness. You won't have atrophy. You won't have fasciculation. You will have increase in tendon reflexes. You'll have increase in tone. You will have Babinski sign, positive. Spastic paresis. Okay, so that is condition muscular weakness caused by nerve damage or disease. Partial paralysis. Okay, and spastic is contraction, right? Some muscle spasms. Okay, so muscle spasm paresis. You'll get that in upper motor neuron. Okay, so I guess it's just gonna try sending signals, and some of them will get through or not. So it will depolarize some of it, and then it's not gonna sustain the depolarization. Flaccid paralysis. So there's no contraction at all. That's not gonna happen in upper motor neuron. And then you have clasp knife spasticity. That's positive in this. Okay, so upper motor neuron, everything is up. Tone, DTRs, that's deep tendon reflexes, and toes for Babinski. So tone is because of spasticity. Okay, so spastic paresis. Okay, it's not going to be flaccid, it's going to be spastic. Okay, so toes, tone as well, it's increased. Reflexes are increased as well. There's no fasciculation or atrophy, but there is weakness. Okay, in lower motor neuron junction, so over here, it's going to be, there is weakness here because now there's completely no connection to it, right? And atrophy is going to be there as well. Fasciculations are going to be there. Reflexes are decreased because now even if it senses stuff and goes to dorsal root ganglion, there's no way of it coming back down here, right? So it's decreased. Tone, it's decreased. Babinski sign is negative. Spastic paresis is negative because it's flaccid paralysis and lower motor neuron. And clasp knife spasticity is negative because it's flaccid anyways. So spasticity is going to be in the spastic paralysis column. So in lower motor neuron, everything is lowered. Less muscle mass, decrease in muscle tone. Right, less muscle mass because why? You're not using any muscles anymore. It's not getting stimulated, so it's going to atrophy. So lower motor neuron, everything's lowered. Decrease in muscle tone and decrease in reflex and downgoing toes. Fasciculations are muscle twitching, and it happens in lower motor neuron. And positive Babinski is normal in infants. Okay. Spinal lesions, area affected, disease, and characteristics. Okay, so in spinal muscular atrophy. Okay, so that's a congenital degeneration of anterior horns. So lower motor neuron symptoms only for this one. It's symmetric weakness, so floppy baby with marked hypotonia, right? So that's flaccid paralysis, so that's a lower motor neuron thing. That's one of these, right? Flaccid paralysis. And tongue fasciculations, that also happens in lower motor neuron, right? Fasciculations and lower motor neuron. So autosomal recessive, SMN1 mutation, uh, or spinal muscular atrophy and something, I don't know. Mutation, it will lead to defective SNRNP, right? That's the spliced one, assembly. So defective of that. So SMA type 1 is called Wernicke-Hoffmann disease. You don't need to remember that. You gotta remember that this one is you get spinal muscular atrophy over here, uh, in the anterior horn. It's congenital degeneration of the anterior horn that will lead to that lower motor neuron symptoms. Okay. ELS, that's amyotrophic lateral sclerosis, also called the Lou Gehrig disease. It's combined upper motor neuron because it's corticospinal and anterior horn as well. And yeah, so corticobulbar and corticospinal and lower motor neuron. Okay, so medullary. Okay, so that's why it's lower motor neuron. So medullary and spinal cord degeneration. No sensory or bowel bladder deficits. Okay. It can be caused by defect in superoxide dismutase 1, element deficit, so you have flaccid paralysis or weakness, fasciculation atrophy, bulbar palsy, dysarthria, dysphagia, tongue atrophy. Okay. So if you have both lower motor and upper motor, it's gonna be ALS because that's the only one that has symptoms of both upper and lower. Okay. Yeah. Okay. So upper motor neuron deficit, it's gonna give you spastic limb weakness, hyperreflexia, clonus, pseudobulbar palsy, dysarthria, dysphagia, emotional liability, fatal and it's fatal more often from respiratory failure. Okay, and treatment for Lou Gehrig disease is Riluzole. Riluzole. Okay, so here if you have upper and lower motor neuron deficits, then it's ALS, and if it's only lower motor, it's going to be SMA. That's anterior horn, and this is corticobulbar or corticospinal, right? So this and lower motor is the medulla. Okay, so medullary and spinal cord degeneration. Okay, so here we have complete occlusion of anterior spinal artery. Okay, so anterior spinal artery, if that's right over there, so if that is occluded, then all of this is gonna be affected. So you'll have the motor area and the sensory area, right? But not the dorsal one. So your dorsal ones are the proprioception, vibration, light touch, and all that stuff, right? And a little bit of pressure over there too. So complete occlusion of anterior spinal artery spares dorsal column and lesser tract. Mid-thoracic ASA territory is watershed area. So mid-thoracic one is the watershed area in this area. As artery of Adams Kievigs supplies ASA below T8. Okay, so below thoracic 8, it's this one that supplies it. And above it it's this one, so that's the watershed one. It can be caused by aortic aneurysm repair, presents with upper motor neuron deficit below the lesion. Okay, so below the lesion it's upper motor neuron deficit because of corticospinal tract, and your lower motor neuron deficit at the level of the lesion. Okay, so anterior horn, and loss of pain, temperature, sensation below the lesion because of spinothalamic. Okay, so anything below the lesion, it's gonna be upper and lower, and right, because this is below the lesion as well, so that's lower motor neuron deficit, and the upper motor neuron deficit at below the lesion as well. However, at the side of the lesion or the level of the lesion, it's going to be lower motor neuron deficit, right? So okay, so let me just draw that out. So we have one that's coming into the muscles. Okay, that's the muscles. And then another thing that's coming out of this and going upwards. Okay, and similarly, you have one on this side that's coming in, out of it, then coming in, then going up. Okay, so if the lesion is at, T5, so it's gonna cut this off. Okay, and this is T5 supplied to the muscles, or whatever it supplies to, whatever T5 supplies to. Okay, T4 was nipples, so somewhere below that. Or was it T10? I don't remember. Anyways, so if it was somewhere here, right there, okay, and it supplies, so it's gonna cut off everything below that, right? So all the nerves that are coming over here and here, all of them are gonna get affected. So upper motor and lower motor are gonna get affected for that one. But at this level, you get lower motor neuron deficit at the level of the lesion. Okay, because why? I don't know. Doesn't make sense to me right now. It did last time I read it, but right now it's not making sense. So let me read that again. So presents with upper motor neuron deficit below the lesion, so corticospinal tract, and lower motor neuron deficit at the level of the lesion because of the anterior horn. And right, so anterior horn is lower motor neuron anyways, and loss of that because of spinal thalamic. Okay. Tabes dorsalis. So this one is unique because it's only caused by syphilis. So it's caused by tertiary syphilis. Results from degeneration, demyelination of the dorsal column and roots. So it leads to progressive sensory ataxia, impaired proprioception, so that will give you poor coordination. You'll get a positive Romberg sign and absent deep tendon reflexes. It's associated with charcot joints, shooting pain, and Argyll-Robertson pupil. Cool. Syringomyelia is the syrinx expands and damages anterior white commissure. So this thing's going to expand and push into this, and so all the tracts over here are going to get compressed. So syringomyelia is a cystic cavity forming inside of this tunnel. Okay, so syrinx expands and damages anterior white commissure of spinothalamic tract, second order neuron. So bilateral symmetric loss of pain and temperature sensation in cape-like distribution. It's seen with Chiari 1 malformation. It can affect other tracts. We read about that in the beginning. Okay, so this one is similar to this tabes dorsalis, so you're gonna have to be able to differentiate between the two because it affects the dorsal as well as this one. Okay, but this one also affects the spinal or corticospinal or spinal tract. That's the corticospinal one. Okay, so subacute combined degeneration, SCD, demyelination of spinocerebellar tract. Okay, lateral corticospinal tract, and dorsal columns. Okay, so you get ataxic gait, peristalsia, impaired position vibration senses, so positive Romberg here as well, and upper motor neuron symptoms over here. Over here we didn't have upper motor or lower motor, symptoms. So if you have that, it's going to be vitamin B12 deficiency and not this. Okay. Also, you have paresthesia here. I guess it's still not that easy to differentiate, but if they give you upper motor neuron symptoms, so any of these stuff, you know, and that will give it away for this. Also for this one, they usually tell you that the dude or the person has been, on a diet for 3 years, because you have a storage of vitamin B12 in the liver for 3 years at least before it runs out. Quota equina syndrome. So that's that. It's compressed quota equina. Okay. So compression of spinal root L2 and below, often due to intervertebral disc herniation or tumor. Radicular pain, absent knee and ankle reflexes, loss of bladder and anal sphincter control, and saddle anesthesia. So you'll see all of these things, and that will tell you it's because of quota equina syndrome. Okay. Poliomyelitis. It's caused by poliovirus, fecal-oral transmission. It replicates in lymphoid tissue of oropharynx and small intestine before spreading via bloodstream to CNS. Infection causes destruction of cells in anterior horn of spinal cord. So lower motor neuron death. Okay, so anterior horn over there. So that's why you get the flaccid paralysis, right? Signs of LMN: asymmetric weakness versus symmetric weakness in spinal muscular atrophy. Okay, so you have asymmetric one, and this one you had symmetric weakness. Okay, so that one was also LMN. This is also LMN, but asymmetric on this one. Hypotonia, flaccid paralysis, fasciculation, hyperreflexia, and muscle atrophy. These are all just symptoms of LMN lesion. Okay. Respiratory muscle involvement leads to respiratory failure, and that's how people usually die. Signs of infection is malaise, headache, fever, nausea, etc. CSF shows increase in WBCs, lymphocytic pleocytosis, and slight increase of protein, but no change in CSF glucose. Okay, because viruses don't need glucose for energy. Viruses recovered from stool or throat. Okay. Brown-Sequard syndrome. It's hemisection of spinal cord. Okay, so half of it is uh, cut, and the other half is okay. So hemisection of spinal cord. So that should be easy to figure out if you remember the charts for the this one, because that's what we'll be looking at again. So first one is spinothalamic, second one is dorsal. Okay, and this one is corticospinal. Okay, so hemisection findings. First finding you'll see is ipsilateral loss of all sensations at the level of lesion. Okay. Wait, hemisection. Just gotta make sure that I know this. Is it half or full? Is hemisection half or is it like a full cut? I'm confused. Yeah, we'll figure it out here. Oh. Okay, yeah, it's just half. It's given here. I'm zoning out, man. Okay, so half of it is affected, right? So if it's on the right side, what will you see? So there will be ipsilateral loss of all sensation, right? On the right side, because let's see. If the thing is over here, so here, you're not gonna get any information coming in from this side, right? From the right side, if it's problem on the right side. Okay, got it. So ipsilateral loss of sensation at the level of lesion. So this is spinothalamic tract, right? And that's the one that brings in the pain and temperature one. And then you have the dorsal one for the pressure, vibration, and all that stuff. Again, if it's this side, it's not gonna send ascending fibers and signals through those fibers if this one is damaged. So that's why ipsilateral loss of all sensation at the level of the lesion. Okay, so loss of all sensation and element signs over there. Then number 2, it's ipsilateral element signs, flaccid paralysis at the level of lower motor neuron. Okay, lesion. Then you have ipsilateral upper motor neuron signs below the level of lesion due to corticospinal tract damage. Okay, so if this is damaged, that means when this comes down from here, it's going to cross and then come here, right? So it's not going to be able to do anything. So that's why it's upper motor neuron sign below the level of lesion, because it's still going to be able to do it to the side where it's attaching. So say if this was the one that's affected, right? So it's still coming from all the way here and to all the spinal cords, giving off the signal to all the spinal cord above this or until this, right? But right below this, it's gonna stop giving signals. Okay. Number 4. Okay, so that's number 3 on this side. Ipsilateral that, and 4 is ipsilateral loss of proprioception, vibration, and light. That's dorsal one. Set 2-point discrimination, touch below level of lesion due to dorsal column damage, right? And then 5th one is contralateral loss of pain, temperature, and crude non-discriminative touch below level of lesion due to spinothalamic tract damage. Okay, so the one that's coming from here and going across and then going up, so that's not gonna be able to do that either, because this one is destroyed. So yeah, so none of the fibers coming in from here is they're not gonna send the signal to the brain. Okay, so contralateral loss of pain, temperature, and crude, those are your spinothalamic one. Non-discriminative touch below the level of the lesion, so this one, due to spinothalamic tract damage. If lesion occurs above T1, patient may present with ipsilateral Horner syndrome due to damage of oculosympathetic pathway. Okay. Horner syndrome is not given here. I think it's somewhere else. And where was it? In Musk, I think. Okay. So done with that. Friedreich's ataxia. This is one of the trinucleotide repeat disorder. So GAA, that was like Lady Gaga, the way she walks. So Gaga's for GAA. Okay, so Friedreich's ataxia. It's autosomal recessive trinucleotide repeat disorder on chromosome 9 and gene that encodes frataxin, iron binding protein. It leads to impairment in mitochondrial functioning, degeneration of lateral cortical spinal tract, so you get spastic paralysis. Okay, spinocerebellar tract ataxia because of that, the cerebellum. Dorsal column, so decrease in vibratory senses and proprioception. Okay, so it's all of these areas, right? Uh, and dorsal root ganglion, so that's a lower motor neuron one. Okay, staggering gait, frequent falling, nystagmus, dysarthria pescavis, hammer toes, diabetes mellitus, hypertrophic cardiomyopathy, cause of death. It presents in childhood with kyphoscoliosis. In the question stem, it's gonna be a brother who died early, and he also had a Pascavis or kyphoscoliosis, and now this one he's like 19 or something, and he's also, having kyphoscoliosis or hammer toe or something like that, and then they'll give you that, and then they'll be like, if this is a genetic disease, what is the mutation in? It's because of trinucleotide repeat disorder on chromosome 9, which encodes frataxin. So you gotta know that. Okay. Staggering gait, frequent falling, nystagmus, dysarthria, pescavis, hammer toe, diabetes mellitus, uh, hypertrophic cardiomyopathy. And this is usually the reason why the younger brother dies. Okay, so pescavis has high arches. Okay, and this is a hammer toe. Okay, so Frederick is fretastic, or frataxin. He's your favorite frat brother, always staggering and falling, but has a sweet big heart. Ataxic gait. Okay. Common cranial nerve lesions. So cranial 5 motor neuron. Motor lesion of the fifth nerve. So that's your trigeminal nerve. So jaw will deviate towards the side of the lesion due to unopposed force from the opposite pterygoid muscle. Right. So remember the mastication muscles, they pull the mandible towards them and up, right? So when you don't have masticating muscles besides the lateral pterygoid, right? So besides that one, because that one protrudes the jaw, all the other ones pull towards the attachment. So when you don't have that, it's going to deviate towards the side of the lesion when it's at rest. Okay. So jaw deviates towards the side of the lesion due to unopposed force from the opposite pterygoid muscle. Okay. So if its lesion is on the left side, right. So if lesion is on the left side, jaw is going to deviate to the left side because why? Because it's getting intervention from the other side of the lobe, I guess. So ipsilaterally it's contracting, so that's why it's going that side, and this side is, I guess, the then. Okay, I'll sort it out later. Cranial nerve 10 lesion, its uvula deviates away from the side of the lesion. Okay, so weak side collapses and uvula points away. That's the 10th nerve, or the vagus nerve. Okay. Then 11th nerve lesion, weakness turning head to contralateral side, because remember that's accessory, so that supplies the sternocleidomastoid and trapezius. So turning head to the contralateral side of the lesion. So if the lesion is on the left side, right? So uh, the left side of the neck, SCM is going to contract, and that's going to turn the head to the contralateral side, right? Okay. Shoulder droop on side of the lesion because of the trapezius. Okay. Shoulder droop on the side of the lesion, so that one don't make sense to me now. All right, because it's a lower motor neuron. I don't know. Okay, I'll just memorize this. So when there's 10th lesion, you just gotta remember one of them, because then you can just figure it out from that, right? So head turns to the other side of the lesion from the lesion, right? So then you can figure out if it's the left side or the right side. 11th lesion. Okay, 11th nerve lesion. So now on to 12th nerve lesion, element lesion. Tongue deviates towards the side of the lesion, so you lick your wound. So lesion on the left side, then tongue goes on towards the left, and you lick the deviates towards the lesion, basically. Okay. So lick your wound due to weakened tongue muscle on affected site. Okay. Makes sense. Facial nerve lesion. Bell palsy is the most common cause of peripheral facial palsy. Usually develops after herpes reactivation. Uh, Treatment is glucocorticoids with or without the acyclovir. Most patients gradually recover function, but aberrant regeneration can occur. Other causes of peripheral facial palsy include Lyme disease, herpes zoster, so Ramsay-Hunt syndrome, sarcoidosis, tumors, for example, parotid gland, and diabetes mellitus. Upper motor neuron lesion and lower motor neuron lesions. So upper motor neuron lesion, that's lesion location, motor cortex connection from motor cortex to facial nucleus and pons. Okay. So upper motor neuron lesion. So which one is that? That's over here. Okay, so when that happens, this connection is going to the upper division and the lower division. The upper division, it's going over here and here. So this one is also getting innervated from this side. So that's why you won't see any symptoms on top of the face. It's only the bottom of the face that gets affected. Then you get a drooping over there, because the bottom one is only coming from this side, right? So if there's drooping on the other side of the face, but the top is normal, it's the contralateral side lesion. Okay, so affected side is contralateral. Muscles involved, lower muscles of facial expression. Forehead involved, it's spared due to bilateral upper motor neuron intervention. Other symptoms are variable, depends on the size of the lesion. Okay, so facial nuclei here and that. Okay, so what happens when there's a problem over here, right itself? Then you're going to see symptoms on top and bottom, right? So facial nucleus anywhere along the 7th nerve. Affected side is going to be on the same side of the lesion. Okay. Muscles involved, upper and lower muscles of the facial expression. Forehead involved, yes, it's affected. Other symptoms: incomplete eye closure, dry eyes, corneal ulceration, hyperacusis, loss of taste, sensation to anterior tongue. Because that's supplied by the 7th nerve as well, right? Okay. And the other side, the pain sensation, it was mandibular nerve of the trigeminal nerve of the anterior tongue. And that's it for today. Neuro, we're on to ears, otology, auditory anatomy and physiology. We have the auricle or the pinna, the external auditory canal. This is the tympanic membrane, and this is the inner ear, right? So, and this is the eustachian tube. Um, then you have the ossicles, the oval window over here, cochlea, vestibule over here, and these are the semicircular canals, right? So this is the external ear, the middle ear, and the inner ear is over here. The inner ear is the one with the cochlea. The middle ear is the one with the ossicles, and the external ear is everything outside of tympanic membrane. Okay, so outer ear, visible portion of the ear, the pinna, includes auditory canal and tympanic membrane. It transfers sound waves via vibration of tympanic membrane. Middle ear, it's air-filled space with three bones called the ossicles, malleus, incus, and stapes. Ossicles conduct and amplify sound from tympanic membrane to inner ear. Inner ear, snail-shaped. Right, so that's that right there. Fluid-filled cochlea. That's the one that converts the signals. It contains basilar membrane that vibrates secondary to sound waves. Okay, so this membrane that vibrates due to the sound waves. Okay, vibration transduced via specialized hair cells, which will give off auditory nerve signals, all the way to the brainstem. Each frequency leads to vibration at specific location on basilar membrane, so the tonotopy. Then, okay. All right. Low frequency heard at apex near helicotrema, wide and flexible. Just so we know what the structure is like, we'll look at that too. Okay, so wide and what was it? And flexible, right? So lower frequency are heard over here. Okay, let's see. It would be over here, but that's not in there. Okay, so over there. That thing. It's flexible and it's wide. And high frequency heard best at the base of cochlea. Okay, so at the base of that. It's thin and rigid. Okay, so this is the cochlea right there. It's thin and rigid. And the base of that. And this is the helicotrema. Okay. So far, nothing that important in this. Otitis externa. This is important. It's due to Pseudomonas aeruginosa. Okay. The hot tub folliculitis and all that stuff that happens because of that. And recurrent infection and cystic fibrosis, Cartagner, I think, as well. Gives off a blue-green pigment. Right. Okay, so otitis externa, inflammation of external auditory canal, most commonly due to Pseudomonas associated with water exposure, swimmer's ear canal trauma, occlusion, for example, hearing aid as well. It presents with otalgia that worsens with ear manipulation, pruritus, hearing loss, and discharge. Okay. Normally in the question stem, if it's anything to do with some kind of inflammation outside or, pain outside of or in the external auditory canal, it's going to be this that they're referring to, because nothing else for step 1 that happens over there. that consists of a disease or condition that you should know other than otitis externa. Ear manipulation, pruritus, hearing loss, and discharge. Malignant necrotizing otitis externa. This is invasive infection causing osteomyelitis. Complication of otitis externa, mostly seen in older patients with diabetes. Presents with severe otalgia and otorrhea. Physical examination shows granulation tissue in ear canal. Wasn't there a furuncle as well? That happens. Okay, so that would be, I guess, because of something else. Okay. Yeah. So otitis externa is due to Pseudomonas. Okay. Otitis media, inflammation of the middle ear. This one is important. It's the one inside of the tympanic membrane. Okay. So when they tell you that they did they looked at the ear and then the tympanic membrane is bulging and they see whitish hue or something like that behind it, it's gonna be otitis media. Yeah. Inflammation of the middle ear, most commonly due to non-typable H influenza, strep pneumoniae, Moraxella catarrhalis. Okay. It's associated with eustachian tube dysfunction, which promotes overgrowth of bacterial colonizers of upper respiratory tract, usually seen in children less than 2 years old. It presents with fever, otalgia, hearing loss. Physical exam shows bulging, erythematous tympanic membrane that may rupture. Mastitis, that's important too. It's infection of the mastoid process of the temporal bone. So complication of acute otitis media due to continuity of the middle ear cavity with the mastoid air cells. Presents with post-auricular pain, erythema, swelling. May lead to brain abscess. Okay. With this one, you need to know how an infection can lead to the brain, and it goes from the middle ear to the mastoid air cells to the temporal through the temporal bone into the temporal lobe, right? So if they tell you that this person has this and if not treated, where would you see infection later? That could be one of the complications. So that's how it would go there. So this one you need to know that it's due to H influenza, strep pneumoniae, and Moraxella catarrhalis. They'll give you like 6 options, and they won't have strep, they won't have H influenza, and then you forget that Moraxella also causes this, right? Catarrhalis, that's the one that actually causes the runny nose and all that stuff, the nose stuff, right? So, but remember these 3, okay? Oops. Okay. Common cause of hearing loss, noise-induced hearing loss. Okay, so it's damage to stereociliated cells and organ of Corti. Loss of. So first we need to know what that is. Okay, it's in the cochlea, I think. Inner ear located within the cochlea. Okay. So you would find it over there. So if you were to zoom into that, you would see something like this. Okay. So yeah. We don't need to know the anatomy of it, so it's okay. Damage to stereociliated cells and organ of Corti. Loss of high frequency hearing first. Sudden extremely loud noise can produce hearing loss due to tympanic membrane rupture. Okay, so important for people who go to music festivals. to bring like noise cancellation headphones as well for that. Uh, Presbycusis, that's age related. Okay. It's age related progressive bilateral symmetric sensory neural hearing loss, often of higher frequencies, due to destruction of hair cells at the cochlear base, preserved low frequency hearing at apex. Okay. Yeah, so presbycusis, it's age related. So they usually ask you a question that uh, they'll explain this and they'll ask you what's a similar mechanism in the body. Then they'll give you options like wrinkling, uh, and I don't know, growth of bone or something like that. So since this is due to aging and so is wrinkling, that would be similar to this, the mechanism of action. But it will make sense when you do like differentials of the options, and then you can isolate this one out because of that. Okay, diagnosing hearing loss, normal, conductive, and sensory neural. You have Weber test, you have Renin test. Okay, so Weber test, it's tuning fork on the vertex of skull. Uh, you need to know what that is. So it's like in the middle of your forehead, I think. Okay. So you would put it somewhere here, right? Bifidal, I don't know. Okay, anyways, so it's in the middle of the skull. Okay, so you put it there. So in normal, uh, or you can put it up there if you don't have hair. No localization. Okay, so and normally it goes to both ears. Okay. Uh, in conductive, so conductive is like bone conductions, right? So localized to the affected ear, decreased transmission of background noise. So you'll hear it in this a lot more because so basically the air. Hold on, let me figure this out. Right, so you're not hearing the air coming in, right? So the bone are gonna vibrate and they're gonna bring in the sound because of the vibration. So you'll hear this better because there's no air to cancel out the you know, the frequencies. So on this side there's air, so the bone and air both are gonna, you know, sort each other out and you won't hear it as loud. Over here you don't have air coming in to balance out the sound, so you'll hear the conduction a lot more on the affected side because of that. Okay, that's why it's localized to the affected ear, decreased transmission of background noise. In sensory neural, you don't have anything, right? Sensory is because of the cochlea, it's not able to convert the vibrations into sound signals. So when you do this, there's not going to be that much sound coming out of this. So you'll hear it better on this side because this is still functional. So localized to the unaffected ear. Okay. Due to decrease in transmission of all sounds. Okay. Then there's Renin test. So tuning fork in front of the ear to check the air conduction, and then you put it on the mastered process uh, to check the bone conduction, right? So first you're gonna check the air and bone. So normally, the air and the bone, the air you have a greater, uh, it's gonna be louder. The air conduction is gonna be louder compared to the bone conduction. Okay. So that's at the mastery process. So it's going there, and air is gonna be louder. So in conductive, remember it's the air one that's not happening. So there's some problem with the conduction of sound through the outer membrane and outer canal, auditory canal, and the to the middle ear as well. It's the inner ear that's okay, but the sound's not able to reach it through this. So sound can reach it through the bone, right? So when you do it on outside in the air, there's going to be trouble going in. Okay. But when you do it to the mastoid bone vibrates all the way to the inner ear. So it's going to be better. So bone conduction is louder than air conduction in conductive one. However, in sensory neural, air conduction is better than bone conduction. Okay. Why? Because the bone, it vibrates to this ear, but there's problem with the inner ear, right? But with the air, you actually have that going to the other side, and you hear a little bit more of the air conduction than the bone conduction over here. I think that's why air conduction is more than bone conduction in sensory neural. Because in sensory neural, no matter how much you put into this, it's not going to convert the sound, right? It's not going to be able to convert the sound into signals. So when you do it in the air, it travels to the other side and you hear a little bit more of that. So the brain thinks that you're picking up the air sound much louder than you would for bone, because bone, by the time it reaches the other side of the head, it would dissipate throughout the body. So you won't pick that up in the other ear. Okay, so that's why the air conduction is more in sensory neural. So that's how you differentiate which ear and where it lateralizes to. So in conductive deafness, it lateralizes to the affected ear, and sensory neural, it lateralizes to the unaffected ear. Okay, because sensory neural, that's basically CNS problem, right? So it doesn't sense and send signal to the, it's not able to convert the vibration into the sound signals into the brain. Okay. And in written test, normally it's AC more than BC, right? Air conduction is more than bone conduction. But then if you have something wrong with the tunnel where the air passes through, then it's going to be bone conduction more than air conduction. And this is conductive deafness. And in sensory neural deafness, you'll have air conduction more because it goes to the other side of the ear, and you hear that better than the bone conduction because the organ of Corti is not functional, or the inner ear is not functional. Okay. Cholesteatoma. This is abnormal growth of keratinized squamous epithelium in the middle ear, skin in the wrong place. Usually acquired, but can be congenital. Primary acquired results from tympanic membrane retraction pockets that form due to eustachian tube dysfunction. Secondary acquired results from tympanic membrane perforation, for example, due to otitis media that permits migration of squamous epithelium to middle ear. Classically presents with painless otorrhea, may erode ossicles and lead to conductive hearing loss. Okay. I'm gonna read that again. I got zoned out. Sorry. Actually, I will just look at that. So it's that. And what is it? It's keratinized squamous epithelium in the middle ear. So skin in the wrong place. Okay. It's usually acquired but can be congenital. Primary acquired results from tympanic membrane retraction pocket. Okay, so there's a retraction in the tympanic membrane that forms due to eustachian tube dysfunction. Okay. Or secondary acquired result from tympanic membrane perforation due to otitis media. Oh, okay, I remember that one. That permits migration of squamous epithelium to middle ear. Okay, classically presents as painless otorrhea, may erode ossicles and conductive loss. Let's look it up. So, abnormal collection of skin cells deep inside your ear. Okay. So normal. Retracted and perforated eardrum. and then you have cholesteatoma. Steatoma. Okay. Max cholesteatoma opening and cholesteatoma debris. Okay. Um, I don't think I came across any question of this. That's why I can't remember anything about it. Vertigo, sensation of spinning while actually stationary, subtype of dizziness but distinct from lightheadedness. Peripheral vertigo is more common than central vertigo. Okay. So what is peripheral vertigo? This is due to the inner ear pathology such as semicircular canal debris, benign paroxysmal positional vertigo, vestibular neuritis, Meniere's disease, endolymphatic hydrops. Okay, this is an important one, so you gotta know about this one. So it's endolymphatic hydrops, so increase in endolymph in inner ear. So you'll get the triad of vertigo. Again, this is a triad, so you gotta look out for this triad. Triad of vertigo, sensory neural hearing loss, and tinnitus. Okay, men wear vests. Uh, Findings: mixed horizontal torsional nystagmus, purely, never purely torsional or vertical, that does not change direction and is suppressible with visual fixation. Okay, finding mixed horizontal transortional. Okay, I'm gonna have to look that one up. What does torsional mean? That's just nystagmus. Okay, so horizontal torsional nystagmus, purely, never purely torsional or vertical. Okay. That does not change direction and is suppressible with visual fixation. Alright. So, Meniere's disease, you'll see vertigo, sensory neural hearing loss, and tinnitus. Tinnitus, that should be like a buzzword, because if you see tinnitus, then you gotta look out for these two things, and if you are given these two things, it's Meniere's. Okay. And then central vertigo, that's brainstem or cerebellar lesion. For example, stroke affecting vestibular nuclei, demyelinating disease, or posterior fossa tumor. Findings are nystagmus of any direction that is not suppressible with visual fixation. Neurologic finding, for example, diplopia, ataxia, and dysmetria. Okay, so here, central vertigo, it's brainstem or cerebellar lesion. For example, stroke affecting vestibular nuclei, right? So it's not coming from the inner ear, it's now in the central, something with, either the brainstem or the cerebellum, right? Demyelinating disease or posterior fossa tumor, right? So posterior fossa tumor, it's usually in the cerebellum. Findings are going to be again nystagmus of any direction that is not suppressible with visual fixation. So when you're looking at something, it stops. So if that doesn't happen, it's this. And you'll have neurologic findings as well, right? So they'll give you either of these. If they give you ataxia, then you know it's something to do with central anyways. Dysmetria was what? Right. Okay. And on to ophthalm. So this is the normal eye anatomy. Okay. You have the macula, the physiologic cup, the optic disc, retinal artery and retinal vein over here. The vein is the darker one, artery is the lighter one, and the fovea right here. If you were to look at this, the important stuff is right up here. So the ciliary body, and the lens, which are attached to each other by zonular fibers. Then you have the cornea over here, and this is the one that makes iris. Okay. Uh, the area out here, near the pupil, right? That's the anterior chamber. Between the iris and the lens, you have the posterior chamber. Okay. Uh, this is all the anterior segment. Then you have the posterior segment. The posterior segment consists of the vitreous chamber, where you have the vitreous humor, the optic disc, the central and retinal artery, and optic nerve, fovea, or the blind spot that our brain just hides and has accommodated, so you don't really notice it unless you draw a paper, a dot on the paper. Actually, let me show you. It's pretty cool. I don't know if you can find it, but I'll give it a try. So let's see. Place your right thumb next to your left thumb. Keep looking at the left thumb and slowly move your right thumb to the right while looking at your left thumb. When your right thumb disappears, you found your right eye's blind spot. So if you want to try that right now. I think I have superpowers. I'm gonna try this. Okay, so yeah. I remember this thing. You were supposed to look at one and then cover your left eye at the plus sign. Move closer or further away to find where the circle disappears. Okay. So you just go close to your screen or away until the circle disappears. And you'll find the blind spot. Okay, I found it. It worked. This one works for me. Okay. It's pretty cool. Back to the thing. You can do that over the break. Okay. So on to conjunctivitis. Conjunctivitis it has itis on it, so that's inflammation, and conjuncta, so it's inflammation of the conjunctiva. Right. So red eye. It could be because of allergy, so itchy eyes or bilateral or bacterial. You'll have pus. It's treated with antibiotics, and it could be viral. This is the most common, often adenovirus. Gotta remember that one for the virus. Okay. Sparse mucus discharge, swollen periauricular node, increase in lacrimation. It's self-resolving. Okay. Refractory errors, common cause of impaired vision, correctable with glasses. So hyperopia, also called farsightedness, right? Okay, let's look at these. Okay, so hyperopia is called farsightedness, right? Because the focal point is far from this, okay? Far behind this or whatever. Or, yeah. So also called farsightedness, eye is too short for refractive power of cornea and lens. So light is focused behind retina. Correct with convex or converging lens. Okay. Let's see. So So since it's far, if you put a convex lens, it's gonna be uh, on that, on the retina. Okay. Myopia, also called nearsightedness. So it's far too short, the focal point in front of the retina. So also called nearsightedness, eye too long for refractory power of cornea and lens, so light is focused in front of the retina. Correct with the concave or diverging lens. Okay. So the way I remember it is, if this, I just look at the front of these. Okay. So if that is pushing inside, that means it's gonna push the focal point that way. So if you, that's towards the retina, right? So focal point from here to there, you needed to push it that way. So that means for the lens, you gotta push it inwards. So that's a concave lens, right? Over here, since it's too far behind, you gotta pull it back in. So if you pull the front of the lens this way, you gotta pull, it will come back towards the retina, right? So that makes it a convex lens. Or you can just memorize it if you have good memory power. Or if you have glasses, then it's even easier to understand this. Okay. And then you have astigmatism. That's abnormal curvature of the cornea. So it's different refractive power at different axes. So correct with cylindrical lens. Okay. Lens disorder, presbyopia. So just like presbycusis, this is due to age-related as well. So age-related impaired accommodation, focusing on near objects, primarily due to decrease in lens elasticity, right? So patients often need reading glasses or magnifiers because of this. However, if someone has a refractive error caused by tightness of this, so this is like spread out over time, eventually when they get older, this gets looser, right? Because they lose the elasticity. So when this comes back in, they feel like their eyesight is improving uh, as they grow older, and they'll have like an improved eyesight, maybe even like lose the glasses at that point, and they'll be like, it's a miracle, but it's just old age that's doing that, and it's called presbyopia. Okay. uh, Let me just confirm that theory. Okay, I don't want to go down the rabbit hole, but it happens, so just keep it at the back of your mind. Cataract, painless, often bilateral opacification of lens. Okay, can result in glare and decreased vision, especially at night, and loss of the red reflex. It's acquired risk factors. So acquired risk factors are increase in age, tobacco smoking, alcohol overuse, excessive sunlight, prolonged glucocorticoid use, diabetes mellitus, trauma, and infection. There's also congenital risk factors. These are your classic galactosemia, galactokinase deficiency. Okay, so notice how there's nothing to do with fructose, right? But why diabetes mellitus? Because of sorbitol, right? So remember that. And sorbitol gets metabolized to fructose. Okay. Uh, from biochem. So classic galactosemia, galactokinase deficiency, trisomies are 13, 18, and 21. So that's Down syndrome. Uh, no, that's Down syndrome. This is Patau's, and 18 is Edwards. Okay. Torch. So Patau is the one with the capitis aplasia, right? And this is the rocker hand or rocker feet or whatever. Torch. Infections, for example, rubella. Okay, so rubella will cause this. Marfan syndrome, uh, Elport syndrome. So Marfan's the one with the tall, you know, problem with the fibrillin. Elport, the airport syndrome, so basement membrane of the kidney and the lungs. Changes. It has a problem with the collagen type 4 in the basement membrane. Myotonic dystrophy. Uh, myotonic dystrophy. Is that the can't terminate grip one? Okay. Yeah, so that's the one. CTG repeat one. That's myotonic dystrophy. So that's the one where if they, shake your hand, they can't let go, or they open a door, but then they can't let go the doorknob. Um, then neurofibromatosis 2. So we did that in CNS just now. Treatment is surgical removal of lens and replacement with an artificial lens. Okay. Lens dislocation, also called ectopia lentis. Okay, so that happens in Marfan's and homocystinuria. Displacement of malposition of lens, usually due to trauma, but may occur in association with systemic disease. For example, this and this. So in Marfan, it fans upwards and outwards, and over here it's downwards. So if lens is dislocated downwards, it's going to be this. If it's upwards, it's going to be this. Aqueous humor pathway. So you have, for this, let's look at this first and then we'll read about it. So we have sclera, cornea, the anterior chamber, and this would be your iris and the lens, and then you have the posterior chamber right here, right? Um, at the corner of the anterior chamber, you have a canal called the canal of Schlemm. That's where you have the meshwork. Okay. So what is the meshwork in the eye? Okay, so this thing right here that you're seeing, that's the meshwork, and then it drains out into the uh, canal of Schlemm or whatever. Okay. Let me do a thing over here. So this is the iris. Okay, so this is the angle. Uh, that's not the trabecular meshwork. That's wrong. Hold on. So this would be the meshwork, and all of that goes into a tunnel over here or canal over here, and that's the canal of Schlemm. Okay, so you need to know that everything, the fluid drains through this meshwork. Meshwork is just something net-like or reticular-like or something like that. So this net-like thing right here, so it's gonna filter it, and then it's gonna go through this thing that's behind this, and that whole thing is called the canal, and it's going to accumulate there, and then it's going to drain out of the canal of Schlemm. Okay, as long as that is clear, we can move on. Okay, so there's the iris, and between the iris you got the pupil. Okay, so this is the trabecular meshwork. Okay, and behind that you have canal of Schlemm, and then so all the fluid will get drained, filtered out into this, and then from here it goes out. Okay, over here this is the ciliary body. This is the fibers attaching the lens, and that's it. So let's do this now. Trabecular outflow. So draining through the trabecular meshwork to the canal or Schlemm. From there, it goes to episcleral vasculature. It increases with M3. That's a muscarinic agonist. Okay. For example, carbachol or pilocarpine. Okay. Let's bring those over here. Okay. So we're gonna be looking at these and this actually. So let's bring this much back there. Okay. So increases with there's draining. It increases with, or trabecular outflow. It increases with M3 agonist. So this is M3. It uses the Q method. So GQ, right? What does GQ do? It uses the PIP IP3 DAG method with the calcium and all that stuff, right? So it increases exocrine gland secretion. So you can imagine if all of this water is coming out, you're gonna get that increase, right? So increase in lacrimal, sweat, and salivary gastric acid. Increase in gut paralysis. Increase in bladder contraction, bronchoconstriction. Increase in pupillary sphincter muscle contraction. That's an important one. Ciliary muscle contraction as well. Okay, so if this is going to contract, it's going to push everything in here and through here as well, right? Increase in insulin release and endothelium mediated vasodilation. Okay. Other than that, here I don't think M3 is that important. It's only important in like the bladder and this one thing right here. Okay. Uveoscleral outflow. Okay, so instead of going through the canal or Schlemm, it goes straight out from here. So uveoscleral outflow, this is drainage into the uvea and sclera. It increases with prostaglandin agonists like latanoprost and bimetoprost. Then you have aqueous humor. Okay, over here. It's produced by the non-pigmented epithelium on ciliary body, so decreased by beta blockers. Okay. So beta blockers right here. So let's see. Right here, it increases aqueous humor production, right? So if you block beta 2, it's gonna decrease aqueous humor production, right? It's over there. So it's produced by non-pigmented epithelium on the ciliary body. It's decreased by beta blockers like timolol. So A2M was cardioselective, right? So N2Z are non-selective beta blockers. So it's gonna be anything in between N2Z. Okay, so T is in between N2Z alphabetically, so it's gonna be cardio non-selective. Just a throwback to that. Alpha 2 agonist. So it decreases by alpha 2 agonist. So alpha 2 agonist normally does what? It decreases aqueous humor. So if we have an agonist for alpha 2, it's gonna increase its effect. So it's gonna, further decrease the aqueous humor production. So A2 agonists like brimonidine and carbonic anhydrase inhibitor as well, with like acetazolamide, right? So when we did that drug, this came there as well as a treatment, I think. But we did that in renal. Let me see. Clinical use, yeah. So glaucoma, right? Glaucoma is increase in pressure in the eye. So when you decrease the aqueous humor production, at least it won't increase any further, right? That's why it's used there. Okay, on to iris over here. So iris, the dilator muscles are alpha 1. Okay, so alpha 1 causes dilator muscle contraction. Okay, so increase in pupillary dilator muscle contraction. So it causes mydriasis, right? And sphincter muscle. So M3 here. You have ciliary muscle contraction. Okay, so it causes accommodation, and pupillary sphincter muscle contraction, meiosis. So to know about these, it's easier to look at a picture and understand it. Okay, so pupil constricts as circular muscles of iris contract. Okay, so these things. Okay, and you can also get dilation because of this. Okay, so one is sympathetic, and this is the parasympathetic, and the other is sympathetic, right? So pupil dilates as radial muscles of iris contract. Okay, so it's sympathetic, this thing, and that's why M3 is over here, and these are your cholinergics, and these are your adrenergics. Okay, so okay, so cholinergics are your parasympathetic ones. Okay, and because how do you remember that meiosis is parasympathetic? It's because when you're relaxed, uh, you don't have the fight or flight response, right? You are relaxed, so you don't need that much light coming into your eye, you don't need that much information. But when you're in your fight or flight response, you need the majority of information coming in your eye, so you have more light coming into your eye. So that would be sympathetic. Okay, like that. All right. That's it for that. A lens, suspended from ciliary body by zonular fibers. Muscular fibers in ciliary body affect lens shape and position. Glaucoma, optic neuropathy causing progressive vision loss, peripheral, then central. Usually, but not always, accompanied by increase in intraocular pressure. Etiology is most often primary but can be secondary to an identifiable cause, for example, uveitis or glucocorticoids. Fundoscopy will show optic disc cupping, so this is normal. Uh, the circle they're showing you is just the thing you gotta focus on, so that normal, and then here you see it thinning out, right? And that's called cupping. Okay, so what was I? Fundoscopy, optic disc cupping, normal versus thinning of the outer rim of optic disc. Treatment is pharmacologic or surgical lowering of IOP. Okay, so there are two types of glaucoma. Uh, there's open and angle closure. So let's look at that. So in open, it's when this is increased and this is open angle right here. So going into the trabecular meshwork, right? In closed, this axis is closed basically. That's why it's closed angle. Okay, so trabecular meshwork is here, and now this is closed. So how would that happen? It could be because there's open increase in pressure over here, pushing the iris outwards and closing that, right? Why would this happen? Increase amount of this, or it could be something else. So we'll look at that. So in open angle, which is this one, Anterior chamber angle is open, so normal. Most common type in US, associated with increased resistance to aqueous humor drainage. Okay, so it's not being drained, it's not going into the trabecular meshwork. Let me just bring that over there. Alright, so it's not able to go through here because the nets are increasing resistance. Drainage through trabecular meshwork. Okay. Risk factors: increase in age, race, increased incidence in black population, family history, and diabetes mellitus. Typically asymptomatic and discovered incidentally, right? Yeah. And then you have angle closure, glaucoma. Okay, so that's closed angle. So this is normal, and here we have a closed one because of that. Okay, give me a second. Okay. Usually chronic and asymptomatic, but may develop acutely. Sorry, where was I? Over here. Okay, so I was explaining that, right? So that and this. So iris, closed angle, trabecular meshwork, and ciliary body. Okay. So anterior chamber angle is narrowed or closed. So it's associated with anatomic abnormalities. For example, anteriorly displaced lens resting against the central iris. Okay. So this lens, it could be that it's you know pushing into the iris, and then iris is pushing into the cornea and closing this angle, right? So associated with anatomic abnormality, for example, anteriorly displaced lens resting against the central iris. This will lead to decrease in aqueous flow through the pupil, so it won't be able to. This flow won't be able to go through here. Okay. So then what happens is the fluid is going to build up here, and that's going to push this iris into this as well. So that will happen, I guess. That's how that happens. Okay, so it's not that lens is pushing it as much as the fluid is going to be pushing this into this and closing this angle. Okay, so again, decrease in aqueous flow through the pupillary block will lead to pressure buildup in the posterior chamber, causing peripheral iris pushed against cornea, causing obstruction of drainage pathway by the iris. Usually chronic and asymptomatic, but may develop acutely. Okay. So acute angle closure glaucoma. This is complete pupillary block causing abrupt angle closure and rapid increase in IOP. Okay, so complete pupillary block, that means the pupils are blocked up, right? The pupil is between the iris, so that is blocked. So the fluid, the aqueous humor, whatever, it's gonna build up over here and increase in IOP. So that's gonna cause the angle closure. So again, acute angle closure glaucoma, complete pupillary block, again causing abrupt angle closure and rapid increase in IOP. It presents with severe eye pain, conjunctival erythema. Okay, that just means like redness of the eye. In the this, it's not called conjunctivitis because it's not inflammation. It's just that it's increase in pressure is causing this, and it's causing pain. Sudden vision loss, halos, and light headache, fixed and mid dilated pupil, nausea and vomiting. So hurts in a hurry with halos and a headache, and a half dilated pupil. Uh, True ophthalmic emergency that requires immediate management to prevent blindness. Mydriatic agents are contraindicated. So acute angle closure is an emergency uh, condition. You gotta treat it right away to prevent blindness. Okay, done with that. So they give a photo for this. Anyways, now that we need it, we'll look at it one more time. open angle glaucoma. So comes from here, the aqueous flow, and then it goes into this, and then it's not able to go through, so then it's going to build up in the anterior chamber. Okay, so there's increase in trabecular outflow resistance and angle closure glaucoma. The pupillary block is happening, right? So this fluid is not able to go anywhere, so it's going to stay here, build up, increase the pressure, pushing the iris into the cornea, blocking the trabecular meshwork. So now it's obstructing obstruction of drainage pathway by the iris. Retinal disorder. So you can get age-related macular degeneration. Actually, let's bring these up there. Okay. So age-related macular degeneration. We know what macula is, right? We saw it up here. That's macula. Okay. Around the fovea. Okay. So age-related macular degeneration. Degeneration of macula, central area of the retina, leads to loss of central vision or scotomas. Okay, so you need to know what that means. Okay, so like that, central vision. So that's a scotoma right there, right? So this is a normal view, and then here you have a little black spot over there, so that's scotoma. Okay, so degeneration of macula, central area of retina, loss of central vision, so scotoma. Two types, it could be dry or wet. Dry is the most common one. It's a gradual decrease in vision with subretinal deposits known as drusen. Arrow in A. So those things that you're seeing. And then there's wet. Rapid decrease in vision due to bleeding secondary to choroidal neovascularization. Distortion of straight lines, metamorphosia, is an early symptom. They usually ask you about cherry red ones. They won't give you a photo for these. Actually, they do give it to you, but it's gonna be, something very obvious like this one, or something like this. This is also obvious, so I guess, yeah, do these. Diabetic retinopathy, chronic hyperglycemia, leads to increase in permeability and occlusion of retinal vessels. There are two types: non-proliferative, most common, and then there's proliferative as well. So non-proliferative is the one with microaneurysms, hemorrhages in B. Okay, so little hemorrhages like that and that. Can't really see it in this one. Okay, I see it now. So with this thing, that and that. Okay, so microaneurysm, hemorrhages, cotton wool spots, and hard exudates. This is the buzzword, cotton wool spot. If they tell you it's diabetic retinopathy, okay, non-proliferative type. So hard exudates, vision loss mainly due to macular edema. Then you have proliferative one, that's retinal neovascularization due to chronic hypoxia. Right, it's proliferative because it causes neovascularization. So it's due to chronic hypoxia because of, I guess, the hemorrhages. So abnormal new vessels may cause vitreous hemorrhage and tractional retinal detachment. Okay. Hypertensive retinopathy, chronic hypertension, spasms, it will cause spasms, sclerosis, and fibrinoid necrosis of retinal vein. Fundoscopy will show atriovenous nicking, microaneurysm, hemorrhages, and cotton wool spots. So blue arrow in C. Okay, so that. Hard exudates may form a macular star. Okay, so when they talk about the macular star, that's the buzzword for this hypertensive retinopathy. Cotton wool spot is in this too, but normally when they give you that, they're talking about this one for non-proliferative one. If they're talking about new vessels formation, it's gonna be proliferative one. For this one, it's the star. Presence of papillary edema, which is indicative of hypertensive emergency and warrants immediate lowering of blood pressure. Okay. Retinal artery occlusion. Also, you gotta be able to figure out hypertensive just from the photo. You gotta look for these things. Okay. The blue arrow is the cotton wool spot, right? That's similar to this little white stuff you're seeing. And then this, ripping type of pattern, which is the macular star. Okay. Retinal artery occlusion. So it's the blockage of central or branch retinal artery, usually due to embolism. Carotid artery atherosclerosis, more than cardiogenic. Okay. So it's more common because of that than because of this. Less commonly due to giant cell arteritis, right? That's the vasculitis that causes temporal headache and blindness, and it can lead to blindness in eye, and it's unilateral. Okay. It presents with acute painless monocular vision loss, fundoscopy, cloudy retina with cherry red spot at fovea. Okay, so if you have that, that's a cherry red spot, and it's due to retinal artery occlusion. Okay. Okay. Identifiable red emboli. For example, cholesterol crystals appear as small yellow refractile deposits in arterioles. So here the buzzword is this cherry red spot. It's also for a buzzword for the Niemann-Pick and Tay-Sachs. However, for that they'll give you some other stuff. But if they give you a photo like this and they're asking you this, you won't have those in the option. You'll have these stuff, hypertensive, diabetic, or all of this stuff, and then you gotta figure out which one it is. So cherry red spot is buzzword for retinal artery occlusion. And if you see it like that, you see a red spot, that's what it is, retinal artery, and it's occluded. Okay. Okay. For this retinal vein occlusion, that will be this thing. For vein, it's something that you're trying to drain, right? But if it doesn't drain, it's gonna stay in the vessel, and then eventually vessel gonna start dilating, right? So this is dilated retinal vein. Okay. So central retinal vein occlusion is due to primary thrombosis. Branch retinal vein occlusion is due to secondary thrombosis at the atriovenous crossing. Sclerotic arterial compresses adjacent manules, causing turbulent blood flow. Okay, so fundoscopy is going to be retinal hemorrhage and venous engorgement. So this is called venous engorgement. Okay, and you see little spots, the red spots, those are retinal hemorrhages. Okay. And this thing looks like a thunder, right? So blood and thunder appearance. So blood from the hemorrhages and thunder because of the veins. Appearance in arrow in E. Retinal edema in affected areas. So retinal detachment, separation of neurosensory retina from underlying retinal pigment epithelium, leads to loss of choroidal blood supply, which leads to hypoxia and degeneration of photoreceptors. There are two types. It could be rectomeganeous or non-rematogenous. Okay. Uh, Basically, it's detachment of that, right? The whole retina. So this thing that's more common, it's due to retinal tears, often associated with posterior vitreous detachment, increased risk with advanced age, and high myopia. Less frequently traumatic. Non higmatogenous is tractional or exudative. Okay, it's fluid accumulation. Okay, commonly presents with symptoms of posterior vitreous detachment, for example, floater and light flashes. So these are the buzzwords for retinal detachment. If you see floaters or light flashes, right, followed by painless monocular vision loss, so dark curtain, right, fundoscopy, opacification, and wrinkling of the detached retina. So you see this wrinkling, that's the detached retina. So if you see something like that, it's gonna be retinal detachment. Uh, Change in vessel direction as well. Okay. And it's a surgical emergency. Retinitis pigmentosa. It's a group of inherited dystrophies causing progressive degeneration of photoreceptors and retinal pigment epithelium. Okay, so that's why you see dark stuff because it's getting depigmented. So retinal pigment epithelium, uh, atrophied, right? It may be associated with A beta lipoproteinemia. That's important from GIT, remember? You don't have the lipoproteins, right? So the fat is it's gonna get absorbed, but it's not gonna get transported from the intestinal epithelial to the blood to the liver, right? So it just gets accumulated there. So you see fat cells at the brush border, uh, buildup of adipose tissue and all that stuff, or cells actually, right? So that's what you will see. So fat is just there under the epithelium and all that, right? Because it can't be transported because there are no lipoproteins to transport it. So early symptoms are night blindness, nyctalopia, and peripheral vision loss. Fundoscopy, triad of optic disc pallor, renal vessel attenuation, and retinal pigmentation with bone spicule shaped deposits. Okay, so if you see like this, blackening of black pigment on top of the red pigment, it's pigmentosa. Okay, retinitis pigmentosa. It's associated with this, so know that. Okay, papilledema. It's optic disc swelling. So you see optic discs in all of these, right? Uh, this and this, that. So over here, if you see it, it's swelling of that, right? So optic disc swelling, usually bilateral, due to increase in intracranial pressure. For example, secondary to mass effect. So it's just the structure physically causing this increase and, or causing this papilledema. It results from impaired exoplasmic flow in the optic nerve. Fundoscopy, elevated optic disc with blurred margin. Okay, so here you can make out the margin, right? Over here and here as well. But here you can't make out the borders, which one's thin and where does the central portion start and end. So that. So don't confuse this one with this, because they look similar, right? Because there's a little thing over there, but that's not because of occlusion, it's because of the pressure of the intracranial. Okay, so learn how to differentiate from the photos. Okay. Okay. Leukocoria. This is because of retinoblastoma and uh, loss whitening of the red reflex. Okay, so important cause in children included retinoblastoma. It's congenital cataract. Okay, so that's what it is. Um, so remember that congenital cataract is what happens in leukocoria, and it's a sign of retinoblastoma. So there was a story how someone was posting pictures of their child and they were confused why one eye would be red and the other would be white, and then someone in the comments told them they should get their eyes checked, and then it's because it's a sign of retinoblastoma. Okay, so you see how there's a whitening, or you know, the red reflex is gone, so that uh, so untreated. So see how in normal photo, this is what you would see, right? Redness in the eye. There's a little tool in iPhone that you can fix it with, the redness, but it doesn't fix the white one, and so you end up with something that looks like this. The other one's black, but this one's gonna be white. Okay, so that's retinoblastoma, and in the question stem, that's how they're gonna explain it. That when they took a child has lost the red reflex, or there's whitening of the lens or something like that, but it means the same thing. It's whitening because of the congenital cataract, and it's red, a loss of red reflexes because of leukocoria. Okay. uh, Uveitis. There's also, I think, a website for retinoblastoma where people would upload photos and then they would, you know, there used to be, I don't know, there's a story there too for around the time. Uveitis, inflammation of uvea, specific name based on location within affected eye. Okay. It's just, you know, build up of stuff over there. So it's inflammation of uvea, specific name based on location within the affected eye. Anterior uveitis, so iritis or posterior uveitis, so choroiditis and or retinitis. May have hypopyon, that's accumulation of pus in anterior chamber, so that's what you're seeing here. Or conjunctival redness associated with systemic inflammatory disorder, for example, sarcoidosis, Behet syndrome, juvenile idiopathic arthritis, HLA-B27 associated conditions. So when we were reading about all of these conditions, they told us about uveitis, so now they just, you know, put everything here under uveitis. Pupillary control, meiosis. Okay, so meiosis is constriction, and it's parasympathetic. Remember, it's when you're uh, relaxed. It's a PNS, parasympathetic one. Okay, so circular muscles of iris contracted, causing a constricted pupil. Okay, so constriction of that will cause meiosis. Okay, first neuron is Edinger-Westphal nucleus to ciliary ganglion via cranial nerve 3, and then second neuron is short ciliary nerves to sphincter papillae muscles. Short ciliary nerves shorten their pupil diameter. And that's how you remember that. So short ciliary nerves to sphincter pupillae muscles. So these ones are the ones responsible for meiosis. Okay. Let's look at what that is. So these are the constrictor muscles over here, and these are the dilator muscles, the one where um, the mydriasis will happen because of. Okay. So this ones are at the center. So if you look at it from here, that would be this part right here. The sphincter ones, and the dilator ones are these, the one outside of it. So that's over here in the iris. Okay. Right. So before we do that, let's do mydriasis now. So this one goes to Edinger-Westphal. So that's Edinger-Westphal right there. Okay, so from here it's gonna then travel upwards into this through whatever second neuron is at over there. Okay, then dilation, which is a sympathetic one. It was sympathetic was M1, M2. Which one was it? M3, right? No, alpha 1. Sorry, and M3 is for the sphincter one. So alpha 1 is the dilator one causing mydriasis. Dilation sympathetic. First neuron is hypothalamus to ciliospinal center of Budge, C8 to T2. That's where it is. And then second neuron exists the T1 to superior cervical ganglion, travels along cervical sympathetic chain near the lung apex, and then subclavian vessel. Okay, and then third neuron is plexus along the internal carotid through cavernous sinus, enters orbit as long ciliary nerve to pupillary dilator muscles. So we just looked at those. Sympathetic fibers also innervate smooth muscles of eyelids, minor retraction, and sweat glands of forehead and face. So because of this, that's how Horner syndrome happens when this pathway is obstructed, or there's a lesion in this pathway, because then it will be opposite of all this, right? We'll look at that. So long ciliary nerves make the pupil dilator longer. So Horner syndrome is right here. We'll do that now. So Horner syndrome, sympathetic denervation of face. So you have ptosis, that slight drooping of the eyelid, superior tarsal muscle. Then there's meiosis, because now it can't do mydriasis, right? That's why it's meiosis, pupil constriction. Anhidrosis, that's absence of sweating, and flushing of affected side of the face, right? Because it goes there as well, sweat glands of forehead and face. Okay, so anhidrosis, absence of sweating, and flushing of affected side of face. Okay, so it's associated with lesion along the sympathetic chain. So sympathetic chain, it's going to be similar to that. So first neuron here, however, it's going to be different. So it's pontine hemorrhage, lateral medullary syndrome, spinal cord lesion above T1, for example, Brown-Sequard syndrome, and late stage syringomyelia. Okay, but then after that happens, it comes down here at T1, right? So over here you'll find like something that happens over here. So these are the lesions that they're talking about. Stellate ganglion compression by Pancoast tumor, right? And then third neuron, that's this third one right here. So anywhere there. So carotid dissection, painful, and hydrosis is usually absent. So it's coming from here, hypothalamus, that's the first neuron. Going here, synapses in the lateral horn, and the like around where T1 is. Okay, and then from there it's gonna go into the second neuron, into the, what is this, superior cervical ganglion. Okay, and then here you have the bifurcation of the carotid, right? So that's why it's something to do with that. Carotid dissection, so that's going to compress it and all that stuff over there. Okay, and then from there it goes up into the eye, the face, and all that stuff. So to the sweat glands of the forehead, to smooth muscles of the eyelid, to pupillary dilator, and long ciliary nerve, ophthalmic division of trigeminal nerve. Okay. For Horner, I think in the old book there's a mnemonic for it. It was PEM is horny. So P for ptosis, A for anhydrosis, and M for meiosis. So PEM is horny for Horner syndrome. That's what it was. Okay. So those three things you gotta remember. Okay, so that's ptosis, anhydrosis, failure to sweat, and that's the problem with sympathetic chain or to the one side of the face. This is what ptosis looks like. So if they give you a photo of something like this, you should be able to figure out that it's ptosis. Okay. The sunset sign. Is different. Okay. Never mind. Okay. And yeah. So back to this. Pupillary light reflex. Light in the retina sends a signal via optic nerve or the second cranial nerve to pretectal nuclei, dash line, and image. In midbrain, that activates bilateral Edinger-Westphal nuclei. Pupils constrict bilaterally, direct and consensual reflex. It results in elimination of one eye, results in bilateral pupillary constriction. Okay. Okay, so we have visual field over here and this and all this stuff. You should know how this works. And if there's a lesion, hold on, did they do that? If they did, I'll just do it there. Yeah, visual defect. So we'll talk about it when we get here then. Okay. So light in either retina sends signal through the optic nerve to pretectal nuclei. So this is the optic nerve going to the pretectal nuclei. That's over here. Okay. The dashed line in the images. Okay. In the midbrain, that activates bilateral Edinger-Westphal nuclei. So then pupils will constrict bilaterally, direct and consensual reflex. So that means if there is a problems over here, you'll have constriction only on the one side, and then the other side is not going to get constricted because there's something wrong with the Edinger-Westphal nuclei. Okay, so result is illumination of one eye normally. So if you shine light in here, you'll get constriction in both of them. Okay, so pupillary constriction in both of them. That's all you need to know for now. And Edinger-Westphal is responsible for that bilateral constriction. Relative afferent pupillary defect. It's also called Marcus-Gunn pupil, and you need to know about that. So before we go further, let me pull up a picture for it. Okay, so when there's no light, it's dilated. Normal response to light, it can get constricted, right, because of Edinger-Westphal. However, in a positive, what is this, RAP? D? Of right eye, there's no constriction happening, right? Pupil do not react to light. However, there is accommodation happening because it happens because of something else and not the same path of that. Okay, so also called Marcus-Gunn pupil, extent of pupillary constriction differs when light is shown in one eye at a time due to unilateral or asymmetric lesion of afferent limb of pupillary reflex. So basically what they're saying with this one is you have an eye pupil here. Okay, let's make that black. And then another one as well. What's going on? Right. So you have this, and then eye is shown in this eye, and then nothing happens, right? Because this one is not registering the stimuli. However, when it's shown in this eye, because it's unilateral, this one will constrict as well. Okay, so they both constrict when it's shown in this. Okay, so that's what it is. So extent of pupillary constriction differs when eye is shown in one eye at a time due to unilateral or asymmetric lesion of afferent afferent, that's the sensory one, limb of the pupillary reflex, for example retina or optic nerve. When light shines into a normal eye, constriction of the ipsilateral eye, direct reflex, and contralateral eye, the consensual reflex is absorbed. When light is swung from a normal eye to an affected eye, both eyes dilate instead of constricting, right? Because when you shine it in this one that's affected, it's not going to register it, so it's going to dilate. And since it's not registering any stimuli, this one's going to dilate as well, because that one doesn't have the light coming in there either. Okay. So that's Marcus Gunn, pupil. How are you going to remember that? You put a gun to the to the eye, so it's not going to react. Okay. But the other one does, because that one's a coward. I don't know. Make up a story. I would probably react. I'm a coward when it comes to guns. Ocular motility. Superior rectus, lateral rectus, inferior rectus, medial rectus, trochlear. Trochlea is over there, and superior oblique over here. Okay. So you have superior rectus over here, medial rectus over here, lateral rectus, inferior rectus. Important one is to remember the obliques, because obliques are the only one that get confusing. Because not because of the position, but because of their action. Okay. So when this one constricts the superior oblique, the eye moves upwards. Okay. It doesn't move downwards. And then same thing with this, it moves towards this side, the inferior oblique, but not, upwards. Actually, wait, no, I think I got confused again. It moves, so if superior oblique is activated, it moves downwards actually. We'll see over here. Okay, so LR6 and SO4, right? So superior oblique is supplied by fourth nerve, the trochlear one, and LR6, that's lateral rectus, supplied by the sixth nerve, or the abducent nerve, right? So cranial nerve 6 innervates the lateral rectus, cranial nerve 4 innervates the superior oblique, and all the other ones are innervated by cranial nerve 3, oculomotor nerve. Okay. So these are the actions of all of these muscles. So for lateral rectus, it moves the eye laterally. Same thing with this, right? And it's because of LR6. Superior rectus, it moves upwards and outwards. Superior rectus moves upwards and outwards. Okay. Inferior rectus moves downwards and outwards. Inferior rectus moves downward and outwards. Medial rectus brings it inside. Now the superior oblique, although it's up there, its action is to move it inwards, downwards. Okay. Superior oblique moves it inwards, downwards, and inferior oblique moves it inwards, upwards. Okay. So yeah, that's what I meant, that this one, the action is different. So inferior oblique is down here outside, but it moves it inside and upwards. And whereas superior oblique is up here, but it moves it inwards and downwards. Okay. So obliques go opposite. Left SO and IO tested with patient looking right. Okay, so if you wanted to see if this one's still functioning, you would ask them to look right, towards the right. So that's how you check the left ones. And for left ones, you tell them to look left, and that's how you check the right ones. Okay. IO tested looking up. So inferior oblique is tested looking upwards and inwards. Okay. There's something called blowout fracture. It's orbital floor fracture, usually caused by direct trauma to eyeball and intraorbital rim. Increased risk of uh, inferior rectus muscle and or orbital fat entrapment. May lead to infraorbital nerve injury. Okay, so that it's a fracture in the orbital floor. You gotta know about that one. Uh, so increased risk of inferior rectus muscle and or orbital fat entrapment. So then inferior rectus is not going to be able to do these actions on one side of the eye, right? And then they'll ask you what's wrong. It's because they had a blowout fracture. May lead to infraorbital nerve injury. Right? Okay, so cranial nerves 3, 4, and 6 palsies. Uh, if cranial nerve 3 is damaged, then cranial nerve 3 has both motor, which is central, and parasympathetic components. Okay. Uh, Common causes include ischemia, so pupil sparing, motor fibers affected more than parasympathetic fibers. There's uncal herniation. Remember, that's the one that compresses it, so it can lead to coma. Posterior communicating aneurysm, so sudden onset headache. Okay, and it could be cavernous sinus thrombosis. You get propoptosis, involvement of cranial nerve 4, 5, and 6, and that's an important one. We'll do that over here. And midbrain stroke, contralateral hemiplegia. Okay, so they all lead to that. So motor and middle, and parasympathetic are peripheral ones. Okay. So motor, when you have motor problem with the motor part of this cranial nerve 3, it's gonna be the center that gets affected, and then if it's the peripheral part, it's this part. So for the central part, motor output to extraocular muscles affected primarily by the vascular disease, for example diabetes mellitus, glucose to sorbitol, due to decrease in diffusion of oxygen and nutrients to the interior middle fibers from compromised vasculature that resides on the outside of the nerve. Signs are ptosis, down and out gaze. Okay, so that's down and out gaze that you're seeing, I guess. Parasympathetic output fibers are the periphery are first affected by the compression. For example, because of the PCOM aneurysm or uncal herniation. Signs are diminished or absent pupillary reflex, so blown pupil, often with the down and out gaze. Okay. How do you remember these one? It's if they give you down and out gaze, remember that action is because of IR3, unopposed action of IO3 as well, right? So that means it's something to do with the 3 one, right? So you don't have cranial nerve 3 functional over there. So something's wrong with cranial nerve 3, and it's a cranial nerve 3 damage. Then they might tell you that the pupil is fine, but the constrictor muscles are not, or something like that, and then you figure out if it's middle or the peripheral part that's problematic. Okay, but normally they don't ask you that. They just ask you which nerve is damaged, and they give you a picture for it, or they'll explain the picture. Okay. So what would you see in a cranial nerve 4? The trochlear damage, right? Uh, Pupil is higher in the affected eye. Okay, so characteristic head tilt to contralateral affected side to compensate for lack of intorsion in the affected eye. Can't see the floor with cranial nerve 4 damage. For example, difficult going down the stairs or reading, and that's what they'll tell you, that the patient has fell down the stairs multiple times, or they have difficulty going down the stairs, or they can't read. So SO4, right? So that's this one. Okay, so when it can't do that, what's it gonna do? It can't oppose SR3, right? So SR3 is gonna overpower this movement, so it's gonna go that way. The eye is gonna go that way. So that's upwards and outwards, right? And that's the gaze you will see. So wait, you're seeing inwards and upwards, okay. Uh, Pupil is higher in the affected eye. Okay. So I guess this is the one. So it's inwards and upwards. My bad, not upwards and outwards. So I guess it's just this one that's not opposed. So inferior oblique is not opposed to superior oblique. So then inferior oblique is going to overpower and look inwards and upwards instead of downwards when you're asking them to look this way. Right? Because this one is normal, so it's looking laterally, but this one is going laterally and upwards. Okay. Because normally it balances out the two obliques, they get balanced out, so you get the normal lateral view. Okay. And if there's sixth nerve damage, the abducent one, abducent abducts. Okay, so affected eye unable to abduct and is displaced medially in primary position of gaze. Okay, so that's the lateral rectus, LR6 and SO4, right? So LR6, it looks laterally to the lateral rectus, right? So when this one's looking medially, that means this one's going to look laterally, but then it can't look laterally, and that's because of this. Okay, so this one is looking this way to the left, and this one can't look to the left because there's damage to that. So if the eye can't move laterally, it's because of LR6. If it can't look medially, it's because it's not that it can't look medially, but when you're trying to look medially, this one medially and this one laterally, right? But this one is going upwards. That means the two dominant muscles are the medial rectus and the inferior oblique. So something's wrong with the SO and SO4. So something's wrong with the fourth nerve. Okay. For this one, they'll explain that the medial part is not is affected or not affected. I don't remember the question, but you'll get it that it's a cranial nerve 3 damage. So if when it just pushes, right? So if it's a nerve, okay, so this is a nerve, okay. So when something pushes into it, what's gonna happen? This part is gonna get compressed, but this middle part is gonna stay same, right? So when this part gets compressed, it's gonna be this one, the periphery one, the parasympathetic output. So fibers of the periphery are first affected by compression, right? Because it could be because of PCOM aneurysm or uncal herniation. Okay, and that gives you the pupil blown pupil often. Okay, with down and out gaze. Okay, so that's a blown pupil. So they'll tell you that there's a difference between the two eyes and the difference between the diameter of the pupil. Okay, and they'll explain there's no head injury or anything happening. Okay, because that happens in head injury as well, but you don't get down and out gaze in head injury, so you gotta remember that. And for motor, it's affected primarily by vascular disease, so diabetes or something like that. Okay, so that's the only way something in the middle is going to get affected. It's because of diabetes mellitus. It's due to decreased diffusion of oxygen and nutrients to the interior or the middle fiber from compromised vasculature that resides on the outside of the nerve. Okay, so the outside of the nerve, the nutrients can't go all the way to the middle. It will only supply the outside. So then this one gets ischemic, I guess. Okay, and you get signs of ptosis and down and out gaze again. Okay, down and out gaze is for this. Okay, what else causes down and out? We heard that phrase in lens dislocation for homocystinuria, but that's lens dislocation, not the gaze. Okay, how much time? 8 minutes. Let's do this. Visual defect, visual field defect. So right anopia, so monocular loss. Okay. Okay. So if you have, a lesion right here cutting this off, uh, you won't have a vision in this eye at all. But this one's normal, so you'll have vision in that eye. Okay. Bitemporal hemianopia. So that's this thing right here. So it's in the name. So the temporal region are, hemianopias. That means loss, half of the loss, the temporal half of the eye has loss of visual field. Over there, it's in the name, right? This can happen because of pituitary lesion, right? Like adenoma, or because of the chiasm. Okay, something with that. So right there, you cut this off. So why is it temporal? Remember the fibers over here. The temporal fibers are going from here to here, right? And this one is the red. So the red vision is coming from this side of the eye, right? So this side of the eye will go to this side of the, well, this side of the lens, I guess, is going to this side of the retina or eye, and this side of the lens will go to the nasal side. So nasal side will then travel and cross. Okay. Similar with this, the nasal side travels and crosses. So if there's a vision, a lesion right there, what's it gonna do? The ones coming in over here, that's the nasal side. It's gonna be okay. So you'll see nasal view from here and here, but the temporal ones, because they're the temporal sides, you won't get vision from there or there if there's a lesion right here in the middle, and that's why you get bitemporal hemianopia. Make sense? Let me bring this over here. Okay. Then left homonymous hemianopia. Okay, so that's 3 over here. So that means the fibers that are coming, you just follow these lines, right? So the blue line is coming from here, so that's the nasal side. So nasal side from here, and this blue line that's here, so it's going to be the temporal side. So you won't see the temporal and from the left side and the nasal from the right side, right? So 3, that's both on the left side of the eyes, right? So that's why it's called left homonymous hemianopia. Then you have left upper quadrant tenopia. Okay. For these, you gotta remember which arteries are affected. That. Okay. So 4 is over here. We don't have anything for that, so let's put that away. Left upper quadrantopia. So that's just the upper part of the thing. So if it's upper, you won't see the lower one, right? Nope. You see the lower ones. Okay. You don't see the left upper quadrant. Okay, that's where the defect is. Not sure how to make sense of that, but just memorize that. Right temporal lesion. Okay, 3 minutes. What? Pie in the sky? Okay. Sure. But how does that make sense with this though? Oh, because you're cutting it like a pie. Okay, so pie in the sky. Got it. Right temporal lesion and middle cerebral artery uh, obstruction or lesion for that. Then left lower quadrantonepia. That's this thing. It's still on the left side, but down here. That happens because of a lesion over here, just half of it. So right parietal lesion and middle cerebral artery for that as well. Okay. Left hemianopia with macular sparing. Okay, so 6 is this, 3 is that, 6 if posterior cerebral artery infarct. Okay, so normally it's the left hemianopia, I guess. I don't know what they're saying with that. 3. But anyways, left hemianopia with macular sparing. It's right occipital lesion and this, right? So it's going to be that. Why? Because the third one is coming from the third nerve, right? That's the one that supplies the macula. So that's why there's a macular sparing with this. And then the 7th is central scotoma. That's in macular degeneration that we read about. Ventral optic radiation. That's the Mayer loop. Lower retina loops around inferior horn of lateral ventricle, and dorsal optic radiation. Superior retina takes shortest path via internal capsule. I would say the most important ones are these things where you need to know which artery causes problem with what part. Okay, so 3, 4, 4, 5, and 6. So middle cerebral artery will cause the high ones, and the PCA causes the macular sparing one. All right. What was it? When an image hits primary visual cortex, it is upside down, and left, right is reversed. Okay. Cavernous sinus. Cavernous sinus, collection of venous sinuses on either side of the pituitary. Blood from the eye and superficial cortex will drain to cavernous sinus, and that will drain into internal jugular vein. Okay. Remember what goes around jugular vein? It was. I don't think it's important here though. Okay. Cranial nerve 3, 4, 5. That's trigeminal ophthalmic branch, trigeminal maxillary branch, and abducent nerve, right? Plus the postganglionic parasympathetic pupillary fibers en route to orbit all pass through cavernous sinus. Okay, so all of these will go pass through the cavernous sinus. Okay. Cavernous portion of internal carotid artery is also here. Okay, cavernous sinus syndrome it presents with variable ophthalmoplasia. For example, cranial nerve 3 and 6. Decrease in corneal sensation, Horner syndrome, and occasional decreased maxillary sensation, secondary to pituitary tumor mass effect. Carotid cavernous fistula or cavernous sinus thrombosis related to infection spread due to lack of valves in dural venous sinuses. Okay, so let's look at this and then we'll give this another go. We have the third ventricle here that attaches to the fourth ventricle. So over there, it goes from there to that. Okay, this is the optic chiasm, or the second nerve is over there. This is the third, fourth, above the pons, right? And then these ones are in the pons, so fifth and sixth. Okay, so this artery and this is internal carotid artery. Okay, So it's important to know that when something happens with the internal carotid artery, for any reason there is a blockage somewhere here, so then there will be buildup of blood in these arteries, or even if these are dilated or something, it's going to affect the sixth nerve, right? And LR6, so lateral rectus, is something that will show symptoms, right? So you won't be able to see laterally in either one of them. There's the pituitary and the cilia turnica, right? This is a subarachnoid space, and between subarachnoid space and sphenoid sinus, you have the cavernous sinus. Okay, or the sphenoid bone, you have the cavernous sinus. There's the pia arachnoid and the dura over here. This is the anterior cerebral artery, and yeah. So usually it's this one that they talk about, right? The internal carotid, and something's happening with because of that. Nerve is gonna be affected. So which nerve is most likely to be affected because of this condition or whatever it is? It's gonna be the sixth nerve, right? But it could be any of these actually, right? Because this is gonna affect the cavernous sinus, increase the pressure here, and then that will affect these nerves passing through as well. The third, so optical oculomotor one, that's optic, and this is the trochlear and trigeminal. Let's read that again. So collection of venous sinuses on either side of pituitary. Okay, so either side of the pituitary. Blood from the eye and superficial cortex. Okay, will come to the cavernous sinus, and then from here it will go into the internal jugular vein. Cranial nerves 3, 4, 5, and 6, plus the postganglionic sympathetic pupillary fibers en route to orbit, all pass through cavernous sinus. Okay, so all of these things can get affected because of whatever's happening in there. Cavernous portion of the internal carotid artery is also here. Okay, cavernous sinus symptom presents with variable ophthalmoplegia. For example, cranial nerves 3 and 6. 3 supplies to all the muscles except for the lateral and superior oblique, right? SO4, so that's the fourth one, and LR6, so that's the sixth one. Decrease in corneal sensation and Horner syndrome, right? Because of the sympathetic pupillary fibers going through there as well, and occasional decreased maxillary sensation. Okay, maxillary sensation because of maxillary branch of the trigeminal nerve. Secondary to pituitary tumor mass effect. Okay, so it could be because this is enlarged, like adenoma or something, so that's gonna structurally create the whole mass of that is gonna affect the cavernous sinus as well. Okay, so secondary to pituitary tumor mass effect. Carotid cavernous fistula, if there's a fistula between these, so either of those are leaking into each other. Or cavernous sinus thrombosis related to an infection. So if this cannot get drained anymore, right? So then you would get thrombosis over there. Spread due to lack of valves in the dural venous sinus. And we already did the dural venous sinuses, right? They drain into subarachnoid space, into the thing, and then it goes from transverse to sigmoidal into the jugular vein. Remember, we did that up here. Let me just do a callback to that. Okay, so the durovenous sinuses over here, it goes from here to transverse to sigmoid into the jugular vein, right? So anywhere in here, and then you have cavernous sinus right here. Okay, so that's the cavernous sinus. Okay. This is the sphenoid, and this is the subophthalmic, inferior sagittal, and straight sinus over here. So That's this one drains into this as well. The jugular internal, it comes from there. Can't really see it, but anyways. Okay. Okay, and done with that. On to, yeah, so remember, sixth one is the closest one to the internal carotid. Internuclear ophthalmoplegia. So now we're going to talk about the MLF and PPR and all this stuff. So if this eye is looking to the left, how is this one looking to the left as well at the same time? Because this one's contracting, the left lateral rectus is being contracted, and how is medial rectus getting contracted as well? It's because the signals are coming from here to look to the left, so it's going to come into the paramedian pontine reticular formation, and this is going to send signal to the abducens nuclei, because sixth nerve is for the lateral rectus, right? So from this, it's gonna go to the lateral rectus of the left eye, and there's also another fiber or fascicula. It's called the medial longitudinal fasciculus that goes to the oculomotor, because that's the one that takes care of the medial rectus. It gets supplied by the third nerve, right? So it's gonna go to that nucleus. So it's because of this right MLF that you are able to look to the left with both eyes. Okay. So medial longitudinal fasciculus, pair of tracts that interconnect the sixth and the third nuclei. It coordinates both eyes to move in the same horizontal direction. Highly myelinated, must communicate quickly so eyes move at the same time. Okay, that's why they're highly myelinated. Because when they're highly myelinated, what happens? There's decrease in loss of ions, so increase in time decrease in time constant and increase in space constant, right? That's why it's faster. Okay, lesions may be unilateral or bilateral. Okay, it could be either one or both, and we did these in the patho, the first page of patho, right? So okay, we'll look at that after. Lesions may be unilateral, bilateral, latter, classically seen in multiple sclerosis when it's bilateral, okay, or stroke. Lesion in MLF, that means if there's a lesion here, this one's going to look to the left, but this one's not going to be able to look to the left. So what do you get? This one's looking, but this one's not. You get nystagmus in this one, okay. Yeah. Okay, so a conjugated horizontal gaze palsy. Lack of communication such that when the sixth nerve or nucleus activates ipsilateral lateral rectus, contralateral cranial nerve 3 nucleus does not stimulate medial rectus to contract. So abducting eye displaces nystagmus. Cranial nerve 6 overfires to stimulate cranial nerve 3. Okay, and that's the thing that causes nystagmus. It's because it's the brain is realizing that this connection is not happening, so this is going to overfire it to make this happen. However, because of the lesion, that's not going to happen. But what happens instead is that this one gets overcontracted, and when it's trying to it's gonna basically lead to nystagmus. Okay, so the convergence is normal in this, so that just means when you're trying to do a cross eye, so this looking this way and this looking this way, that will happen because that doesn't rely on this MLF. So MLFs in MS, when looking left, the left nucleus of cranial nerve 6 fires, which contracts the left lateral rectus and stimulates the contralateral nucleus of cranial nerve 3, while the right MLF contract the right medial rectus. Directional term. Okay, so for example, right INO and left INO refers to the eye that is unable to adduct. Okay, so if this one is affected, the right MLF, what would you call that, right? You would call that the right INO, okay, because it's the lesion in the right eye, or right MLF. So directional term, for example, right INO or left INO refers to the eye that is unable to adduct. Adduct is looking nasally. Okay, so INO, ipsilateral adduction failure, nystagmus in the opposite one. That may get confusing, so just remember like that. So now you have right INO, so right MLF. Right, so when you're trying to look to the left, you're gonna have problem. Okay, so this is right and this is left side. So when you're trying to look to the right, what's happening? You're looking this way, right? So this lateral rectus is fine for this one. So this is the lateral rectus for right eye, and the medial rectus for the left eye. So since there's no problem over here, it's gonna be able to do the right gaze. Okay, so this is the right on this side, and this is the left on this side. Okay. However, when you're trying to look to the left, so this is the left, you have a problem over here, right? So this is not able to look that way. The medial rectus is not going to be contracted because of a problem in the right MLF lesion. This is the left gaze, right? And the MLF is, or the sixth nuclei is gonna overfire, and that's gonna cause nystagmus of this, but no effect is gonna be seen on this side. Okay. However, convergence is normal. That's when this eye is looking this way and this eye is trying to look this way, right? So if you had an eye, so it's when you look here, and this one's gonna be like E, and a nose and a little mouth. So happy. He's looking to the left, and now here. Okay. And done. So that's it. It's here, and the pons. Remember, that's where the nuclei are. We did that. So that's important. Alright. On to pharmac. For pharmac and CNS, epilepsy therapies are the drugs for epilepsy. They're important. All of them get asked about a lot, so gotta do those. Okay. So benzo and phenobarbital. Let's go over this and then we'll look at those charts. Okay, so barbiturates: phenobarbital, pentobarbital, thiobarbital, pentyl, and secobarbital. The mechanism here is okay. So I'll give you the mnemonic first. It's Barb likes it longer, whereas Ben likes it more frequent. Okay. So Barb likes it longer and Ben likes it more frequent. This will make sense. So barbiturate mechanism is it facilitates GABA action by increasing duration, okay, of chloride channel opening. So increasing of chloride channel opening, so it keeps it open for a long time, right? So keeps it open longer. Thus decreasing neuron firing. So barbiturates increased duration, okay, and that's why Barb likes it longer. It's because of the duration. It increases the duration of channel opening. Clinical use is sedative for anxiety, seizures, insomnia, induction of anesthesia, and thiopental. And adverse effects are respiratory and cardiovascular depression, can be fatal, CNS depression can be exacerbated by alcohol use, dependence, and drug interactions. It induces cytochrome P450, that's important, and overdose treatment is supportive, assists respiration, and maintain BP, right? Because it causes respiratory depression. And yeah, it's contraindicated in porphyria. Whereas benzo, and these are your diazepams and lorazepam and all the PAMs. Okay. Mechanism is it facilitates GABA action by increasing the frequency of channel opening. Okay, so that's why Ben likes it more frequent, because it increases the frequency of channel opening. So you don't mess up the, mechanisms of these two. Benzodiazepines increase in frequency, decreases REM sleep, must have long half-lives, most have long half-lives and active metabolites. Exceptions are Adam, so alprazolam, triazolam, oxazepam, and midazolam, which are short-acting. So higher addictive potential. Okay. Clinical use is anxiety, panic disorder, spasticity, status epilepticus, so lorazepam, diazepam, and midazolam. Eclampsia, detoxification. For example, alcohol withdrawal, DTs, long-acting this and diazepam are preferred. Night terrors, sleepwalking, general anesthetics, amnesia, muscle relaxation, hypnotic insomnia, and all these can be used for those with liver disease who drink a lot. So those are lorazepam, oxazepam, and temazepam due to minimal first pass metabolism. Okay. Adverse effect is dependence, additive CNS depression effects with alcohol and barbiturates all bind the GABA receptor. Less risk of respiratory depression and coma than with barbiturates. Treat overdose with flumazenil, competitive antagonist at GABA benzodiazepine receptor. Can precipitate seizures by causing acute benzodiazepine withdrawal. Alright, so we did that. Let's look at this. So benzo is used for status epilepticus. Okay, remember that's the one with when the duration of the epilepsy is longer than 5 minutes. It could be, it happens for 1 minute and then there's like for 1 minute it doesn't happen, but there's no regaining of consciousness between them. So in total, if it's 5 minutes, it still counts as status epilepticus. Those are 2 points. So this is first line for acute. Okay. So benzo is first line for acute status epilepticus. Okay. Mechanism is increasing GABA action by doing what? Benz likes it more frequent, so it opens up chloride channels more frequently. Okay, its adverse effect is sedation, tolerance, dependence, respiratory depression. Note also for eclampsia seizures, first line in is magnesium sulfate. Okay, yeah, that's important because we give that in eclampsia and also in pre-eclampsia, magnesium sulfate. Okay, for benzo and barbs, they usually just ask about mechanism. That's the most important thing that you will be tested on. Okay, and we did benzo, and where's barbiturate? Right there. Okay, so increases GABA action. Also, this is used in status epilepticus as well. It's also used in tonic-clonic and partial focal. Okay. Another thing about we'll do it other way as well, but let's finish this. So again, similar side effects: sedation, tolerance, dependence, induction of cytochrome P450, cardiorespiratory depression. Okay, it's important to remember barbiturates are the ones that induce cytochrome P450. First line in neonatal phenobarbital. Okay. All right. So let's do these. Partial focus. So hold on. Status epilepticus. There are only 3 drugs, and we did 2 of them. Okay, so this and this, and there's also phenytoin and phosphenytoin. So let's do that one. Okay, so mechanism of action is it blocks Na channel and zero order kinetic. Okay, so that means it gets eliminated in a straight line on a chart, right? So constantly, it doesn't depend on the step 1. So phenytoin, the most important thing I have to know about these are its side effect. That's what they test you on for phenytoin. So phenytoin side effects are cytochrome P450 induction, pseudolymphoma, hirsutism, enlarged gums, nystagmus, yellow-brown skin. So in a question stem, they'll give you that this person was given a drug and then they started seeing these things. So what drug can it be? Right. So hirsutism, enlarged gums, nystagmus, yellow-brown skin, teratogenicity, fetal head and toe end syndrome. So yellow-brown skin is important. Osteopenia, inhibited folate absorption, and neuropathy. Rare is SGS and Dress syndrome, drug-induced lupus, and toxicity leads to diplopia and ataxia and sedation. Cool. So with that, so status epilepticus, we give 3 drugs, right? We give benzo, we give barbs, and we give phenytoin. So we're done with status epilepticus. For partial focus, we can give everything except for benzos and ethosuximide. Okay, and carbamazepine is the primary one. Okay, so we can give everything for focal except for benzos and ethosuximide. Benzo we already did. Why not ethosuximide? It blocks thalamic T-type calcium channel. Okay. Right. Okay. So EFGHIJ. Ethosuximide causes fatigue, GI distress, headache, itching, and urticaria. SGS can happen because of this. Okay. So sucks to have silent absence seizure. Because it's only given in, it's the first line in absence. And ethosuximide, you can only give it in absence, nothing else. Okay. Similarly, benzo is only given in status epilepticus and nothing else. Okay, so ethosuximide sucks to have silent or absent seizures or silent seizures. SSS. Cool. So carbamazepine is the primary one you give in focal. Okay, the primary or first line. Common use. Okay. It blocks the sodium channel, so it prevents depolarization, right? Adverse effects are diplopia, ataxia, blood criasis, agranulocytosis, aplastic anemia, liver toxicity, teratogenesis, cleft lip, palate, spina bifida, induction of cytochrome P450, and SIAD and SGS. First line for trigeminal neuralgia. That's an important thing to remember. Okay, so carbamazepine. So we did that, and you can give all the rest of them in that. Also with this, so there are 2 that are only meant for partial focal. other than this carbamazepine. So there are three actually. So this was one. Then you have gabapentin. Okay, and it's in the name GABA. So primarily inhibits high voltage activated calcium channel, designed as GABA analog. Okay, so it's like a GABA, and GABA is inhibitory, so it inhibits activated calcium channels. Okay, and it's meant for partial focal, just like carbamazepine is meant for partial focal, and actually this as well, but when we are speaking about epilepsy. So gabapentin, that it causes sedation and ataxia. It's also used for peripheral neuropathy and post-herpetic neuralgia as well. Okay, and then this one, vigabatrin. That's also, GABA's in the name, so it increases GABA. It's still, that one is also like GABA. This is also like GABA. Okay, so it increases GABA, irreversible GABA transaminase inhibitor. Permanent visual loss, black box warning. So you get a black box warning in the thing on this drug. Vision loss with GABA transaminase inhibitor. So there's VI for vision and GABA because it's a GABA transaminase inhibitor. It increases aminase, so that's something that cleaves. So transaminase, I'm guessing it's something that breaks down GABA. Right, so now this is a transaminase inhibitor, so it's not going to break down the GABA, so you have increased GABA in your thing and it causes visual loss. Okay, so now that we're done with those three, we did vigabatrin, gabapentin, and carbamazepine for these, right? Which ones are not given? Only two. It's ethosuximide and benzodiazepine you can't give. Okay. And the other ones that you can give are all of these, right? We'll do those for these as well. So before we do tonic clonic, remember tonic is contraction, clonic is jerks. So you get contraction and jerks in these, whereas in partial focus is focal. So wherever the epilepsy is happening or seizures are happening because of something else, particular, you'll see symptoms in those parts of the brain that they get attached to. So like you'll see movement of your jaw, or like one hand is going to be moving or one leg is moving, something like that. Okay, so we'll do absence first because absence only has 1, 2, and 3 drugs that we can give. Absence, you give first line is ethosuximide, and we already did that. Right. Second is lamotrigine. So ethosuximide, it sucks to have silent seizures. It blocks thalamic T-type calcium channels. Okay, so remember that for that. Next one is lamotrigine. Okay, so it blocks voltage-gated sodium channel. It inhibits the release of glutamate, right? So what does this do? If you block sodium channel, you won't get depolarization. If you don't get depolarization, neurotransmitters won't get released. Okay, so it blocks or inhibits the release of glutamate. Okay, so lamotrigine, you can give it in all three of them. So partial or tonic-clonic or absence, because it's has a similar mechanism for all of them, and it's beneficial for that. However, it does cause SGS, so it must be titrated slowly. Hemophagocytic lymphohistiocytosis and black box warning. Okay. What is this? Let's look up on it. With an aggressive and life-threatening syndrome of excessive immune activation. Okay. It most frequently affects infants and preteens. Enlargement of your liver, swollen lymph nodes, skin rashes, this and this. Okay. nothing to see. Okay, skin, liver enlargement there. So hemophagocytic lymphohistiocytosis, it's pretty lame. Lymphocytosis, histiocytosis, so it's L for that. And I'm guessing that's a important side effect for this. Okay, so you can give it in, everything except for status epilepticus. And then another drug that you can give is valproate. Valproate is, first line for tonic-clonic, but you can give it in this as well. The mechanism of action is increase in sodium channel inactivation, increase in GABA concentration by inhibiting GABA transaminase. Okay. So again, you're blocking the breakdown of it. So valproate and vigabatrin, it has a similar mechanism of action. However, it also causes increase in sodium channel inactivation. Right. So it's sort of like this one actually. Topiramate. Okay, so valproate, again, side effects are important for valproate. You get vomiting, alopecia, liver damage, hepatotoxicity, pancreatitis, cytochrome P450 inhibition, rash, obesity, weight gain, tremor, teratogenesis, so neurotube defect, and that's the important one, and epigastric pain or GI distress. Also used for myoclonic seizures, bipolar disorder, and migraine prophylaxis. So just like lamotrigine, you can give this one for all of them as well. And just like lamotrigine, it blocks the sodium channel, inactivates it, and this one also inactivates that, right? This one inhibits the release of glutamate. This one increases the GABA concentration. Okay, so valproate, you can give it in everything except for status epilepticus. So done with that. Now, for tonic-clonic, there are only 5 drugs you can give, right? Wait, 1, 2, 3, 4, and 5. And we did valproate. Out of those drugs, we did phenobarbital. That was GABA one, right? Barbiturate. We did lamotrigine as well. So only one that's left are 2 of these. So levetiracetam and topiramate. Levetiracetam, okay. You can give it in both the partial focal or tonic-clonic. SV2A is receptor blocker, may modulate GABA and glutamate release. Okay. So modulates the GABA, that's the inhibitory one, and this is the excitatory one. So it modulates it. It inhibits voltage-gated calcium channel. Okay, so it tires it out basically. It tires out the calcium channel, C for calcium, I guess. Okay, so leave the calcium out of it. Okay, so SV2A receptor blocker may modulate GABA and glutamate release, so it gets tired out, and then you leave the calcium out of it, so inhibits voltage gated calcium channels. Neuropsychiatric symptoms, for example, personality change, so adverse effect, fatigue, drowsiness, and headache. Okay, and topiramate is similar to valproate. It has 8 in it, so it blocks sodium channel and it increases GABA action. Side effects are sedation, slow cognition, kidney stones, that's an important one for this, skinny, weight loss, sight threatened or glaucoma, speech and word finding difficulties. Okay. So that's an aphasia. Also used for migraine prophylaxis. That's important as well, just like these two. The trigeminal neuralgia and eclampsia for that. Okay. Topiramate. So done with all of them. So again, for status epilepticus, we give 3. That's benzodiazepine, phenobarbiturate, and phenytoin, right? Um, then we give in partial everything except for benzo and ethosuxamide. Okay, so everything except for those two. So we give carbamazepine, gabapentin, lamotrigine, levetiracetam, phenobarbital, phenytoin, topiramate, valproate, and vigabatrin. For absence, we give ethosuxamide. That's the first line because it sucks to have silent seizures. Okay, we give lamotrigine, and we give valproate. So valproate, lamotrigine, and ethosuxamide. So LVE. Uh, that doesn't make anything. It's well can be something. You can make up a mnemonic there for that. And then for tonic-clonic, we give lamotrigine, levetiracetam, phenobarbital, and topiramate and valproate. So topiramate and valproate are similar in action, whereas valproate and vigabatrin are half similar in action. Know their mechanisms and important side effects. They won't be tested for all of them, but for the ones that stand out. Moving on to epilepsy therapy. So here we saw sodium channel blockers. So they just gave you all of them over here. So carbamazepine, phosphenitoin, lamotrigine, and phenytoin, topiramate, and valproate. So if I was to ask you which one would you give for what, you should be able to tell me that, right? So let's see if I can do it. Carbamazepine, that was for uh, the partial focus one, right? Phos was also there. No, this was status epilepticus that I saw, and partial focus, I think. Lamotrigine is for all three except for status. Phenytoin was for status and absence. Was it? Let's see, status. Not absence. Sorry, partial. Right. Valproate for all three as well. As topiramate was only for two. Okay, first two. All right. So they block sodium channels, right? So block sodium channel, block sodium channel, block sodium channel, block sodium channel, and this one also block sodium channel. Cool. So when this blocks, action potential comes in to cause depolarization. So depolarization is not going to happen because there's no sodium coming in, right? So after it gets depolarized, it can cause glutamate vesicle release, the neurotransmitters. So release of it can be inhibited by this, leave calcium out of it, right? So it inhibits the release of calcium. Okay, over here we have calcium channel blockers, the ethosuxamide and gabapentin. So this one's given in silent seizures. Gabapentin, it causes increase in GABA, right? And it's given in what was it? Just a partial one. So GABA P for partial. That's it. Okay. So again, you won't get release of that. So in normally it would get released and then it would attach to the channels over here, and then that will cause influx of sodium and calcium in the postsynapses. Okay, the MPUS receptor and NMDA receptor over here. So when sodium comes in or calcium comes in, causing depolarization, this gets inhibited by this GABA receptor. GABA receptor that brings in the chloride, right? So chloride's gonna do what? It's gonna increase the chloride ions in here, so that will, make the polarity of the nerve more negative, because you need polarity to be positive for depolarization to happen, right? So that's why you have positive ions coming in and causing depolarization. So when you increase the negative ions here, it's going to take a lot more of these, right? So basically what you're doing is you're stopping the depolarization, and that's how depolarization stops. So we know which one's affected by uh, which one affects the chloride ion or channels, right? Benzos and barbiturates. So we read about those, and then you also have topiramate, that's like valproate, so it blocks sodium uh, channel, and it does what? Increases GABA action. Okay, so GABA action, so more calcium's gonna come in now. Okay, so that's GABA agonists. These are your GABA agonists. Okay, benzodiazepine, you give it in only one, and that's status epilepticus. And phenobarbital, we did that, it's given in everything except for silent seizures. Okay, and topiramate is only first two, the tonic-clonic and partial, because partial for P for partial, and topiramate. Okay, then you have GABA. So glutamate with GAD will become a GABA. They will be then taken up in the vesicles. Okay, and then they get released. Over here we have GABA reuptake happening here. So this is going to be an inhibitor, which is tiagabine. We don't have that here, do we? No. So that's a GABA reuptake inhibitor. Okay, so you won't get GABA. If you don't get GABA, you won't have GABA transaminase, which breaks down GABA to make succinic semi-aldehyde. Right? So this inhibitor, we have something for that: valproate and vigabatrin. Right. So valproate is in the first three, and vigabatrin is only for partial. Okay. And moving on to this, we did this already. Barb likes it longer, and Ben likes it more frequent. Okay. Okay. That took some time. Anyways, insomnia therapy, agent, mechanism, adverse effects, and notes. Non-benzodiazepine hypnotics. Okay, so these are the ones with the Z in it. You don't need to know how they're spelled or how they look, as long as you see Z in the names. So that's ES and then Z, or Zelplone or Zelpidem, doesn't matter. They all have the same mechanism. They activate. It acts via the uh, benzodiazepine subtype of, I don't know, BZ1. I don't know what that is. I'm guessing it's benzodiazepine, but anyways, it acts a subtype of this GABA receptor. Okay, so they're used to make you fall asleep. Okay, so ZZZ is these Z's put you to sleep. Adverse effect is ataxia, headache, confusion. Confusion causes only modest day after psychomotor, depression, and few amnestic effects versus old sedative hypnotics. Okay, so normally we would give benzodiazepines, but there are ones that are also non-benzodiazepine, right? Because that one also acts on anxiety. So what if you don't have anxiety? It's just you can't sleep, so you would give this. Okay. So these Z's put you to sleep. Short duration due to rapid metabolism by liver enzymes. Effects reversed by flumazenil. So that's important. Decreased dependency risk and decrease in sleep cycle disturbance versus benzodiazepine hypnotics. Okay. Then you have suvorexant. That's orexin one. That's important. It's a hypocretin receptor antagonist. Okay. This one we came across this somewhere else too. Let me see where. Oh, okay. We haven't read it yet. It will come in Psyche. Okay, so orexin, hypocretin receptor antagonist. Uh, okay, so it adverse effects are CNS depression, somnolence, headache, abnormal sleep-related activities. Contraindications are narcolepsy, combination with strong CYP3A4 inhibitor, cytochrome P450 or whatever. It's similar to that. Not recommended in patients with liver disease, limited risk of dependency. Okay. So it's a blocker for that. It's in the name, right? It's okay. And then we have rameltation. It has mel in it, so that's for melatonin. Melatonin receptor agonist. So you know that's the one that influences the circadian rhythm and all that stuff, right? Or you do that, you get that when you have a normal circadian rhythm functioning. So when you go to sleep, you have melatonin release, right? So rameltation is melatonin receptor agonist, binds to MT1 and MT2 in suprachiasmatic nucleus or sun sensing nucleus. Adverse effect is dizziness, nausea, fatigue, and headache. No known risk of dependency. Okay, then you have triptans, that's sumatriptan. So mechanism is 5-HT1B1D agonists inhibit trigeminal nerve activation, prevent vasoactive peptide release, induce vasoconstriction. Okay, so this is an important one because we use this for acute migraine. Okay, so you want to go on a trip when you have a migraine. Clinical use, acute migraine. Cluster, so if you want to go to trip when you have migraine, acute migraine, you would take sumatriptan. Cluster headache attacks. Okay. Adverse effects, coronary vasospasm. So contraindicated in patient with coronary artery disease or vasospastic angina. Mild paresthesia, serotonin syndrome in combination with other 5-HT agonists. So as for serotonin syndrome, okay. Okay. Parkinson's disease therapy. The most effective treatment are non-ergodopamine agonists, which are usually started in younger patients, and levodopa with carbidopa, which is usually started in older patients. Deep brain stimulation of the subthalamic nucleus or GPI, the globus pallidus internus, may be helpful in advanced disease. Remember, this one is the one that produces GABA for thalamus, right? Or GPI does GABA for let me just go check with the basal ganglia. Okay, so yeah, so GPI makes GABA for thalamus. GPE is over here in the middle. Okay, so when dopamine comes in, remember dopamine acts independently to this. So D1 will go to the direct pathway. So direct pathway is the one where it will come in and activate, GPI. So when GPI is activated, uh, actually it will, sorry, wait, no. Let me read that. So SDN input via glutamate stimulates this and that. Okay, so dopamine comes in with S and C. Okay, so S and C is gonna stimulate striatum to block GPI. Okay, that makes sense. So dopamine or D1 is gonna come in. and stimulate S and C to stimulate the striatum, and then striatum is going to block GPI. So GPI will be inhibited from releasing GABA. So thalamus is disinhibited. Yeah, so then thalamus is disinhibited from this. Okay, let me see if we need to bring that back down there. So I'll just bring that. Okay. Right. So yeah, deep brain stimulation of the STN or GPI may be helpful in advanced disease. Okay. Dopamine agonists. So these are non-ergot or preferred. Pramipexole, ropipexole, ropinirole. Toxicity include nausea, impulse. We don't need that. What we need is this stuff. So let me bring that up here. Or actually, you know what? I have a better one here. Let's bring that. Okay. It's with mnemonics. So, anyways. Okay. So, pramipexole, ropinirole, and toxicity includes nausea, impulse control disorder. For example, gambling, partial hypotension, and hallucinations, confusions, sleepiness, and edema. Ergot, bromocriptine, rarely used due to toxicity. There's a because of this thing. There's a story about it. How there was a class action lawsuit against a casino because the guy who owned the casino knew about this side effect. So he would, he basically took advantage of this side effect. He would send free bus rides to and from the old age home. And he knew people with Alzheimer's were there. So first he would start sending free rides and give them free coins to gamble, and then they started getting hooked. So then he started earning from that, and then doctors started figuring this out, and then they did a class action lawsuit against that guy, and they won. Okay, so yeah, so mnemonic for that, it would be dope if uh bro could rope in Pam, right? So for this one, so pramipexole, that's Pam, non-ergot, ropinirole, so rope, non-ergot, and bromocriptine, that's ergot. What do? They act on the dopamine receptors and activate them, right? Okay, so the whole point is, the whole game is about dopamine. Okay. Okay, that's over that. So yeah, pramipexole, ropinirole, and bromocriptine. It would be dope if bro could rope in Pam, and they all act as the dopamine receptors. So there are dopamine agonists. Increase in dopamine availability. So this is amantadine. Okay, it increases dopamine release and decreases dopamine reuptake. Okay, so that's right here. Uh, DA reuptake inhibitor, amantadine, right? So dine or dean. D for dopamine. Uh, R for, where's R? There's no R. Inhibitor. Okay, dopamine reuptake. Oh, okay. So you dine at a drive-through. That's how it is. Okay. So dine at a drive-through. So D for DNA, DA, and D for that, and DR for reuptake and drive-through. I don't know, it should make sense. That amantadine is what it does is it increases dopamine release and decreases dopamine reuptake, so there's more dopamine in the synaptic cleft for a longer time. Okay, it's mainly used to reduce levodopa-induced dyskinesias. Okay, so toxicity will lead to peripheral edema, livedo reticularis, and ataxia. Okay, so what is this? It's a skin condition. It looks like, yeah, this stuff. Okay. So increase in L-DOPA availability. Okay, so for that we'll look at this one. Okay. Okay, so we have agents. So L-DOPA availability. Agents prevent peripheral pre-blood-brain barrier L-DOPA degradation. Okay, so over here. Okay. So then you have increased amount of L-DOPA entering CNS. Okay. So L-DOPA, because when you take it in, it's gonna be in the system, right? And just like there are ways to metabolize it in the brain, there are ways to metabolize in the system. So to prevent that, we give carbidopa. So to prevent L-DOPA breakdown into dopamine in the system, because we dopamine can't grow across the BBB, so we need it in L-DOPA form so it can cross it and then get it converted to dopamine. Okay. All right. So then, right. So L-DOPA entering the CNS, that will lead to increased central L-DOPA available for conversion to dopamine. We have levodopa, this is L-DOPA and carbidopa combination. So carbidopa blocks peripheral conversion of L-DOPA to dopamine by inhibiting the dopa decarboxylase. So carbidopa blocks dopa decarboxylase. Okay. It also reduces adverse effects of peripheral L-DOPA conversion into dopamine, like nausea and vomiting. And then you have entacapone and tolcapone. Okay, this one is so that you don't convert dopamine into 3-MT by COMT. So tolcapone and entacapone blocks the COMT, so you have dopamine for longer time in the system. Okay, so entacapone and tolcapone prevent peripheral L-DOPA degradation to 3-OMT methyl dopa. Okay, or 3-OMD, sorry, that should be M. Okay, by inhibiting COMT. It's used in conjunction with L-DOPA. So let's see what's given here. So tolcapone right here, dopamine to 3-MT and dopec. Okay, so there is 3-MT there. So it inhibits it over there. And then we have entacapone and tolcapone coming through the blood-brain barrier. So it prevents the conversion peripherally as well to this. And dopa decarboxylase inhibitor is this one. Okay. Okay. So then we have prevent dopamine breakdown. Okay, so so okay, these ones. Okay, Al Capone commits crime. Okay, so Al Capone, the mob boss, right? He commits crime. So commits, COMT is in the commit. So that's how you remember that one. Okay, Al Capone COMT inhibitor. And then you have MAO inhibitors, or it prevents the dopamine breakdown. Okay, so agents act centrally post a blood-brain barrier to inhibit breakdown of dopamine. So dopamine to dopac. Okay, so selegiline and resigline. So since these are MAO inhibitors, okay, so it blocks conversion of dopamine into dopac by selectively inhibiting MAO B. Okay, and that's what we saw over here. Dopac MAO B inhibits that, and it's selegiline and rasogiline. It has line in it, so for MAO you read it as mow, and mow the lawn in a line, right? So you mow the lawn in a line. So anything you see line, it's a MAO inhibitor or MO inhibitor. Okay, that's it for that. Okay. So breakdown dopamine prevents dopamine breakdown. Agents act centrally again to inhibit breakdown of dopamine, selegiline and rasogiline. It blocks conversion of dopamine into dopac by selectively inhibiting MAO B, which is more commonly found in brain than in the periphery. And then you have tolcapone, who no, that's Al Capone, or was it tolcapone? Which one did I say? Al Capone. Okay, right. So tolcapone, it crosses blood-brain barrier and blocks conversion of dopamine to 3-MT in the brain by inhibiting the central COMT. Right. So tolcapone, like Al Capone, is he commits crime as well. So commit is COMT. Okay. So tolcapone and encapone, they prevent that. Okay. COMT and encapone as well. Okay. Basically, they prevent peripheral conversions of that stuff. Okay, so tolcapone is inside central and encapone is on the outside. However, tolcapone is on inside and outside as well. So E for exit, I guess, or does not enter inside. Then you have curb access cholinergic activity. So benztropine trihexidiphenyl phenydyl. Okay. Antimuscarinic improves tremor and rigidity, but has little effect on bradykinesia in Parkinson's disease. So try parking my Mercedes Benz. Okay, so try and Benz for tremor and rigidity, but not for bradykinesia. Cool. Done with that. So MAO inhibitor, it prevents dopamine to dopac. Because and line, so you mow the lawn in line. Dopamine to 3-MT is blocked by tolcapone and ENT acting on the COMT. L-dopa to dopamine is decarboxylase, dopamine decarboxylase that converts it to dopamine, right? L-dopa right here, so DDC inhibition by carbidopa, okay, in the peripheral. Next, carbidopa and levodopa. So mechanism is increased dopamine in the brain. Unlike dopamine, L-dopa can cross blood-brain barrier and is converted by dopa decarboxylase in the CNS to dopamine. Carbidopa, a peripheral dopa decarboxylase inhibitor that cannot cross blood-brain barrier, is given with L-dopa to increase bioavailability of L-dopa in the brain and to limit peripheral adverse effects. Clinical use is Parkinson's disease. Adverse effects are nausea, hallucination, postural hypotension. With progressive disease, L-dopa can lead to on-off phenomenon with improved mobility during on periods, then impaired motor function during off periods when patient responds poorly to L-dopa on medication when it wears off. Okay, this is an important phenomenon, so understand that phenomenon better. Okay, neurodegenerative disease therapy. So for Alzheimer's, we give Don, Riva, and Gala. So Don took Riva to the Gala or whatever. Its mechanism is acetylcholinesterase inhibitor. So it inhibits the acetylcholinesterase, which breaks down the acetylcholine. So when you inhibit the thing that breaks down something, you have increase in that. So you have increase in acetylcholine. Yeah. Okay. So for Parkinson's, remember what happens, right? There's decrease in dopamine, but there's also increase in acetylcholine, right? So acetylcholine is the one that's responsible for the muscarinic effects. So that's why you give benztropine and trihexyl, which are muscarinic, right? So acetylcholine is a cholinergic or muscarinic effect. It causes muscarinic effects. Okay. On this side, yeah, there's nothing. Okay, so notes. First line treatment, adverse effects, nausea, dizziness, insomnia, contraindicated in patients with cardiac conduction abnormalities. So Donna River dances at the gala. Okay. I don't think they ask you about these as much. They don't ask you about the treatment of Alzheimer's. They mostly ask you how someone can get it and who can get Alzheimer's. So Down syndrome, because it's on the same chromosome as trisomy 21, so it's over there. And amyloid deposition or tau protein and senile plaques or whatever, the pink plaques or something like that happens there. So memantine, NMDA receptor antagonists, helps prevent excitotoxicity mediated by calcium. Used for moderate to advanced dementia, adverse effects are dizziness, confusion, and hallucinations. Just know about these drugs and their mechanism. ALS, Lou Gehrig's disease, so you give Lou, right? Riluzole. It decreases neuron glutamate excitotoxicity, so increases survival. Treat Lou Gehrig disease with Riluzole. Huntington's disease, tetrabenazine. That's what you would give. Okay. Treat Huntington with tetra. It inhibits vesicular monoamine transporter or VMAT, so you have decreased dopamine vesicle packaging and release. May be used for Huntington chorea and tardive dyskinesia. Okay. Anesthetics and general principle. These are important. They test you on the anesthetics. These ones as well. Okay. CNS drugs must be lipid soluble, crosses the blood-brain barrier, or be actively transported. Drugs with decreased solubility in blood equals to rapid induction and recovery times. Drugs with increased solubility in lipids is increase in potency. Okay. So when they have decreased solubility in blood, they'll their effect only lasts as long as they're in the blood, so they'll get filtered out pretty quickly. They won't stay in the tissues and stuff. Whereas something that's soluble in lipids, it will be found in lipids, right? So it gets deposited in fat cells and all that stuff. So it's harder to, clear them out of your system. So it increases potency for that. And here, it's rapid induction and recovery time. Okay, so MAC. This is minimum alveolar concentration of inhaled anesthetics required to prevent 50% of subjects from moving in response to noxious stimulus. For example, skin incision. Potency is equal to 1 over MAC. Okay, so when you want to increase potency, you would require this to be lower. If this is increased, that means potency is decreased. Okay, so when minimum alveolar concentration is decreased, that means you need lower concentration of it to cause its anesthetic effect, that means it's more potent. Make sense? So example, nitrous oxide has decreased blood and lipid solubility, and thus fast induction and low potency. Okay. Halothane has increased lipid and blood solubility, and thus high potency and slow induction. Okay, halothane. There are questions about someone who had surgery done in Mexico. They came back, and after a while, they realized they had problems. So when the doctor checked it out, it turned out that he has fulminant hepatitis. Right, it's because of halothane. Halothane causes fulminant hepatitis. Okay, so inhaled anesthetics. That's desflurane, halothane, and all of these main ones, and nitric oxide. Mechanism is unknown. Effects are myocardial depression, respiratory depression, post-operative nausea, vomiting, increase in cerebral blood flow, and ICP, decrease in cerebral metabolic demand. Adverse effects, it's hepatotoxic, right? So halothane. Nephrotoxic for methoxyflurane, proconvulsion, that's enflurane, and epileptogenic. Okay, so that is an epileptogenic. Expansion of trapped gas in body cavities, so nitric oxide for that. Malignant hyperthermia, rare life-threatening condition in which inhaled anesthetics and succinylcholine induce severe muscle contractions and hyperthermia. Susceptibility is often inherited as autosomal dominant with variable penetrance. Mutations in ryanodine receptor, so RY1, causes increase in calcium release from sarcoplasmic reticulum. Okay, we did that in Musk when we were doing the contraction and all that stuff, I think. Treatment is dantrolene, ryanodine receptor antagonist. Okay. Remember that one. So those were inhaled ones. Now on to intravenous anesthetics. So agents, mechanism, anesthesia, use, and notes. Thiopental. All of these are important. Know the mechanism and the notes on them. Thiopental, it facilitates GABA, okay, or it's a barbiturate, okay. Anesthesia. So why is it used? It causes anesthesia induction and short surgical procedures. Okay. Notice it decreases cerebral blood flow and high lipid solubility. Effect terminated by rapid redistribution into tissue and fat. Then you have midazolam. These facilitate GABA, and it's a benzodiazepine. Procedural sedation, for example, endoscopy and anesthesia induction. So, okay. It may cause severe post-operative respiratory depression. It decreases blood pressure and anterograde amnesia. Propofol, it potentiates GABA. Rapid anesthesia induction, short procedures, and ICU sedation. It may cause respiratory depression and decreases blood pressure. Okay. So P for potentiates GABA. Okay. And you have ketamine. This is an important one because this one's the one that doesn't have anything on GABA. It's NMDA receptor antagonist instead. Okay, so it's used for dissociative anesthesia, symptomatic. It increases cerebral blood flow and emergence reaction possible with disorientation, hallucination, and vivid dreams. So they'll give you that this person was, it came out of whatever he was in, and then he felt all of these symptoms. So which anesthetic was he given? Okay, so that one for sure. Okay, so local anesthetics. Esters are procaine, tetracaine, benzocaine, and chlorprocaine. If they don't involve cane in it, it's gonna be amides. Okay, so all the other ones are amides. So you have two I's in the name. Okay, so local anesthetics come and they go in and then they close these channels with the inactivation gate, right? And so the sodium's not gonna come in, so action potential is not gonna occur. So if action potential doesn't happen, then there won't be neurotransmitters going out. Okay, so the mechanism is it blocks neurotransmission by binding to the voltage gated sodium channels on the inner portion of the channel along nerve fibers, most effective in rapidly firing neurons. Tertiary amine local anesthetics penetrate membrane in uncharged form, then bind to ion channels as charged form. It can be given with vasoconstrictors, usually epinephrine, to enhance block duration of action by decreasing systemic absorption. In infected acidic tissue, alkaline anesthetics are charged and cannot penetrate membrane effectively, need more anesthetic. Order of loss is first the pain, then temperature, then touch, and then pressure. Clinical use, minor surgical procedures, spinal anesthesia. If allergic to esters, give amides. Adverse effects, CNS excitation, severe cardiovascular toxicity, so bupivacaine, hypertension, hypotension, arrhythmias, uh, cocaine, methemoglobinemia, and benzocaine, prilocaine as well. Okay, for that. Okay. This one's not as important, this whole topic, so I'll move on. Neuromuscular blocking drugs, muscles paralysis in surgery or mechanical ventilation. Selective for NM nicotinic receptors and neuromuscular junction, but not on autonomic and receptors, the nicotinic receptors. So these ones are important. They ask a lot about these. Not even this, they just ask a lot about this one because it's succinylcholine and you need to know everything about that. Okay, so depolarizing neuromuscular blocking drugs. Succinylcholine, it's a strong NM nicotinic receptor agonist. So it produces sustained depolarization and prevents muscle contraction. That you need to know the mechanism. It produces sustained depolarization and prevents muscle contraction. Right, because normally depolarization causes contraction, right? But this one produces sustained depolarization and it prevents muscle contraction. Okay, that's why it's important. So reversible of blockade. So in phase 1, it's prolonged depolarization, so there's no antidote for that. Just block potentiated by cholinesterase inhibitor. Okay, so when you give cholinesterase inhibitors, the block gets potentiated, so it increases that. The phase 1. Phase 2, however, it's repolarized but blocked. Okay, so NM nicotinic receptors are available but desensitized. May be reversed with cholinesterase inhibitors. Okay, so if it's phase 2, it can be reversed by giving cholinesterase inhibitor. So you need to remember that as well. Complication includes hypercalcemia, hyperkalemia, malignant hyperthermia, increased risk of prolonged muscle paralysis in patients with pseudocholinesterase deficiency. Okay. So this could be congenital or hereditary disease. You need to remember that. So once more, complications include hypercalcemia. They'll give you that. They'll give you hyperkalemia. They'll give you malignant hypothermia. Okay. So there'll be like this person was giving an anesthetic, and then after after procedure they did a test and ran a lab, and then they got hypercalcemia, hyperkalemia, and uh, the vital shows malignant hyperthermia. Why? So there's increased risk of prolonged muscle paralysis. Okay, so he couldn't come out of you know the paralysis that was caused by the anesthetic. So why is that? It's because in patients with it happens in patients with pseudocholinesterase deficiency. Okay. Non-depolarizing. So depolarizing neuromuscular blocking drug. It's in the name. They depolarize the muscle, and so then eventually it's gonna fatigue and then stop contraction. Okay, so that's why it's depolarizing. But what about the ones that don't cause depolarizing but are still causing the blockade? These are the atracurium, cistracurium, pancurium, onium, sorry, and rucuronium. Everything that has core in it. It's competitive NM-nicotinic receptor antagonist. So, yeah, that's it. Know about that. They both act on these, right? NM and NM. They don't act on the NN anyways, so it's easy to remember that way. So reversible blockade, Sugama Dex. Sugama Dex. Yeah, sugar my. That's what it sounds like, but anyway. Sugama Dex of cholinesterase inhibitor. For example, neostigmine and etrophonium. Anticholinergics like atropine or glycopyrrolate are given with cholinesterase inhibitors to prevent muscarinic effects like bradycardia. Cool. Know about these. Both of these are important, but this one's really important. Okay, so skeletal muscle relaxants. So baclofen, it has back in it, so it affects the back. Okay, so GABA receptor agonist in spinal cord. Okay, so GABA receptor agonist, so that's agonist for GABA, so inhibitory, right? And it's spinal cord in the back. Okay, clinical use is muscle spasticity, dystonia, and multiple sclerosis. It acts on the back, so spinal cord, may cause sedation. Okay, so it's used for these. Remember this one. This one's important as well. All of these. Cyclobenzaprine. Okay, that's not as important. Baclofen is important and dantrolene is important. Okay, so cyclobenzaprine. It acts with CNS mainly at brainstem. Muscle spasm. It acts centrally. Structurally related to TCAs, may cause anticholinergic adverse effects and sedation. Dantrolene. It prevents release of calcium from sarcoplasmic reticulum of skeletal muscle by inhibiting the ryanodine receptor. Clinical use is malignant hyperthermia, toxicity of inhaled anesthetic, and succinylcholine. Right, so we saw this over there. And neuroleptic malignant syndrome, toxicity of antipsychotics. So it's used for all these. It acts directly on the muscle. Okay, so dantrolene prevents release of calcium from this by inhibiting ryanodine receptor. Tizanidine, it's alpha 2 agonist and acts centrally. Okay, so there's A in it. It acts centrally. Muscle spasticity, multiple sclerosis, ELS, and cerebral palsy. So you can use this as well if you can't use baclofen. Opioid analgesics. Mechanism is acts right. So opioid analgesic, it acts as an agonist at the opioid receptor, so mu, beta endorphin, and delta enkephalin, and K for kappa for dynorphin to modulate synaptic transmission, close presynaptic calcium channels, open postsynaptic potassium channels, leads to decrease in synaptic transmission, inhibit release of acetylcholine, norepinephrine, 5-HT glutamate substance P. Okay, so it inhibits release of all of these. So you get, antiadrenergic and anticholinergic effects of that. Efficacy is full agonists are morphine, heroin, pyridine, long-acting methadone, codeine. Prodrug is activated by cytochrome P2D6, fentanyl. Partial agonists are buprenorphine, and mixed agonists and antagonists are nalbuphine, pentazocine, and butorphanol. Antagonists are naloxone, naltrexone, and methyl-naltrexone. These ones are important. Okay. Know the full agonists, know the partial ones, and the mixed ones are not that important. Mixed ones are not important. Know the partial and the antagonists and the full agonists. Clinical use: moderate to severe or refractory pain, diarrhea like loperamide or diphenoxylate. Okay, they act on mu as well. Acute pulmonary edema, maintenance program for opiate use disorder. So for methadone, buprenorphine. Okay, for that you can give methadone, buprenorphine, or with naloxone. Neonatal abstinence syndrome. This one's important. So for this, you give methadone or morphine, but methadone is what you would give, and if you can't give that, then morphine. Adverse effects: nausea, vomiting, pruritus, histamine release, opiate use disorder, refractory depression, constipation, sphincter of Oddi spasm, meiosis, all of this stuff that causes depression. Overall, you just need to know when you look at it that it's talking about opioid and not about something else. Like, you wouldn't see this when you drink coffee, right? So you can tell it's because of something like morphine and or heroin and not caffeine or cocaine or stuff like that. Okay, so tolerance does not develop to meiosis and constipation. Treat toxicity with naloxone and prevent relapse with naltrexone once detoxified. Okay, so I think you gotta be able to figure it out between this and alcohol, or like between this and benz or barbiturate, and all that stuff. It's pretty easy because we'll read about that in psychiatry, I guess, if it's not given here. Yeah. So yeah, treat toxicity with naloxone and prevent relapse with naltrexone. That's important. So once detoxified, is naltrexone, but toxicity is with naloxone. Okay, and tramadol, mechanism is very weak, opioid agonist, also inhibits the reuptake of norepinephrine and serotonin. Clinical use is chronic pain. Adverse effects are similar to opioids, decreases seizure and seizure threshold, and serotonin syndrome can happen because of this as well. Okay, so tramadol is a weak opioid agonist. It inhibits the reuptake of norepinephrine and serotonin. So you will have increased amount of norepinephrine and serotonin in your body or in the synaptic cleft. Okay. Mixed agonist and antagonist opioid analgesics. So drug mechanism, clinical use, and notes. Pentazocine and butorphanol. These aren't that important, but let's do it anyways. Kappa opioid receptor agonist and mu opioid receptor weak antagonist and partial agonist. Clinical use is analgesia for moderate to severe pain. Can cause opioid withdrawal symptoms if patient is also taken full opioid agonist due to competition of opioid receptors. Okay, so it blocks that. Okay. And it blocks this, so even if they're taking opioid, it's going to cause opioid withdrawal because of this. Okay, so analgesia for moderate to severe pain. Butorphanol, it's kappa opioid receptor agonist and mu opioid receptor partial agonist as well. So it's going to potentiate its effect with opioid. Severe pain, you use it for severe pain like migraine or labor. Causes less depression, respiratory depression than full opioid agonists. Use with full opioid agonists can precipitate withdrawal. Because this one's gonna, compete for that. So you still get the thing. So you won't get potential effect for that, okay? Not easily reversed by naloxone. Okay. Capsaicin, naturally found in hot peppers. Mechanism is excessive stimulation and desensitization of nociceptive fibers. It leads to decreased substance P release, which decreases pain. Okay. But don't hot pepper cause pain as well by itself? Okay. Clinical use, musculoskeletal and neuropathic pain. Musculoskeletal and neuropathic pain. Okay. Glaucoma therapy. Right. So decrease in IOP, intraocular pressure, via decreasing amount of aqueous humor. So inhibit synthesis or secretion and increase drainage. Right. So beta alpha and D. So bad humor may not be politically correct. PC. So BADPC. Okay. So beta blocker, timolol, betoxolol, and cartiolol, they decrease aqueous humor synthesis. No pupillary or vision changes. Alpha agonists are epinephrine for alpha 1, epiraclonidine, and brimonidine are alpha 2 agonists. Mechanism is decrease aqueous humor synthesis via vasoconstriction. Epinephrine, decrease in aqueous humor synthesis, so epiraclonidine or brimonidine, increase in outflow or aqueous humor via uveoscleral pathway. Okay, and adverse effect is mydriasis because of blockage of alpha. Because of stimulation of alpha 1. So do not use in closed angle glaucoma. Don't do that. So it's contraindicated. Alpha agonists are contraindicated in glaucoma. Closed angle glaucoma. Okay. Blurry vision, ocular hyperemia, foreign body sensation, ocular allergic reaction, ocular pruritus. Diuretics like acetazolamide, so decrease aqueous humor synthesis via inhibition of carbonic anhydrase, so no pupillary or vision changes because of that. Prostaglandins, bimetoprost, lantoprost, PGF2A. So it increases outflow of aqueous humor via decreasing resistance of flow through uveoscleral pathway. Remember we read about that in the picture. Darkens the color of iris, so browning of that. Eyelash growth as well, it increases it. Okay, then cholinomimetic. Okay, so direct are pilocarpine and carbachol. And so these ones are going to cause mydriasis. Right? No, they're going to cause meiosis. Okay. Cholinomimetics. So that's cholinergics. Cholinergics are alpha 1 and 2. Okay. So wait, cholinergics are which ones? Right, those are M1s. Okay, M3. Right, it says right there. So that one was causing mydriasis. Okay. Direct pilocarpine, carbachol, indirect physostigmine and ecotioplate. Fate. It increases outflow of aqueous humor by contraction of ciliary muscles and opening of trabecular meshwork. Use pilocarpine in acute angle closure glaucoma. So you can use it over there. You can't use this one, right? But you can use pilocarpine in acute angle closure. Very effective at opening meshwork into canal of Schlemm. Meiosis, contraction of pupillary sphincter muscles, and cyclospasm, contraction of ciliary muscles. Okay, and we're done with CNS.